Hello everyone, I've compiled a list of 200 questions that are very important for you to know by the time you finish NBME 29. Each of these compilation videos takes about 20 hours of work, and so if you find this helpful, I would really love it if you could just like and subscribe. If you want a guaranteed way to pass this exam, visit ivtutoring.net to get access to a tutor from Harvard Medical School. Let's dive into question 1. Here we have a 35-year-old man brought to the emergency department after collapsing after a multi-day wilderness survival challenge. Fun fact, that was my first merit badge as a Boy Scout, the wilderness survival one. He has not eaten in 4 days and reports dizziness and fatigue. Physical exam shows dry mucous membranes and mild orthostatic hypotension. His breath has a fainty, fruity odor. Blood glucose, 61. Bicarb, 20. Anion gap, 16. We got some positive ketones. Urine analysis is also positive for ketones. There's no glucose in the urine. Which of the following most directly contributes to the ketone body formation in this patient's current state? So 35-year-old man. He's got 4 days of starvation. What we need to know for this question is that the brain can run on fat in a way. During prolonged fasting, the body burns fat for fuel, but the brain cannot use fatty acids directly. Instead, your liver converts that fat into ketone bodies. So thank you, liver. And that reaction can take place because of the buildup of acetyl-CoA from fatty acid oxidation. But there's a catch. The TCA cycle slows down because oxaloacetate is diverted to make glucose. So all that acetyl-CoA right here piles up and gets shunted into ketogenesis. And so this patient, after days without food, shows the signs of fruity breath, low glucose, and positive ketones. This guy's body is running low on glucose because he's starved, or you'll see untreated type 1 diabetes. So it has to have another fuel source. And that's where the ketone bodies come in. If your body has no insulin, the body's like, oh my gosh, I'm starving. And then fat gets broken down, fatty acids go to the liver, and normally acetyl-CoA enters into the TCA, the Krebs cycle. But during fasting or diabetes, oxaloacetate is used for gluconeogenesis. And that means the TCA cycle is going to be slowing down. So the result is, oh my gosh, we got all this acetyl-CoA. It's just sitting around. And that's when the liver converts the extra acetyl-CoA into, wait for it, ketone bodies. So we got a dude, hasn't eaten, no glucose, no big deal, let's burn fat. Check it out, we just made acetyl-CoA. And normally that goes to the TCA cycle to make energy. But during fasting or diabetes, the body uses oxaloacetate to make sugar. And this is a process you guys know called gluconeogenesis. And so there's not enough oxaloacetate to go through the Krebs cycle. Uh-oh, indeed. And so all this extra acetyl-CoA has nowhere to go. So the liver turns it into ketone bodies. So why are these ones wrong? Impaired hepatic uptake of glucose. That's seen in type 1 diabetes, but not starvation. Ketogenesis is driven by acetyl-CoA availability. Decreased NADH to NAD plus ratio. Actually, the opposite would happen. Beta oxidation increases NADH. I want you to think of NAD plus like a sponge that just picks up electrons. I want you to think of NADH like the used version. It's full of electrons. And so this ratio, that is to say NADH to NAD plus, tells us how much electron carrying fuel is available for energy reactions in the cell. And during fat breakdown, also known as beta oxidation, it creates acetyl-CoA, NADH, and FADH too. And so this electron carrying fuel availability ratio is going to be elevated. You're making more of NADH. And high NADH to NAD plus ratio slows down the Krebs cycle. Because NADH tells the cells, hey guys, we got enough energy. Look at me, I'm full of electrons. And this causes acetyl-CoA to build up. Why? Because it can't enter into that TCA cycle as easily. And what happens, as we now know, to the extra acetyl-CoA? Well, it gets shunted over to make some more ketone bodies. How about inhibition of carnitine transport to the mitochondria? That would block fatty acid entry. There'd be less beta oxidation. So that's the opposite. And E, enhanced glycolysis. That would be suppressed in fasting. Hepatocytes prioritize gluconeogenesis over glycolysis. And in case that's confusing, glycolysis is the breaking down of glucose to pyruvate to make energy. It's what the body does when there's plenty of glucose available. But if you're fasting or you have type 1 diabetes, there's not enough glucose inside the cell. And so this solution, our body's solution for turning glucose into pyruvate to make energy, is not a good one anymore. And so the liver's like, oh my gosh, let's switch gears. Let's stop breaking down glucose, glycolysis, and we'll start making glucose. And that is known as gluconeogenesis. So for step 1, you need to know you are not you when you're hungry. Fed state, glycolysis is on. You're burning that glucose. It's off here and on here. If you're fed, insulin is high, and if not, insulin is low and glucagon is high because gluconeogenesis is on. So enhanced glycolysis in hepatocytes is incorrect because the liver isn't breaking down glucose. It's trying to make more. Are you ready for question number 2? A 70-year-old woman undergoes evaluation for chronic aspiration pneumonia. During neurologic testing, A cotton swab is used to gently stimulate the left side of her oropharynx, but no gag reflex is elicited. What's damaged is the glossopharyngeal nerve. That's the afferent limb of the gag reflex. So if you touch one side of the throat and there's no gag reflex, but the other side works fine, then what's missing is the afferent sensory limb. Afferent is for your senses. I like to remember this by thinking, wow, that affected me. I felt that. Sensory. And that's carried out by the glossopharyngeal nerve. So cranial nerve 9 detects the stimulus on the back of the throat and it passes it to medulla. And then the vagus nerve, which is cranial nerve 10, contracts the muscles, causing the gag. And if one side does not sense anything, but the muscles still work well when triggered from the other side, then it's an afferent problem. Cranial nerve 9, glossopharyngeal. Now there's a lot more you could see on test day, so let's explain some of these other things, the high-yield buzzy stuff. Anytime you have absent gag, you should think of glossopharyngeal and vagus. Afferent, efferent. If, for instance, this question were to ask about cranial nerve 10 being damaged, then the stimulus would be detected, but no motor response would happen. The glossopharyngeal does sensory from the pharynx and taste to the posterior 1/3 of the tongue. There's something called the jugular foramen syndrome. That's if you have a mass like a tumor, metastasis, or a schwannoma that compresses the area of the jugular foramen, then you can get the loss of the 9, 10, 11. 9 is loss of gag reflex, dysphagia. 10 would be hoarseness, palate drop, uvula deviation. 11 is a weak shoulder shrug. You'd have the SCM and the trap weakness. So if you see hoarseness, shoulder weakness, and a loss of gag reflex, it's a jugular foramen problem. Now there's also Wallenberg syndrome. That is caused by an occlusion of the posterior inferior cerebellar artery, stroking the lateral medulla. This affects the 9 and 10 nuclei, so you get a loss of the gag reflex, but it also affects the spinothalamic tract. You get a contralateral pain and temperature loss. You also get damage to the vestibular nuclei. Horner syndrome is super important. It's the triad of ipsilateral, so same side, signs of disruption to the sympathetic innervation to the face. Ptosis, meiosis, and hydrosis. Ptosis means the drooping eyelid. That's due to the loss of the superior tarsal muscle, which is sympathetically driven. Meiosis is the constricted pupils, and that's due to the loss of the pupillary dilator muscle, which is sympathetic. And then anhidrosis, that's the lack of sweating. So you have decreased sweat gland stimulation, and all those three are on the same side of the face. So it's a 3-neuron chain, and all this to say, if the location is the lung apex, then think of a Pancoast tumor, and that's ipsilateral Horner. If it's an internal carotid artery, then you think of dissection, and that's painful Horner syndrome. And a spinal cord trauma could be Brown-Séquard syndrome. It's like the hemisection. But yeah, basically know that ipsilateral means like the same side, and that's because the sympathetic fibers do not cross. They stay on the same side the whole way. So if you knock out the sympathetic chain on the right, then all symptoms will also show up on the right. Okay, just wanted to explain Horner syndrome, and I think this is a good illustration of the principle. Just review one part of a question, zoom out, get the whole picture, cover all the areas you're weak in. Ready for number 3? So here we have a 58-year-old man, history of hyperlipidemia, presented to the emergency department with a sudden onset nausea, chest tightness, dizziness. ECG shows ST elevation in these inferior leads. There's no crackles and clear jugular venous distension. Which of the following arteries is most likely occluded? Answer, right coronary. Now this is just a table you have to memorize. 2, 3, AVF, this is all right coronary artery. The lateral would be 1, V5, V6, AVL, that's the left lateral wall. V1 to V4 is covered by the LAD. The septal is V1, V2. That's also the LAD, but it's the septal branch. And the posterior is V7 to V9. But that's not on the 12 lead, right? That could be your RCA or the LCX. And there you see ST depressions in the V1 to V3, which is just the posterior. So here's our diagram. The inferior right here, lateral leads, inferior, lateral, septal, anterior. This is a cool mnemonic. 1, 2, F looks like inferior. This shows the magnitude and direction. In lead 1, there's the inferior, lateral, 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 septal, anterior. Last one, inferior, lateral, lateral, septal, anterior. Now I might be wondering, what's all this stuff I hear about ST elevations? Well, ST elevations mean, for step 1, that you have a transmural infarction. So ST segment increase shows there's a full thickness injury from the epicardium to the endocardium. And the reason why is that dead myocardial cells cannot repolarize. You have persistent depolarization, and so the baseline shifts down, and the ST segment looks elevated on the EKG. This is caused by an acute thrombotic occlusion of a coronary artery. And so you have complete blockage, and that means there's no blood flow. So it starts with ischemia, then it causes an injury, and then there's an infarct cascade. Now, if this question asked about like the anterior STE with hypotension, then you'd say, okay, it's anterior, 1 to 4, LAD. If they asked about ST depression, then it'd be the posterior MI. If it's a young Asian male, then it's Brugada, a mutation that causes dysfunctional sodium channels, and it leads to polymorphic ventricular tachycardia, kind of like torsades, but it's seen in young Asian males. At least that's how they'll ask about it on step 1. And that has a risk of sudden death, by the way. All right, question 4. We have a 55-year-old man with familial cholesterolemia. He started on new medication after he develops a statin-associated myalgias. Basically, he's got some aches and pains in his muscles and tendons. The drug works locally in the GI tract and is not absorbed systemically. Over time, the LDL levels decline, but he begins experiencing bloating and fat-soluble vitamin deficiencies. Which mechanism explains the lipid-lowering effect of the agent? Okay, so it's not statin, it's something else. And before we dive into the correct answer here, I think it's important to know the lay of the land. There's something called a very low density lipoprotein. That's the fat delivery truck that your liver sends out to deliver triglycerides. I mean, look at all those L's. You can tell that it's made by the liver. L, liver. It's metabolized into LDL, which is more cholesterol rich. The purpose is to deliver triglycerides to muscle, fat, and tissues. And this eventually turns into LDL, and that carries mostly cholesterol. And before we dive into the answer, you'd also need to know what LCAT is. Now, this is the high-density lipoprotein that makes cholesterol safe to carry. It makes HDL useful. It turns the trash cholesterol into packable cholesterol that HDL can return to the liver. So very nice of LCAT to do that for us. We're almost there. What about cholestyramine? Well, that's the bile acid resin. It binds the bile acids in the gut so that you can poop them out, and this forces the liver to make more cholesterol. So the effect is decreased cholesterol in the blood. So think of this as you're flushing out the bile, so the liver panics and uses more LDL cholesterol to make bile. And that means your LDL is going to drop because you're flushing it out and you need that stuff. You know, it's like tissues. Yes, they're useful if you're sick, but then they're used up and so you have less tissues in the box after you've been sick. All right, so this guy right here delivers dietary triglycerides to the body. It has tons of triglyceride. Very low density, that delivers the liver-made triglycerides. So it has some cholesterol, but lots of triglyceride. There's LDL, and LDL delivers cholesterol to the tissues. And this is mostly cholesterol. And there's HDL, and that picks up cholesterol from the tissues to the liver. So it has cholesterol esters. And then there's LCAT, and that makes cholesterol packable for the HDL. LCAT's such a nice guy to help out the HDL like that. So which mechanism explains the lipid-lowering effect of this agent? There's a fat-soluble vitamin deficiency, and that's due to the loss of bile. Okay, so that's the first clue. We also know this acts on the GI tract. It's not absorbed. So we're binding those bile acids, and then we're excreting them in the feces. And as we spoke of before, this causes the increased LDL receptor expression, so the liver is pulling more cholesterol from the blood. Why? Because the liver loses bile acids, and it must make more. So it makes up its own cholesterol stores. So the end result is going to be an upregulation of LDL receptors because this is a bile acid resin, cholestyramine. That's the drug. That's what we're introducing here. Acts at the binding site of bile acids, increasing their excretion. And so we compensate by making more LDL receptors. LCAT inhibition would disrupt the HDL maturation. But basically, we need to know this is bile acid resin, which binds bile acids in the gut, and it forces the liver to use its cholesterol stores to make more bile. So it lowers LDL by increasing LDL receptor expression. And the drug's non-absorbed gut-limited nature causes the GI effects and vitamin K deficiency, which explains things like prolonged PT, for instance, they could tell you about, or any of the A, D, E, K vitamin deficiencies, because that bile acid resin is gone. So the most important parts of this question are, we know bile acids are made from cholesterol in the liver. We know they're stored in the gallbladder, and they're released in the duodenum after a fatty meal. And their job is to emulsify fats, right? It helps you absorb dietary fats like A, D, E, K. Cholestyramine binds bile acids in the gut, prevents reabsorption in the terminal ileum, and you poop out bile acids instead of recycling them. So there's less bile in the gut, and the fat cannot be emulsified properly. And so you get poor absorption of vitamins like A, D, E, K, fat-soluble vitamin deficiencies. A, causes night blindness, dry skin. D, bone softening, rickets, osteomalacia, hypocalcemia. E, neuropathy, hemolytic anemia. It's an antioxidant. And K, bleeding time. Next practice question, 60-year-old woman undergoes routine follow-up after completing adjuvant therapy. That's like the secondary therapy for estrogen receptor-positive breast cancer. She's taking daily oral medication that has been shown to significantly reduce the risk of infection in women with hormone-sensitive tumors. She has not experienced hot flashes. Which of the following best describes the mechanism of action of the drug that she's taking? Try to hide the answer. Don't look. But what should immediately come to mind here is tamoxifen and raloxifene. These are selective estrogen receptor modulators. That's why when I was creating these questions for the first time, I wrote down SERM, because this is a selective estrogen receptor modulator question. And these guys are cool because they're agonists in some tissues and antagonists. So you should be thinking of two things. One, breast tissue, and two, the endometrium. One, in breast tissue, both are antagonists. So tamoxifen and raloxifene block estrogen receptors in the breast. So this is used in breast cancer prevention or treatment. And our goal is to stop the estrogen-driven tumor growth. Okay, so they both work on the breast tissue. However, the endometrium is different. Tamoxifen is an estrogen agonist in the endometrium. It increases the risk of endometrial hyperplasia. Raloxifene, however, is an antagonist in the endometrium, so there's no increased risk of endometrial cancer, and it's safer in postmenopausal women. And the way to remember this, the way that I like to remember this, is T stands for terrible. It's terrible because it can cause the endometrium problems. And then R is respectful because it does not cause those in the endometrium. I don't know. whatever worked, right? But they both are agonists for bone protection. So it's also used in osteoporosis prevention in postmenopausal women, and especially is favored here because of the lower cancer risk, right? So it's protective of the bone. And they do protect bone, but they cause clots to form. Remember, they're selective estrogen receptor modulators. And so they mimic estrogen in some tissues and block it in others. And so in the bone, estrogen is protective, right? And so the SERMs are mimicking that, lest we forget. Estrogen inhibits osteoclasts. It's like, guys, we got to prevent that bone reabsorption. And SERMs act as estrogen agonists at these bone receptors. And so tamoxifen and raloxifene increase bone mineral density. And so it's used for osteoporosis. Now, estrogen's all over the body, right? And in the liver, estrogen is a procoagulant. Estrogen increases the synthesis of clotting factors. I don't know if you knew that. Which ones? 2, 7, 9, 10. And both tamoxifen and raloxifene act as agonists. The result is increased clotting factor production, so you have an increased risk of DVT. Wild, huh? So the bone, estrogen agonist. Liver, estrogen agonist. Breast, estrogen antagonist. Right? So you decrease that cancer growth. Endometrium, tamoxifen is terrible. It's an agonist there. Increased cancer risk, but it's an antagonist there. It's respectful of the endometrium. Hopefully that made tons of sense. And that's why your answer is competitive blockade of estrogen receptor in the breast tissue. This is a SERM. That's what it does. You can look at these associations and these buzzwords. Feel free to pause, but we're going to be moving on, folks. I want this to be as efficient and high yield as possible. My goal is you guys are sitting at home like, oh my gosh, I can't study anymore. And then you found this YouTube channel. You're like, oh, sick. Let's get the popcorn going. Okay, question 6. We got a new nasal spray, baby. Seasonal allergic rhinitis. We got 200 adults randomly assigned to receive either the spray or the placebo. What's the answer? This is a randomized control trial. There's a lot of anxiety to pick something as simple as a control trial, which is like the backbone of all of science, randomized control, the gold standard. But the takeaway here on step 1 is pick what you're familiar with. They're testing high yield topics at the end of the day. If you keep picking things that you're familiar with and have confidence, then you're going to do well. Let's say they give you a weird one, case control. Well, for this one, I want you to think of the O-odds ratio. For example, here you'd compare patients with lung cancer versus without, and you check their prior smoking status. So you start with the outcome, another odd outcome. See, this is how I remember it, O for case control. Another one they can give you is a crossover study. That's where each subject gets both treatments, and then they're separated by a washout period. So each subject is essentially their own control. And so one group would get drug A and then drug B, and then the other group gets the reverse. That's crossover. I think of BoJack Horseman. Wow, is this a crossover episode? Only if we're both switching and reversing. That's the answer that I get BoJack in my mind as I study for step 1. Or rather, Mr. Peanut Butter. I digress. That's randomized control. Cross-sectional is a snapshot in time. It measures the exposure and outcomes simultaneously. And what they're always going to test you on for this one is the prevalence. And there's no temporality for this. So for an example, they could survey 5,000 people on smoking and the current lung function today in time. That's cross-sectional. Prospective cohort study starts with the exposure, and then you follow forward. In this one, you study risk factors. Risk factors for cohort. We assess the relative risk for a prospective cohort. That's the easiest way to remember this. Once I had that in my brain, these questions became super easy. All right, for the next question, whenever you see these images, you should think of monosodium urate. These are gout. For some reason, it looks like Star Wars. I don't know. But yeah, this is gout. You see it on test day, you just click it immediately. And here we have a 58-year-old man who's got acute pain and swelling of his right ankle that began overnight. He has a history of hypertension and chronic kidney disease. Examination shows erythematous, tender, and warm ankle joint with limited range of motion. Atherocentesis is performed. Synovial fluid has 25,000 or greater white blood cells and needle-shaped crystals that appear yellow. Okay, this is gout. The answer is C, but equally interesting are the buzzwords and associations for other answer choices. If they said needle-shaped negatively bifringent crystals, negative, needle negative, and gout is a negative condition, you do not want it. Pseudo-gout, a little bit more positive. I don't know, that's just the way I think about it. If they show enveloped or dumbbell-shaped, then it is going to be calcium oxalate, and that's often seen with ethylene glycol poisoning. If you see cholesterol clefts, then that's chronic inflammation, often rheumatoid effusions and atheromas. By the way, an atheroma, also known as an atheromatous plaque, is a buildup of fats and cholesterol and other substances in the inner layer of the artery. So calcium pyrophosphate, that's linked to aging, maybe hemochromatosis, hyperparathyroidism. These conditions cause inorganic pyrophosphate levels or calcium levels, and they promote the CPPD crystal formation. That's calcium pyrophosphate deposition disease. Calcium oxalate, that's seen with ethylene glycol poisoning, vitamin C overuse, or Crohn's disease. It's where you have fat malabsorption that increases the oxalate absorption. Our answer is sodium monourate, and that's just gout, right? It's associated with cell lysis, high purine turnover, tumor lysis syndrome, or alcohol use. And cholesterol is just going to be long-standing effusions with the rheumatoid arthritis due to the chronic synovial inflammation. So let's see what these explanations are. Classic gout. Negatively bifringent. Calcium pyrophosphate has the rhomboid-shaped. Kidney stones would be seen with calcium oxalate, not the joints. Cholesterol is found in lipid effusions. Hydroxyapatite would be calcific tendinitis. Now, the last thing they might test you on with this is oxalate is a normal byproduct of metabolism, right? From oxalate, vitamin C, and it's usually excreted in the urine after it binds to calcium in the gut. So it's got to find its friend calcium. And if oxalate levels are too high, or if calcium's not available, then it'll form insoluble calcium oxalate crystals in the renal tubules. And these crystals can obstruct the tubules, and it causes acute tubular necrosis or renal failure. And this is seen in antifreeze, ethylene glycol poisoning, right? Because it's metabolized by alcohol dehydrogenase, glycolate form, which then leads to oxalate. So anytime you increase oxalate or decrease calcium, you have to be worried about these guys, because this is going to be a metabolized oxalate, and you have excess oxalate load, and then you have crystal formation. In Crohn's disease, the fat binds calcium in the gut, so you have less calcium to bind the oxalate, right? The fat is taking care of the calcium in Crohn's. And so free oxalate is now absorbed in the colon instead of being excreted, and that leads to secondary hyperoxaluria, and you get kidney stones. So envelopes or dumbbell-shaped. Oh, and by the way, why is it high anion gap metabolic acidosis? That's because obviously ethylene glycol causes the formation of these acids. And these are organic acids, and so they donate. What do acids do? They donate, thinking back to organic chemistry in college, hydronium ions, and they lower the pH and they consume bicarbonate. So it increases the acid load. So you deplete bicarbonate, causing metabolic acidosis. And that's your like mud piles, right? Methanol, deformic acid, uremia, renal failure, diabetic ketoacidosis. I should probably write this down. Mud piles. Methanol, uremia, diabetic ketoacidosis, propylene glycol, bing bing, isoniazid and iron, lactic acidosis, ethylene glycol, and S stands for salicylate. That's your late phase. So yeah, watch out for hypocalcemia, crystals in the urine with calcium oxalate. You treat it with fomepizole or ethanol. Those are competitive inhibitors of alcohol dehydrogenase, and also bicarb for acidosis. And you can even do hemodialysis if it's super severe. So yeah, fomepizole is the antifreeze antidote. That's pretty much all you need to know about it on step 1. But basically it just blocks that first step. You're preventing the formation of the toxic metabolites. You're inhibiting alcohol dehydrogenase. All right, next we have a 13-year-old girl brought to the clinic for school physical. She's got concerns that she's significantly shorter than her classmates. She's always been the small size, and her mom didn't start menstruating until 16. In the 5th percentile, weight 30th, this is a late bloomer. And our condition causes a temporary delay in the skeletal growth. You have normal predicted adult height. It's just slow but consistent. Now, if the growth curve were to flatten, so like if it's not growing consistently, if it like flattens, then that's going to be an endocrine or a systemic illness. But if you have normal velocity but low percentile, then it could be familial short stature. So familial short stature, that's like normal velocity. Here we have delayed, so it's constitutional. Next question, we have a 24-year-old woman has a 5-day history of joint pain, blotchy rash over her upper limbs. She started treatment with a mouse-derived monoclonal antibody for severe aplastic anemia. She's got tender swollen wrists and knees, erythematous maculopapular lesions on her chest and forearms. Lab studies show leukocyte count of 7,800, ESR of 55, complement C3 of 68, which is low. What describes the mechanism? The answer is immune complex deposition. She's got serum sickness, which is type 3 hypersensitivity. It's 1 to 2 weeks after you have a foreign monoclonal antibody. We have fever, arthralgia, rash, low complement. Arthralgia is just pain at your joints, by the way. Here are the other answers and why they're wrong. Now, there's a mnemonic that you can know for these type of hypersensitivity reactions. Acid, because type 1 is allergy or anaphylactic. 2 is cytotoxic, that's antibody mediated. 3 is the immune complex. And then 4 is delayed, and that's T cell mediated. So the anaphylactic has IgE mediated activation of mast cells, and this requires a prior sensitization. So here you have histamines, leukoprostaglandins, and they cause vasodilation, bronchospasms, and the onset here is just minutes. So think like a bee sting, peanuts, shellfish, penicillin, allergic rhinitis, like hay fever, asthma, eczema, like atopic dermatitis, urticaria, which is hives, food allergies, things like that. Type 2 is a cytotoxic antibody-mediated reaction. And the mechanisms here are through IgG and IgM, and these bind to the antigens on cell surface, and they trigger complement activation, which is ITP. You could also have receptor-related problems like Graves' disease, myasthenia gravis, pemphigus vulgaris, that's the antidesmoglian. So pemphigus vulgaris is the antidesmoglian. Bullous pemphigoid is antihemidesmism. And those are all type 2. Then there's type 3, that's where you actually form the complexes. And these guys are IgG, the antigen antibody complexes that form in circulation, and they deposit in the tissues. So they activate your complement system, and that's why we had a low complement in this question. Attract the neutrophils, inflammation of tissue damage, and the onset is like days. So here's serum sickness, right? Antivenom, monoclonal antibody, penicillin. That's the stuff you think of. Another big one, too, is going to be lupus, the DNA, anti-DNA complexes that form post-streptococcal glomerulonephritis, polyiteritis nodosa, hypersensitivity pneumonitis, that's like farmer's lung. All these immune complex depositions, complement activation, low C3, neutrophils, fibrinoid necrosis, vasculated. These are all type 3 hypersensitivity reactions. Type 4 is the delayed cell-mediated type. That's where you have the CD4 Th1s or the CD8 cytotoxic T cells, and there are no antibodies involved. This is macrophage and cytokines that drive the inflammation. The onset is 48 to 72 hours. So here you think of like a skin test, tuberculosis skin test. Contact dermatitis, that's like poison ivy, nickel, latex even. Immune, you could also have some autoimmune problems like type 1 diabetes. That's your beta cell destruction by your CD8 positive T cells. Multiple sclerosis, that's where you have T cells against your myelin basic protein. Hashimoto thyroiditis, Guillain-Barré, celiac, and graft rejection. So like acute transplant, graft versus host disease. You have a delayed response that's T-cell mediated. There's macrophage activation, granulomas, no antibodies, and induration after 48 hours. So that's everything there is to know about type 1, 2, 3, and 4. And then you look at this one, you go, okay, we've got serum sickness. That's a type 3 immune complex. This is 1 to 2 weeks after the exposure of monoclonal antibodies. They have the mouse monoclonal antibody. And so you have low complements. This is definitely going to be activation. And so our answer is C. That's how you do it. All right, for question 10. Here we have a 55-year-old man with a 5-year history of rheumatoid arthritis, has worsening fatigue over the last 3 months. He denies blood loss, no change in diet, takes methotrexate and NSAIDs. Lab results show all of this good stuff. What's the cause of his anemia? The answer is increased hepcidin-mediated iron sequestration. This is anemia of chronic disease. This is also known as anemia of inflammation. Very common tested cause of normocytic, microcytic anemia, especially in hospitalized or chronically ill patients. So they're probably going to have like lupus. They're going to be on some corticosteroid, prednisone, for instance. And this is where you're trapped in the storage, right? You have anemia of inflammation. And what's interesting about this guy is that the iron is totally present. It's just like locked away. And interestingly, you have increased hepcidin from the liver, which inhibits ferroportin. Basically, iron is present, but you can't use it because hepcidin is a peptide hormone that's produced by the liver, especially during inflammation. This is triggered by IL-6. So inflammation time, right? And it binds hepcidin to ferroportin. And that binding triggers internalization and it degrades the ferroportin and it prevents the iron export into the plasma, serum iron, even though there's increased ferritin. And I like to think of TIBC as how much your body wants the iron. It doesn't because it has a lot of it, so it's low as well. And the MCV is normal to low. So ferroportin is the only known cellular iron exporter. And so hepcidin is the master iron regulator. So it's like the lock on the iron gate, right? You have inflammation and that locks and it tightens things. So imagine your dude right here. He's an enterocyte in the gut, right? He's just absorbing dietary iron and he sends the iron to the blood. Well, hepcidin, triggered by the IL-6 active inflammation, is like, hey, bud, stop that. And so hepcidin blocks that export. Or imagine you got another guy. He's a macrophage and he's like, ooh, I'm going to recycle iron from the senescent red blood cells. I'm going to release the iron. Well, hepcidin goes, let me take that. I'm going to trap that iron. And imagine our last dude is like hepatocyte. He's like, ooh, I'm going to store the iron. I'm going to regulate the plasma iron. And then hepcidin's like, nope, you're not going to release that, bud. So it's just like stopping things. It's binding to ferroportin and it's just halting things and it's being trapped. And so you're withholding iron from the pathogens, right? From an evolutionary standpoint, that's what we're doing because pathogens need iron too. And so your body's like, oh my gosh, I got all these pathogens. I'm not going to share my iron. But in chronic inflammation, right, this protective mechanism, which is awesome, thank you, evolution, is now maladaptive. And you have anemia, right? You need iron too. Oh man, the body's so funny. But yes, this is a hepcidin-mediated blockade of the iron release. All right, folks, that does it. We finished the first 10. I'm going to take a break, maybe do a couple curls with my calcium oxalate dumbbells. And I want you guys to stretch your legs, do something fun, treat yourself. You're going to do great things with your life. Just know you're going to get through this. You will get through this. It takes a little bit more time. Who cares? Life is long and short at the same time. Enjoy yourself. Like and sub if you like this channel. Hoping to give you guys high quality resources. We got a lot of things. Check out the link in the description if you want tutoring, kind of like what we did today, but more personalized to you, guaranteeing that you're going to get a pass on step 1. Click the links in the description. You can get an in-person tutor, and we're also launching some courses soon. Take care, y'all. We'll see you soon. Hello, everybody. I recorded 2 hours of footage, and it all was muted. So really quickly, I'm going to blitz through NBME 29, all original questions, everything you need to know. We're going to go from 23 all the way to 50. All right, let's dive into it. In this question, we have a 70-year-old man undergoing resection for stage 2 pancreatic cancer, enrolled in a long-term prospective trial tracking postoperative survival. The lab below shows the proportion of patients alive at the start of the year and how many survived through the following year. All right, and then it progresses through, and they're asking us, hey, what's the probability he'll survive through year 4? And the answer is literally just C. It's exactly this value. Now, what's interesting is this is a Kaplan-Meier survival curve, and this is a non-parametric statistical approach where you just analyze the time to event data, and it's used for survival analysis. Parametric would be like a t-test, ANOVA, linear regressions, right? You assume normality, linearity, all that stuff. Non-parametric is the Kaplan-Meier survival curve, like in this question. So really easy. Parametric just means you're fitting your data to a mold. Non-parametric is you're just letting the data decide the mold. And that in itself is even overkill. All you need to do is just kind of look at this little table and say, okay, year 4, it's here. Boom, boom. When you're dealing with biostats, I had somebody ask me, hey, can you do biostats questions? And I said, yes, soon. Biostats, don't overthink it. Just memorize the formulas and then have the confidence to be able to select the answers because they're usually pretty easy or they're formulaic. They don't expect you to do large calculations. That's biostats. Next. All right, in our next question, we have a 5-year-old girl brought to the clinic for swelling around her eyes and abdomen that developed over the past week. Her parents report she had mild upper respiratory infection 2 weeks ago, and someone updated the image to show like a young boy or young girl. You can see right there in the image. That's the demographic we're talking about. And on exam, we have periorbital edema, distended abdomen, shifting dullness, and normal blood pressure. Urine analysis shows 4+ protein with no hematuria. Serum creatinine is normal. Albumin is 1.6, cool. And this is the most important part, I think, reveals widespread effacement of podocytes foot process. This is minimal change disease. Now, the case breakdown here is definitely going to be you do not have blood in this disease. It's proteinuria, hypoalbuminemia. What does that mean? That's when you have low levels of albumin in the blood. And it causes the fluid to leak out of the blood vessels and accumulate in other body tissues. All right, so you're going to have like the swelling in the legs, the abdomen, the lungs. And this is usually because of like a liver disease or increased loss, like in kidney disease and even burns. And the treatment is really just focused on managing the root cause. So hypoalbuminemia is going to be minimal change disease. And on light microscopy, this is super, super important. It looks totally normal. If you see normal on light microscopy and you see effacement of the podocytes, click it, move on. That's super easy points on test day. And it responds super well to steroids. Alport syndrome, hearing loss is what you'd see with that, splitting of the GBM. Yeah, focal segmental glomerulosclerosis. This is going to be super common in Africa descendant HIV, but you would see segmental sclerosis, not minimal change, hence minimal change disease. Membranous nephropathy, that's another nephrotic syndrome, and it's thickened GBM. And also you have the subepithelial deposits in adults. So minimal change disease, really think of in the children. And IgA nephropathy is hematuria post-infection. All right, in our next question, we have a 42-year-old woman undergoing exploratory laparotomy. Laparotomy is an incision into the abdominal cavity in preparation for surgery. It's given under general anesthesia. During the procedure, she receives intravenous medication to facilitate relaxation. Breathing ceases despite preserved spontaneous phrenic nerve firing. Pupils are reactive and all that stuff. However, no thoracic abdominal excursions are noted. Which of the following drugs was administered? Bacuronium is the answer. So the setup in this question, and I'll zoom in to my notes when I did this the first time, is the airflow is stopping, right? And the diaphragm is not moving. And the phrenic activity is still continuing, right? So what does that mean? That means that the brain and the nerves are still firing. But the abdominal pressure, that stops changing. What does that mean? The muscles are not responding. So here's like the key logic. If the nerve signal is still firing, but the muscles don't move, then the block has to be at the neuromuscular junction, right? And that's postsynaptic. So that's exactly what a non-depolarizing neuromuscular blocker is going to do. And so, boom, there's our answer. We pick our non-polarizing neuromuscular blocker, and it competitively inhibits acetylcholine at the nicotinic receptors in the neuromuscular junction. So the phrenic is going, diaphragm can't contract. Succinylcholine would have initial fasciculations. It's a depolarizing blocker. So you'd have brief muscle activity before paralysis, not just cessation prior to motion. Propofol, that depresses the CNS. Nerve activity would be decreased with that one. Fentanyl, opioid, they said they didn't have opioid signals, right? Opioids, barbiturates, those guys would depress the CNS anyways, and so that would cause the phrenic nerve to go down. Halothane, it's a volatile anesthetic, causes CNS depression. They could give you other things, tetrodotoxin, lidocaine, right? Those guys will block the nerve or just like kill the heart, right? The phrenic nerve activity also would decrease or disappear. And then non-depolarizing blockers like tubocurine, coronium, those medications allow the nerve to still be active, but the muscle is paralyzed. Non-depolarizing blockers, right? And so just thinking about this practically, like your nerve is firing, acetylcholine is released into the neuromuscular junction. And then acetylcholine binds to the nicotinic acetylcholine receptors on the muscle end plate. And this opens the ion channels, and that lets the sodium go in, the potassium go out, and then that causes end plate depolarization. Depolarization spreads and the muscle contracts. Well, non-depolarizing blockers like tubocurine, rocuronium, bacuronium, those are competitive antagonists at these nicotinic acetylcholine receptors. And so the acetylcholine can't bind, and so there's no depolarization. And the muscle is then flaccid and paralyzed. So the nerve activity is still normal, right? The phrenic nerve is still firing, but there's no muscle contraction. And it's reversible with acetylcholinesterase inhibitors. So what's an example of how this is reversible? Neostigmine. So more acetylcholine would then flood the synapses and it'll outcompete the blocker. If you give them acetylcholinesterase inhibitors, it stops the breakdown, allows more of it so they can flood and outcompete this blocking stuff. All right. So yeah, succinylcholine is an acetylcholine receptor agonist, right? It binds and opens that channel. It causes persistent depolarization and the muscle can't repolarize. So it stays paralyzed. Those are depolarizing blockers like succinylcholine. Maybe another way, I don't want to like beat this dead horse, but like think of it like a lock and a key. Non-depolarizing, that's like a fake key jams the lock and the real key can't get in, right? So the door is going to stay shut, also known as paralysis. Depolarizing would be the real key gets stuck in the lock and it's just not going to be able to reset. There's no contraction. I don't know, maybe that's too simple of an example. Non-depolarizing, they sit right there. Antagonist, blocks acetylcholine, muscle never depolarizes, flaccid paralysis. And then the depolarizing blockers, those guys act like acetylcholine. They bind that receptor a little bit too strongly, and they cause big depolarization fasciculations and they stay stuck. So you can't reset them. So it's also paralysis. Depolarizing, non-depolarizing. All right, in this next question, here the demographic can change. I think in the previous practice question that I made when I recorded this the first time, it was a 75-year-old, hence the photo. In our practice question now, we have a 30-year-old preschool teacher presenting in the clinic in January, 2 days of fever, cold, fever, chills, headache, sore throat, body aches. Rapid antigen test confirms influenza A. She started on oseltamivir. The drug most likely prevents which step in the viral life cycle? All right, so the way that the virus works, the influenza life cycle, is the virus uses hemagglutinin to bind like acid on the epithelial cells, and that's how it gets inside. And it's inside the nucleus, then the viral RNA is replicated, and now the virus buds outside of the cell membrane. But first it's got to get in with hemagglutinin to bind the sialic acid on the epithelial cell. But yeah, eventually later on, new viruses, they bud out, but they're stuck on the host cell, right? They're still bound to that sialic acid. And so neuraminidase, and it cuts it and frees it. So if you give them neuraminidase inhibitors like oseltamivir, then it will block that step, blocks that step so they can't get out. Sialic acid can't be cut. The infection does not spread from cell to cell, and the symptoms are going to get shorter and the illness is less severe. So you're blocking the release of that virus from the epithelial cells. And so if we look at our question, our answer is indeed going to be the cleavage of the surface sialic acid residues. All right, there's our explanation. Neuraminidase cleaves sialic acid residues, freeing the budding virions. Oseltamivir inhibits that, trapping them inside, limiting the viral spread. Fusion is hemagglutinin mediated. Transcription of RNA's negative sense into mRNA is done by the viral RNA-dependent RNA polymerase. Assembly of nucleocaspid in the cytoplasm. Influenza replicates it. And translation of the viral polymerase proteins. Translation is host ribosome mediated and occurs before the budding. All right, now this one is actually super duper simple, so I don't want to harp on it too much. Broken hairs of varying lengths. Trichotillomania. Irregular patches of alopecia. Now this is often seen in obsessive compulsive disorders, repetitive tension relieving behavior. It's a female predominance, hence our demographic over here with our generated image, as comorbid with anxiety. And basically in this condition, we have physical stress and anxiety, repetitive hair pulling, tension relief. And so now how would this present in a question? Well, here we have a 12-year-old girl brought to the clinic due to patchy hair loss. And so you immediately know that it's going to be D. Irregular hair loss, broken hairs of different lengths, and also emotional distress, recent bullying, right? And this is an impulse control disorder. Now, why is not all these other answers? Fluvium has diffuse hair shedding. It's not going to be the patchy and broken. Androgenic, progressive thinning. Tinea capitis, scaly patches. The black dots, alopecia. Areata is smooth, circular patches. So really, it's just the nature of it. And that's why I wrote this when I recorded for the first time. Varying lengths. That's the huge deal there. Varying lengths. That's all you need to know for this one. All right, moving on to SGLT1s, 28. So now we're going to see this in a cute little baby. In this case, we have a 2-month-old girl evaluated for persistent watery diarrhea and poor weight gain. She's exclusively breastfed. Physical exam shows irritability in dry mucous membranes. Lab reveals metabolic acidosis. Stools demonstrate low pH. Oral glucose challenge is given. Serum glucose does not rise. But when you give fructose, diarrhea improves. What mechanism is deficient? The answer is indeed C. Sodium glucose co-transport in the enterocytes. So we got a little youngster, right? Breastfed. And so lactose, which is comprised of glucose, galactose, and you have watery acidic diarrhea and reducing substances in the stool. Why? Because the sugars are not being absorbed. And so oral glucose is not changing the sugar, so the glucose is not being absorbed, but the fructose is fine, and the fructose pathway is intact. That tells us that GLUT5 is working, because that's going to be our fructose pathway. GLUT5, all good to go. So the key physiology here is that there's glucose and galactose absorption via the SGLT1, right? And that is a sodium-dependent transport. And fructose absorption via the GLUT5 is independent of sodium, and so it's fine. So this is SGLT1 deficiency. You can't absorb glucose or galactose, and it causes diarrhea, dehydration, reducing sugars in the stool. But the fructose absorption, totally normal. Now another thing, SGLT1s, these are in the small intestine, in the muscle. Think about it, you have 4 muscly limbs, right? Especially if you're lifting your calcium oxalate dumbbells. Sucrase deficiency shows after introduction of solid foods. Cool? I think this baby is cool. Like and sub if you're doing peds. Peds is the best specialty out there. You guys deserve way more money. All right, next, our demographic has changed. It's going to be an elderly patient. In this question, we have, for instance, a 68-year-old man with a history of hyperlipidemia and mild exertional dyspnea that comes in for routine evaluation. He denies chest pain, palpitations, orthopnea. Physical exam, you detect a late peaking systolic murmur best heard of the right upper sternal border, radiating to the carotids. Carotid upstroke is delayed and diminished. Echocardiogram reveals concentric left ventricle hypertrophy and a heavily calcified aortic valve. What explains this pathology? The answer is a chronic mechanical injury from the valve function. Now, you need to be aware of something called a calcified aortic valve. In my other practice question, I had a 76-year-old male with calcification. And this is going to be seen with a systolic ejection murmur along the left sternal border. So in elderly patients, it's the repetitive kind of micro trauma that happens with opening and closing. And that leads to aortic stenosis, which produces a crescendo decrescendo systolic ejection murmur. And it's common in patients that are greater than 65, let's say, especially have no history of rheumatic fever or congenital bicuspid valve. So this is calcific aortic stenosis, age-related. It's just age. You get obstruction and left ventricle hypertrophy because of that stenosis. You got to pump harder. Post-rheumatic, that's when it's fused, commissures, or mitral involvement. Prior bacterial endocarditis would be regurgitation, not stenosis. Accelerated atherosclerosis would contribute to calcification, but this is just mechanical wear. Amyloid deposition would be restrictive cardiomyopathy. All right, here's our next demographic. Let's say middle-aged man, middle-aged woman. Not too important here. 41-year-old woman here presenting to the emergency department with a 2-day history of persistent right shoulder and upper abdominal pain. Recently lost 30 pounds over 4 months through a low-carb, high-protein crash diet. She's got some nausea, low-grade fever, 101.1 kLRC. Just kidding. Temperature. On exam, she winces and abruptly stops inspiration during palpation of the right upper quadrant. Labs reveal all this good stuff. What's the diagnosis? All right, so the big things that I see in this question, and I've written some notes over here before, is we have some rapid weight loss, right? So here we have losing a lot of pounds in a short amount of time. So that's like a risk of a gallstone. T ratio, right upper quadrant tenderness. That's what we're seeing here. There's no blood in the stool, right? So that means that it's not like a GI bleed. But that rapid weight loss increases the cholesterol stimulation to the bile. So like you get more of that cholesterol. And then you get obstructed cystic ducts, and that causes an inflamed gallbladder wall, leading to acute cholecystitis. So that's the right upper quadrant pain, leukocytosis, biliary lab stuff. And there are a couple of answers that you should always be thinking about with these types of questions. And one of them is acute pancreatitis, and that would have elevated amylase and lipase levels. It's super important to know those two lab values for acute pancreatitis. Small bowel obstruction. There's no signs of obstruction. That'd be like a prior surgery or distension. Hepatitis A would be recent travel, jaundice, malaise, all that stuff. And gastritis is NSAID use, alcohol. Gnawing epigastric pain would be gastritis. They could also say things like try to get you on GERD. GERD would be seen with a burning chest epigastric pain, not right upper quadrant pain. Burning epigastric, GERD, give them a proton pump inhibitor. You could also be seeing, or on test they might ask you about like a fatty liver, and that's usually just completely silent or even chronic. There's no leukocytosis or anything like that in the fatty liver. Or a peptic ulcer they could get you on, and that's pain, GI bleeds, a cold blood, and that's not going to be seen in this patient, right? The peptic ulcer would maybe cause some bleeding. So fat, female, fertile, 40. And if you wanted to, you could even add fat weight loss, right? That's an extra risk as well. All right, next we have a 64-year-old woman with advanced multiple sclerosis admitted to long-term care facility, recurrent hospitalizations of urinary tract infections, wheelchair bound, has difficulty moving her lower extremities. Physical exam, she's alert, minimally interactive. BMI is at 19. What's most effective in preventing skin breakdown? The things to look out for on test day for this condition is going to be paraplegia. So somebody is like immobile, usually, is how they'll ask this. They're admitted with a urinary tract infection, and you're trying to prevent the skin breakdown. So you should think of decubitus ulcers, right? That's skin breakdown from prolonged pressure on bony sites. Where are your bony sites? Well, it's like your elbows, right? Your scalp, your heel, your sacrum. So the mechanism is increased pressure. This is really interesting. Increased pressure causes a decreased blood flow. That causes ischemia, that causes tissue death, that causes ulcers. This question is really actually kind of a good one because you're trying to protect the ulcers. You don't want the ulcers to happen, but you have to recognize that this person is a long-term care facility, wheelchair bound. They're sitting on their butt all day, right? And they have a lot of pressure points at the bony sites. And so that bony pressure causes less blood flow, causes that ischemia, and that causes tissue death. So really a really good question here. And you need scheduled turning and repositioning. So the answer is C, you got to reposition. Just because of the low BMI does not mean high protein malnutrition. You should instead think about what the question's exactly asking. Topical antibiotics, that would treat the infection, not the ischemia. Barrier cream helps with moisture, but not preventing necrosis caused by ischemia. Antiseptic washes, nah, that would not prevent ischemic ulcers. And now this is actually really slept on. Like not a lot of people, no pun intended, I guess. But yeah, it's about over 2.5 million patients in the US develop pressure ulcers every single year, and many of them are entirely preventable, right? So if you guys are rounding on a physician someday, you should be like, hey, have you moved from that position in a while? Like, let's move you. Let's get the blood flowing. But maybe some other things they might try to get you on would be like arterial blood flow, and that'd be for like vascular disease ulcers, not pressure ones. They could also get you on nutritional stuff, right? That'll help the healing, but it's not going to stop the ulcers from forming. They could also get you on like bacterial skin flora stuff, right? That's bacteria that infects the ulcers after they form, but it's not the actual cause of it. Or like venous stenosis. And those are just different types of ulcers. So they're going to test you on different ulcer types. You just need to know that it's a pressure ulcer. All right, going to hide the answer here and move on to 32. 64-year-old man, 15-year-old history. So Different demographics here. Female could be as well, around the same age. But we got poorly controlled type 2 diabetes, chronic fatigue, bone aches. Look at that phosphate. It's high, should be 2 to 4-ish. So phosphate, then maybe there's a kidney. Oh yeah, look at that creatinine. Holy cow. Big old kidney problem, BUN. All right, so what's the abnormality thing going on here? Well, definitely we're having trouble because we have kidney problems, right? It seems like there's kidney problem that's causing secondary hyperparathyroidism. And so our answer is going to be C. Let's talk about this though. So in the other question I recorded, I had a 58-year-old female. In this question, we have a 64-year-old man. So the kidneys make vitamin D. And that's kind of crazy, right? Because it makes you think of like the calcium of it all. And that it's helpful because in renal failure, you have decreased vitamin D and decreased calcium absorption. So calcitriol being vitamin D is helpful. But yeah, it helps the gut absorb the calcium. That's the whole role of the vitamin D. That's one of the reasons why the kidney makes it. Phosphate is like the trash, you know, get it out of there. So in renal failure, you have decreased vitamin D. So that causes hypocalcemia because you don't have that calcitriol. So you can't absorb the calcium. And also the phosphate excretion decreases. So you have hyperphosphatemia, more of it. You're like, oh my gosh, too much of it, can't get rid of it. Hypocalcemia, hyperphosphatemia that stimulates the parathyroid gland, causing secondary hyperparathyroidism. And so on the labs, you'll see low calcium, high phosphates, high PTH. And now the question that I usually get, and I'll allow you guys to kind of see my beautiful face and my room. Check it out. By the way, I'm doing this because you guys told me that you'd prefer this over the green screen. Let me know if that's still the case, because the green screen's kind of fun, you know? But anyways, you might be wondering, okay, why does the PTH go up in chronic kidney disease? The kidneys normally help the calcium and the phosphate be balanced, right? So you convert the vitamin D, calcitriol, we talked about this. Well, in chronic kidney disease, we obviously don't have calcitriol. So the gut does not absorb as much calcium. And so there's hypocalcemia and there's no phosphate excretion. And what's kind of even worse is that this extra phosphate that's just like in our body is going to bind the free calcium. And that then lowers the ionized calcium even more. And then the parathyroids are like, oh my freaking gosh, we have low calcium here, and that's our one job, right, to keep the calcium normal. And so we need to secrete more parathyroid hormone. And so that's secondary, not caused by like some tumor or something there. It's secondary to the other issue of the kidneys. Secondary hyperparathyroidism, PTH goes up in response to chronic low calcium and high phosphate. So PTH tries to fix things. It's like, let's increase the bone reabsorption. Let's like stimulate those osteoclasts. Let's release that calcium and that phosphate. And let's stimulate the kidney. Let's also stimulate the kidney. This is PTH speaking, so that we can make calcitriol. But then the kidneys are damaged, right? So that's not going to work very well. And you increase the calcium reabsorption in the kidney. And again, this is limited in chronic kidney disease. And so that PTH is just going to be rising and rising, but the calcium is never fully going to normalize. And so you have persistent high parathyroid hormone. All right. So it's low calcium, high phosphate, high PTH. Hopefully I explained that well. If you guys think this is helpful, please like and subscribe. It takes a long time to make these videos, double time if you forget and do this accidentally. But yes, it's on. It's blue. Okay, good. All right, guys and gals. There was a study that I read recently that said women physicians are like just holistically better than male physicians. They have like better outcomes for patients. And I was like, that makes sense. Anyways, we are on question 33. I'm going to try to speed through these, but our demographic for this question is going to be somebody who's like pretty fit. Reminds me of that Modern Family episode. I want to dance the ballet. 29-year-old ballet dancer presents with chronic right knee pain after high impact performances. Imaging shows thinning of the articular cartilage but no bony involvement. Biopsy of the affected tissue reveals reduced hydration and compression tolerance. Which biochemical feature of normal cartilage molecule explains the ability of to maintain the high water content in physiological conditions? Okay, now on the surface, this can be pretty tough, but like what this question is asking is essentially, why does cartilage via chondroitin sulfate swell and occupy more space and water than it does in a dry solid? And so what we need to know is that there's this thing called chondroitin sulfate. I'm going to zoom in. I've taken notes in this before. This is a glycosaminoglycan, or GAG, as you may have seen it in your med school classes. GAGs have tons of negative charges. In fact, anytime you guys see, this is a little tip, anytime you see sulfate, just click negative charge. It's going to be the answer. I swear, like every single time. I've seen so many times where sulfate is just negatively charged is the answer. And yeah, negativity, right? It attracts lots of water, the hydration shell, right? So you have the negatively charged that repels each other and the molecules spread out, and the negativity that attracts a lot of water. And so that together makes a gel-like space-occupying, shock-absorbing structure that's good for cartilage. And so our answer is high-density sulfate and carboxylate groups. Let's explain this a little better. Chondroitin sulfate is rich in sulfate and carboxylate, so it's highly negatively charged. It attracts water through these electrostatic interactions, leading to repulsion between chains. Hydrated mixture allows cartilage to absorb mechanical stress. Hyaluronic acid does not explain hydration. Lysosomal degradation would be a storage disorder, not water retention. Covalent linkage, it's for anchoring, not swelling. And N-linked glycosylation would be protein glycosylation, not the hydration behavior. All right, so maybe there's a way that you can remember this by saying GAG on water, right? GAGs gag on water. Glycosaminoglycans have negative charges, and so they soak up the water, and that gel cushion can form. I want to make this super duper simple. I worry that I overcomplicated this one. Maybe I didn't. I don't know. But basically, chondroitin sulfate has tons of negatively charged molecules. Negative repels negative. That causes these molecules to spread out. Negative attracts water. It swells, becomes gel-like. That's the answer. That's it. They're going to try to be like, oh, but collagen. Oh, you've seen collagen before. What if I said collagen binding? Don't you have to choose that because you know what collagen is? I don't know. Maybe I'm projecting, but that's how I feel sometimes. Structural support, right? Anytime you see collagen, think structure, right? Not swelling. How about covalent bond with core proteins, right? That's how proteoglycans are built. That's not why they expand, right? Covalent bonds do not tell you necessarily about the expansion. And they could try to get you with like the N-linked stuff. They'll say, oh, what about the N-linked oligosaccharides? Well, that's a glycoprotein modification, and it's just going to be unrelated. So GAGs, gag on water. They have negatively charged, they soak up the water, and they cause that gel cushion to form. Hopefully that makes some sense. All right, next we have a 27-year-old man collapsing while hiking in Arizona. Been exposed to high heat for hours, didn't drink water. His vitals show tachycardia and hypotension. By the way, always drink water. Check this out. It's so good for your kidneys. This is how much you need to drink in a day. It's probably more than you thought, but I digress. Anyways, this could be any demographic. It could be an older woman, could be an older man, could be whatever. So I'm just putting that question demographic up there. But yeah, the serum is 150. Dehydrated state is what we're talking about. And what's most critical in helping to conserve the water? It is the urea transport into the medullary interstitium from the collecting duct. So the answer is C. And a way that you could see this is like, okay, a man or a woman is running a marathon, they get dehydrated. And that dehydration means you got increased plasma. Osmolality is the concentration of a solution as expressed by the total number of solute particles per kilogram. Okay, so you got a lot of the solute. And the brain senses this. The brain's like, oh my gosh, we got a little solute. Let's release the hounds. Let's release ADH, like Mr. Burns. ADH is a fancy little thing. It's also known as a vasopressin. All right, now the main job of ADH is to put the aquaporins in the collecting duct. Chunk, 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 chunk. It just puts them there, right? Hey guys, let's upregulate the aquaporins. It also has a side job, and that side job, it's a side hustle, is it increases the urea reabsorption through the medullary collecting duct. All right, so we're increasing that urea as well, that absorption. And the urea really helps the medulla stay salty, right? The high osmotic gradient. I took a class on like nephrology at Harvard from one of the most foremost experts on the kidneys. And I swear every 5 minutes he'd say, we need to preserve the osmotic gradient of the kidney. So yeah, it's super important that we just like preserve that osmotic gradient. And here's our explanation. Dehydration responds by increasing ADH. Not only increases aquaporin insertion for water absorption, but also increases urea transport to the medullary interstitium. The urea makes a gradient, drawing more water out of the collecting ducts and concentrating them. So it's all about that gradient, right? ADH is the main hormone that saves water. It adds water channels to the duct and it pulls urea back into the duct, making the medulla extra salty. And that helps it suck out even more water. All right, so ADH adds water, adds urea. That's how I want you to think of ADH, and we're done with that question at least. All right, we're gonna have to go quickly. Macrocytic anemia, alcoholism, seizure, macrocytosis, hypersegmented neutrophils, low retic count, ineffective erythropoiesis is what that means. So you see macrocytic anemia, low folate intake, rapid depletion, B12. And then the other thing to know about B12 is that it has an increase in both, right? Vitamin B12 deficiency takes years to develop, and you can see both increase in homocysteine and MMA. All right, so for this question 35, the big things to look out for are macrocytic anemia, a retic count is low, that means we're not making red blood cells very well. And there's also alcoholism, malnutrition, that's a vitamin deficiency, and the stores of folate are gonna run out super quickly, but then the vitamin B12 deficiency takes years to develop, right? So here we have a 44-year-old woman brought in by a roommate, confused, tremulinous, history of alcohol use disorder. The answer is going to be a folic acid deficiency. Here are the answers and the explanations. They're going to try to trap you various ways. They might say lead toxicity, that's microcytic. They might say iron deficiency, that's also microcytic. Beta thalassemia, that's also microcytic. Thiamine deficiency, they could see like Wernicke's encephalopathy, but that's not going to be a cause of anemia, right? So they could do a whole bunch of things. Vitamin B12 is another one to look out for. But B12 deficiency takes years to develop and folate runs out more quickly. Alcoholism and malnutrition tells you it's probably like a vitamin deficiency. You might be wondering, okay, like folic acid deficiency, vitamin B12 deficiency, which one is like, alcohol is more related with folate deficiency. It's much more common and much faster. And for B12 deficiency, the causes are usually like pernicious anemia, gastric bypass, Crohn's disease, vegan diet. So the stores are a lot less for folate. So it runs out in weeks to months. All right, next we're going to be talking about a 27-year-old kindergarten teacher presents with spontaneous gum bleeding, widespread petechiae, recovers from a cold 2 weeks ago. Here are her labs. What's the underlying mechanism? It's autoantibody-mediated platelet destruction. So, might say like a young woman. Here's a kindergarten teacher. You can see our photo. Easy bruising, viral illness a month ago, thrombocytopenia, bone marrow smears, right, which show like megakaryocytes. Viral infection causes the way that this typically works, this is, by the way, ITP is like a ruling out diagnosis, but you have a viral infection and then the immune system gets all activated and then you start to make antibodies against the platelets. And that is anti-GP2B3A. And so the platelets get destroyed in the spleen, splenomegaly. The bone marrow is still healthy, so it just makes more. And that's why you have megakaryocytes. It's like a good positive response that you're trying to do. You're trying to build megakaryocytes so you can respond to the lost platelets. And this is immune thrombocytopenia purpura. It's an immune problem. All right, they could try to trick you in various ways. Here are some trap answers. Bone marrow failure. That would have hypocellular marrow. B19 is aplastic, splenic sequestration, splenomegaly. But here, actually, they didn't mention splenomegaly, interestingly enough. But yeah, the sequestration would not necessarily come from a viral illness. DIC, elevated PT and PTT. And just briefly on the spleen, you might ask, okay, so if platelets are being destroyed in the spleen, then why would not the spleen be the answer or in the answer? And so this question's going to ask, or question you might see is, what's the most likely cause of the thrombocytopenia? Well, the cause is immune-mediated destruction of the platelets. And the spleen is the place where the destruction happens, but the mechanism is still antibody-mediated platelet opsonization, and it's the splenic macrophages that clear them. And so if it said splenic sequestration as the answer, like big spleens from cirrhosis or portal hypertension, well, that's kind of a different mechanism, right? So in sequestration, the spleen traps the platelets mechanically. In ITP, it's the autoantibodies that target the platelets, and it just happens to be the spleen that recognizes and destroys them. Hopefully that makes sense. Think of it this way. Big spleen, thrombocytopenia by sequestration. Normal spleen, recent infection, megakaryocytes, that's probably ITP. I know that can be confusing at times, so I just wanted to kind of point that out. Oh, I should probably have written that down. Big spleen, thrombocytopenia. Normal spleen, recent infection with that autoimmune activation, and the presence of megakaryocytes. And low tells you got ITP, right? Peripheral immune destruction. All right, in our next question, we have a 59-year-old man. Could also be a woman. The 40-pack presents with new onset fatigue, elevated blood pressure, and difficulty rising from chairs. He denies pain or sensory changes. Physical exam shows moon face, essential obesity, and decreased muscle bulk in the thighs. Fasting glucose at 178. He reveals central pulmonary mass, encasing the right main bronchus. Main bronchus. Which hormone is most likely responsible for the muscle weakness? Oh, and biopsy shows small dark blue cells of chromogranin A. Well, we had moon facies and central obesity, and that tells us it's Cushing syndrome. And that's usually hyperglycemia. You see proximal muscle weak, proximal muscle weakness, trouble standing up. But this is kind of a tricky one, right? Because, and also this is important. I kind of lit up, you saw whenever I saw central pulmonary mass. And that's because I've made a couple of videos on this, and the last recording I did that was 2 hours long, I went through and I explained all of the lung diseases. I should release the muted version of that because I get so excited when I talk about this because there's a really simple way of not missing questions like this in the future. But here I know that this is small cell, or it's going to be squamous cell if it's central. And so small cell carcinoma can secrete ectopic hormones. So that could kind of explain, the muscle weakness, the hyperglycemia, the Cushing syndrome stuff. And so you can have a tumor that secretes ACTH and that overstimulates the adrenal cortex and that causes the increased cortisol, explaining the Cushing. Isn't this crazy? Medicine is kind of crazy sometimes. But here, the answer is adrenocorticotropic hormone. And it's because of that ectopic ACTH from the small cell. And here, I think it's super important to actually look at these answer choices. Vasopressin, inappropriate ADH would cause hyponatremia, not hyperglycemia. So it ain't vasopressin. Calcitonin, medullary thyroid carcinoma, inhibits bone resorption, not with Cushing. This one, PTHRP, that's hyperglycemia malignancy. That'd be squamous. It causes calcemia, not hypercortisol. So that cues you into the different type of cancer. IGF-1, acromegaly. So yeah, there are some tumors that make you diabetic, weak, puffy-faced, and it doesn't even touch your pancreas or your pituitary gland. It's the paraneoplastic syndromes of the small lung cell cancer. So you should think of PTHRP, parathyroid hormone-related protein. And that one causes an increase of calcium. All right, looks like I did a graffiti all over this question in my last video. This one, aspirin makes it worse. Let's talk about when aspirin exacerbates things. Well, there's something called aspirin-exacerbated respiratory disease. It's associated with chronic rhinosinusitis with nasal polyps. Here we have a 29-year-old woman, but it could be anybody, and especially somebody young. It could be a 15-year-old girl or boy, for instance. That's kind of this demographic. And they have onset asthma, presents with shortness of breath and wheezing 30 minutes after taking an over-the-counter. So it's aspirin exacerbated, and you just have to know the mechanism of aspirin is cyclooxygenase. All right, so they have non-selective irreversible inhibition of COX-1 and 2, phospholipase A2. Steroids inhibit it. 5-lipoxygenase, dilutin blocks it. leukotriene downstream, and prostacyclin is downstream as well. So yeah, aspirin can make asthma worse. So it's important to remember glucocorticoids can block phospholipase A2, but that's like way upstream. And then aspirin and NSAIDs block COX. And then xylutine blocks 5-lipoxygenase, and montelukast blocks the leukotriene receptors. All right, this next one's pretty easy. It's just an opioid overdose. Pinpoint peoples is what you need to know. Low respiratory rate. There's a triad for opioid intoxication. 23-year-old man unconscious at a bus station. Small bag of crushed pills is found. Withdrawals to pain, does not open the eyes or speak. Basically, he's got a CNS depression, bradypnea. So his respiratory rate is like super low. That's opioids. And so the answer is D. Pulse is decreased, respiration is decreased, pupils are constricted. Super simple. The mental status, you have like a sleepy comatose patient. The breathing is depressed, it's slow, shallow, heart rate is bradycardic, and hypotension, the pupils are pinpoint. That's opioid overdose. I feel like a lot of people know this one. So those are the notes that I took on the last one. And by the way, you give them naloxone for that. That's the antidote. All right, so here we have a 29-year-old woman, 34 weeks gestation, presents to her primary care physician with a 3-day history of fever, myalgia, loose stools. She denies cough, dysuria, and rash. She has no pets. She ate cheese, fruit platters, smoked salmon, febrile, leukocytosis, catalase positive, gram positive with tumbling motility. What led to this? It's the eating of the soft cheese. Right, this is Listeria. So the blood culture shows small gram positive rod. And here it's just a matter of memorizing all of these rods, which is so silly because we can just look them up on the internet. But don't get too cynical yet. Things will change eventually. Fever, nausea, headache. That's what you should look for in this one. Catalase positive, tumbling motility. What else about Listeria? It grows in cold temperatures. So it survives in unpasteurized dairy. There's soft cheeses, cold deli meats, all that stuff. And the high risk patients are going to be pregnant women. I would say 9 times out of 10, that's going to be your demographic. Also like, neonates, elderly, immunocompromised. But for some reason on STEP, they just love asking about the pregnant woman. And so in pregnancy, you have like mild flu illness in the mom, but it can cause chorioamnitis, fetal demise, neonatal sepsis, meningitis, all that stuff. Okay, here are the explanations. Raw poultry is Campylobacter risk, smoked salmon, less likely for Listeria. With diarrhea, shagella, but they're the blood. You'd see tons with shagella. Farm animals, E. coli associated. So Listeria likes lunch meat. That's how you remember it. This next one is one of my favorites for some reason. WADA syndrome. The pathophys, you have a pancreatic islet cell tumor. VP binds intestinal epithelial receptors, increases the CAMP, chloride, sodium, and water secretion. You get just tons of watery diarrhea, and it inhibits gastric acid. And you treat it with somatostatin. Labs, low potassium, low chloride, high bicarb, increased VIP. Octreotide inhibits VIP secretion. So here we have a 46-year-old woman, could also be a dude, as in her demographic there. Progressive fatigue, lightheadedness, and 6 days persistent profuse watery diarrhea. Is what we're thinking of, and so you give somatostatin analog. Here are the trap answers. Pancreatic enzyme, that'd be for steatorrhea, non-secretory diarrhea. Loperamide is an opioid analog, different mechanism. Insulin infusion for hyperglycemia or DKA. H2 receptor antagonism is for acid suppression. So yeah, a rare pancreatic tumor is what this person's got. You can actually cause up to like 3 liters of watery diarrhea. So it's just like profound watery diarrhea. So you also get hypotension, hypokalemia. The stool output is like 3.5 liters a day. It's associated with MEN1 syndrome, arises from the pancreatic tail, octreotide. Flush face, watery diarrhea, hypochlorhydria, or achlorhydria, and hypokalemia. It's a VIPoma, pancreatic neuroendocrine tumor secreting the vasoactive intestinal peptide. All right, next, what's the swelling that enlarges with crying? Indirect. It's a communicating hernia. Soft reducible mass in the groin, lateral to the inferior vessels. This is going to be seen in kids. I remember that because KID, kid, I, indirect. Processus vaginalis fails to obliterate, leaving a pathway, and then the abdominal contents herniate in there. It's indirect. So it could be a super youngster, like this cute little baby on the top. And so here's our question. 2-month-old male evaluated for swelling of his left groin. The parents notice during diaper changes. Swelling enlarges when the child cries and disappears when he's calm. On examination, a soft, non-tender, reducible bulge is noted in the left groin. What's going on? It's lateral to the inferior and superior to the inguinal ligament. Indirect. What about all these other answer choices? Well, we kind of got to know them. Inferior to the inguinal is femoral. That's in women. For step 1, just think it's in women. They're not going to test you on harder than that. Superior to ligament, direct inguinal in adults. Medial to the vessels, not going to see anything there, especially not above the transversalis fascia. Femoral canal, lateral, again, femoral hernia territory. So we got a young kiddo and a groin bulge that worsens whenever they cry and it goes away whenever they're resting. Indirect inguinal hernia every single time. It's the failure of the processus vaginalis to close. And the anatomy is the indirect inguinal hernia. So it'll pass through the deep inguinal ring into that canal in the superficial ring, so it can even reach the scrotum, and it's lateral to the inferior epigastric. Remember, MDs lie, medial direct, lateral indirect, lateral to the inferior, and it's superior to the inguinal ligament. And so a direct inguinal hernia is medial to the inferior epigastric through this Hasselbalch's triangle, and the femoral hernia is inferior to the inguinal ligament. All right, so it's all about that inguinal ligament, right? If it's medial to the inferior epigastric, then it is a direct inguinal hernia. If it is lateral to the inferior epigastric, then it is an indirect hernia. Remember, MDs lie. Lateral, indirect, medial, direct. Older people, kids. Done. All right, let's talk about PPAR-Y, the party. For those of you who have gone to parties, I've never gone to a party before, but I hear they're fun. We have a 54-year-old woman, could be a man as well, so check our demographic image here. Could be either. 6-year history of type 2 diabetes, follow-up visit. Blood glucose remains elevated despite maximum doses of metformin. And we're now going to try a medication that improves insulin sensitivity by binding to a nuclear receptor. 1 month later, we have mild weight gain. Which drug and mechanism of action? Peroxisome, proliferator, activated receptor gamma. I have a video on all of these drugs. But here we got, the way that you'll see this on test day is somebody's going to have type 2 diabetes. They're going to be on like glyburide or sulfonylurea and metformin, and they're still not going to go anywhere with it. The next step after you've tried a glyburide like sulfonylurea or metformin, you're next going to go to pioglitazone. The mechanism there is very clear. It's you need glitter to go to the party. That's how I remember it. So glitazone to go to the party. Okay, so it binds the PPAR. It binds the PPAR gamma, and I like to say the gamma is like a Y. Glitazone, glitter to the PPAR-edy. Peroxisome, proliferator activated receptor gamma. That's what it stands for. So the PPAR gamma is a nuclear transcription factor that's found in the adipose muscle liver. And the activation increases the gene expression for the insulin sensitivity. And so you have better glucose uptake by the muscle and the fat. And then you have decreased hepatic gluconeogenesis. It's not a GLP-1 agonist like liraglutide that increases insulin secretion and decreases glucagon. So you remember glitazone, or you can remember P for PPAR-Y and P for pioglitazone. But yeah, either way, that's for peripheral sensitivity. Now let's look at these explanations. Activates PPAR-Y, edema weight gain. AMPK would be metformin. DPP-4 inhibition, sitagliptin. SGLT2 flows in the liver, promotes glucosuria. Potassium channel inhibition, sulfonylureas, causing insulin secretion. Cool beans. All right, now this is about where I was when I lost the recording last time, but there's a really easy hack for this question. Basically, if you see an African-American individual or somebody from the Southeast, kind of Asian descent, it's like maybe a sailor, they get lots of sun, but they don't sunburn is the point. So dark skin has like protective melanin, right? And so basically they would be at melanoma risk. And in darker skin, the UV-related melanomas are like less common, right? Because melanin is protective. And so anytime you see that kind of scenario forming on your question stem, immediately lock in acral lentiginous melanoma. That's a darker linear streak on the nail beds in patients with darker skin. And that's how they're going to test on test day. I know it is what it is. The classic sites are going to be the palms, the soles, and the nails. And it's most common in African-American and Asian patients. That's just how it is. That's how they test it. And like other answer choices, like the chest, forehead, all that stuff, those are like sites for UV-related melanomas and superficial spreading and non-lentigo maligna, but that's less common in darker skin. So the darker skin really lends you more toward the acral melanoma. All right, now this one is wild because almost as soon as I recorded this, I went out and bought this mouse so I could make better videos for you guys on Facebook Marketplace, and I met somebody who had this condition. She literally told me that she had acute inflammatory demyelinating polyradiculopathy, and I was like, that is a mouthful. And also, that was the first time I'd seen a patient with that. But anyways, 35-year-old woman, 4 days progressive weakness, difficulty climbing, tingling in her toes, episode diarrhea after eating undercooked poultry, lumbar puncture reveals elevated protein with white blood cell count. Answer is antibody-mediated demyelination of the peripheral nerves. So yeah, this is kind of pointing at Guillain-Barré, but like specifically the acute inflammatory demyelinating polyneuropathy. And so it's post-infectious. Autoimmune cross reactions. The antibodies attack the myelin of the peripheral nerve roots, and demyelination slows the conduction time. So polio, anterior horn is poliomyelitis, not ascending, asymmetric spinal atrophy of the muscles, axonal, corticospinal loss, and ALS. Postsynaptic acetylcholine is myasthenia gravis. What's interesting is that Guillain-Barré is the most common cause of acute flaccid paralysis in the United States today. It's not polio, it's Guillain-Barré. Okay, this next one, I'm not going to overcomplicate it. It's basically if somebody has vaginal dryness, they're going to have low estrogen. So this is obviously going to be a female, but like maybe think of postpartum breastfeeding, dysuria, pale, dry vaginal mucosa 5-6 weeks out. Lactation causes increased prolactin that inhibits the GnRH, that inhibits downstream later on estrogen. And the mechanism is important. It's low GnRH to low FSH to low LH to low estrogen. But then here in our practice question, we have elevated prolactin, and that's what's causing the estrogen that's low. Menses have not resumed since delivery. Low estrogen is definitely going to be correlated to vaginal dryness. All right, here are the other answer choices. Increased luteinizing hormone would be PCOS, but here it's lactation, so this is suppressed. Decreased prolactin impairs milk production. That would not cause pain during sex. Increased estrogen. So yeah, breastfeeding mothers can experience vaginal dryness. And this isn't because of menopause at all. This is like prolactin stuff. In fact, it might explicitly test you on patients who are before menopause, just so that they can get at the prolactin's effect on the lowering of estrogen. But yeah, it's an interesting mechanism. Got to know it. All right, on to our next one. Here we have a 65-year-old man, a 5-year history of poorly controlled hypertension, and they're going to give him a CPAP, and they're just going to say, hey, what's going to change? It's going to be a reduction in your blood pressure. And that's interesting. But, usually the way they'll ask it is we got like some patients, usually it's going to be like kind of obese, loud snoring, daytime sleepiness, obstructive sleep apnea, all those symptoms, OSA, and hypertension, diabetes, kidney dysfunction, all that stuff. And they're treating with a CPAP. Basically on OSA, which is obstructive sleep apnea, you have repeated airway obstruction at night and you have drops in the O2, and that causes sympathetic surges. And so the sympathetic surges cause a big swing in the blood pressure, and that's sustained in daytime hypertension. And so CPAP prevents the airway collapse, and that reduces the apneic episodes, and that lowers the blood pressure. And it's not going to be the pulse, because that's not consistently lowered with CPAP. Creatinine. So sleep apnea can worsen your chronic kidney disease, but the CPAP doesn't fix it. So that's not going to be the answer. Here's some good answer choices that you can choose between. Uric acid would be gout associations, not CPAP related. Renal dysfunction is elevated creatinine, but not with the CPAPs. Weight loss. CPAP alone does not cause weight loss. Glucose, CPAP helps insulin sensitivity modestly, but does not normalize it. All right, next we're going to talk about immunoglobulin switching, isotype switching. Happens after the antigen stimulation. So you got the heavy and the light chains, and they each have variable regions. So there's the variable region is what you should know. And that's unique, right? It's unique for every antibody. It never changes even after the VDJ switching. And the constant regions are determined by the class, like IgM, IgG, IgA, IgE, IgD. And the isotype class switching that happens after antigen exposure with help from the T cells. So you have CD40 ligand, cytokines, and the constant region of the heavy chain gets swapped. So IgM to IgG. And the variable region, that stays the same. The constant region are the parts that change during the isotype switching. So here's our question. 24-year-old man has a vaccine composed of an activated virus. 2 weeks later, serum shows high levels of IgG specific to the viral antigen. This process involved genetic recombination of which portion of the immunoglobulin molecule? It's the constant region, because class switching involves the constant one, like going from IgM to G, while preserving the VDJ recombinated region, allowing the B cell to retain its antigen specificity while gaining the effector functions. All right, those are the other answers. But yeah, every single antibody that you have or that you make after a vaccine starts with an IgM, even the IgG and the IgAs. All right, guys, we're almost there. We are so close to the finish line. All right, so here we have a 22-year-old college student who is confused in her dorm room, multiple empty cold medications nearby. Vitals are stable, but look at that, 2,100 AST, ALT 2,250. What's the mechanism of this hepatotoxic effect? It is lipid peroxidation due to the oxidative free radicals. This is acetaminophen overdose. Accumulation of NAPQ toxic metabolite. Glutathione is depleted. NAPQI causes lipid peroxidation and death. So acetaminophen overdose is actually the most common cause of acute liver failure in the United States. And usually they have like a normal exam. The questions they like to ask this is like a younger student in college or somebody else, but typically at normal doses, it's safely handled. This medication is safely handled by the phase 2 conjugation, like glucuronidation or sulfation. But at overdose, you get some saturation, right? You get excess acetaminophen that's shunted to the CYP450 metabolism. And so CYP450 makes NAPQI, right? It's a toxic metabolite. And so what that does is it's normally detoxified by glutathione, but in overdose, glutathione storage gets depleted. And so now you have a lot of NAPQI, and you get peroxidation of the lipids in the cell membranes. And the treatment is N-acetylcysteine. That's the secret. All right, last question, and I really worked this one up. Basically, we have a 72-year-old man or woman, as you can see in this demographic image. It could be either. And the reason I'm trying to do that is I want you guys to be exposed of not just locked into this one patient. I want to give you a range of the demographic that's affected, because I think that's helpful as you take the step 1 exam to think about what types of patients you can and cannot see, as opposed to just being like, oh, it's a woman this time. I want it could be a man. But here we're kind of testing like some myocardial problems like congestive heart failure stuff. And so it's going to be somebody elderly. But I digress. A 72-year-old woman, in this case, history of long-standing hypertension, presents with progressive dyspnea and orthopnea. We have a normal left ventricular ejection fraction, but increased left atrial size and signs of impaired diastolic filling. Myocardial biopsy reveals normal sarcomeric structure, but increased systolic calcium levels during diastole. Which of the following mechanisms is most likely impaired in this patient's cardiomyocytes? The answer is the function of the sodium-calcium exchanger. That's diastolic calcium clearance. Now, especially if we look at heart failure with preserved ejection fraction, we have that poor myocardial relaxation, not the poor contraction. Contraction's fine, it's just the relaxation's not. So you preserve the ejection fraction. We have a circa dysfunction in chronic congestive heart failure. So it's the inability to restore the low calcium concentration during diastole. So basically what's happening is like after contraction, the calcium is not cleared from the cytoplasm. And so you can't relax. You just can't relax. There's so much in the body that's like that. You just can't let go. And after contraction, the calcium must be removed. It has to be. And that's mainly done by what How is this done? By the sodium calcium exchanger. It pumps the calcium out in exchange for the sodium to come in. And that's how you restore the baseline before you can actually start the next beat of the heart, right? It's not the fast sodium channels, because what do those guys do? The fast sodiums, those are the depolarization, right? That's phase 0. That's the fast depolarization. Inward rectifier potassium, that stabilizes the resting potential. L-type calcium channels, that lets the calcium in, right? That's the phase 2 plateau. And then ryanodine receptors, that releases the calcium to trigger that. So the ryanodine release, it's the sodium calcium exchanger. That's what's happening here. All right, guys, we did it. Man, deja vu. It's been fun kind of doing this twice. I've actually gone through and finished all the way to 90. So I'm going to try to finish the rest of these as soon as possible. If you guys like this format, please let me know. Is that better lighting? Let me know as well. Should I have all of my lights on, or is this better? Anyways, I hope you guys are doing super well. And remember, you're going to pass this exam in due time. Take care of yourselves. No feeling that you have is final. Make sure to prioritize your mental health. And let me just show you guys something. You live in a tiny little blue dot. That's you. And all of your problems, they seem like they're the biggest in the world, but that's only because of your perspective, right? We don't have control of very much, but a change in our perspective is very easily accessible through meditation and gratitude. So remember, if you're feeling a little bit overwhelmed, take a pause before watching the next little couple videos. Watch a movie, do something that's fun for you, lift your calcium oxalate dumbbells. And remember, we don't have a lot of time here on Earth, so make the most of it. We'll see you guys in the next video. Adios. All these questions are original. Here we have a 25-year-old woman delivering a term male infant. She reports self-limiting illness with fever, rash, joint pains. Okay, so the mama is sick and she does not get medication. And then the newborn has a murmur. Oh no. Bilateral white pupillary reflexes. Okay, some vision problems and also failed auditory. Okay, so vision, hearing, that is a triad for rubella. It's cataracts, sensory neural deafness, and also a heart defect. In this case, it looks like it's a patent ductus arteriosus. So basically in this question, we got a mom who's got a mild illness like a fever, rash, and post-auricular lymphadenopathy. Auricular, by the way, just means like the ear, so posterior to the ear, lymphadenopathy, and it's going to clear, but then the fetus is going to be in trouble because now the kid's going to have maybe like a blueberry muffin lesion with extramedullary hematopoiesis in the skin. And there's actually a vaccine for this. It's the MMR vaccine. It's a live attenuated vaccine. And you just have to notice that triad of the cataracts, the hearing loss, and also the heart defects, and that's rubella, especially if it's like a torch infection. You might be saying, okay, cool beans. What's a torch infection? Well, that would be like toxo. Other is like syphilis, rubella, which is the answer to this question. C stands for CMV, cytomegalovirus, and then H stands for HSV. And they present differently, but toxo, you need to know it's like raw meats and then cat feces. And the big one for rubella is cataracts, PDA, blueberry muffin rash, and they usually have an MMR that's not given, like a vaccine that's not given, and it should be before pregnancy. And I figured these are kind of difficult sometimes, so I wanted to cover them. Like CMV, that's transplacental vaginal. It could be like mild or mono-like maternal symptoms. Now in CMV, you can also have chorioretinitis. That's a big old fancy word for saying that you got inflammation of the chorioid and the retina of the eye. It's part of the uveal tract. You can also be seen with the blueberry muffin rash for this one too. And it's the most common congenital viral infection. Now, what's interesting about HSV as one of the torch infections is that actually occurs during pregnancy. And you'll get painful genital vesicles. There's usually a vesicular rash and encephalitis that's seen. So looking at our answer choices, a vesicular rash is zoster or HSV, would be CMV, and anemia with target cells, that's a thalassemia. So liver problems. But yeah, now you know torch, the congenital infections that cross the placenta and affect the fetal development. But some other ones that are important like HIV, that can be vertically transmitted, but it causes immunodeficiency, usually not congenital malformations in HIV. HTLV, which is the one right here. This is a retrovirus that causes adult T-cell leukemia. That can cause limb hypoplasia, cutaneous scarring, but this is not common unless you have an early pregnancy. But these guys here on the right, these guys are your torch pathogens like CMV. This is sensory neural hearing loss, periventricular calcifications, microcephaly, blueberry stuff. Herpes. So herpes that's acquired during delivery. You should think of a C-section if there's active lesions. But yeah, this causes vesicular lesions, seizures, encephalitis. Rubella was the answer to this. Cataracts, deafness, PDA. Toxos, raw meat, cat feces, hydrocephalus, chorioretinitis, and intracranial calcifications would be seen with toxo. And syphilis goes with that saddle nose right there. That's the other, right? So that's the snuffles, desquamating, rash, like when the skin starts to just come off in scales. Also Hutchinson's teeth. Saber shin, saddle nose. All right, so hopefully that's a good little recap on all this stuff. These next two questions we're going to fly through pretty quickly. One is uncomplicated grief. And I think the most important thing that you should do on STEP is distinguish this from depression. So uncomplicated grief can take many forms, but it's never going to have 5 of the SIGI caps. So 5 of 8 for 2 weeks would be medical depression. But here we're not having medical depression, it's just uncomplicated grief. Medical depression is a bit more interesting on the exam. You have sleep changes, loss in interest, guilt, energy loss, concentration, difficulties, appetite, psychomotor, and these ideations. The sleep comes from the serotonin, interest loss is from the dopamine. The guilt is a prefrontal cortex dysfunction, energy loss, HPA axis, and also females are twice as likely, and so there's a hormonal influence as well. Cortisol is a known instigator. There's something called the stress diathesis model, although people are thinking that electrical circuits and voltage has a lot to do with it these days, but they're not going to really test you on that. But yeah, cortisol might disrupt the HPA axis, causing dysregulation of dopamine and serotonin, which can cause mood disorder. But the stress diathesis model says maybe there are instigating stress factors which can cause medical depression, but that's 2 weeks, 5 out of 8 of the SIGICAPs, and it's different than uncomplicated grief, which can take many forms. Okay, that's all I wanted to say for that one. I think if you know the difference between uncomplicated grief and depression, then you're going to be good to go. And so that's going to cover that topic for NBME 29. Now, for 53, I want to talk about colon malignancies. Now, on step 2 especially, less on step 1, but still may be seen, you have right-sided or proximal colon problems, and then you have the left-sided, which are more distal. The right-sided is typically seen with iron deficiencies, like iron deficiency anemia, fatigue, weight loss, all that stuff. Left side is usually bowel habit changes like obstruction, blood streak stools, things like that. On this right side, it's going to be more of a silent bleeder. And by the way, the reason I'm drawing it right and left is because when you're practicing to become a physician, we always want to imagine that we have a person there, right? So this is their right side of their body, this is the left side. So just getting in a habit of that. When you're reading x-rays, you always got to flip it. So silent bleeding versus the apple core would be seen on the left side. Right side is a little bit more likely to be involved in Lynch syndrome. So I'd think of that for step 1. Whereas the right side, more FAP, more sporadic. But it's also important to distinguish between a lot of these cancer kind of instigating syndromes like FAP, familial adenomatous polyposis, Lynch syndrome, Peutz-Jeghers syndrome. And with FAP, there is a 100% risk of colonic cancer. And the key word you should think about Lynch is microsatellite instability. There it is. And you can have right-sided cancers, endometrial ovarian risk. Marilyn Lynch, the CEO, right? Cervical endometrial ovarian risk. Peutz-Jeghers, that has the weird mutation associated with it, the STK11. It's also autosomal dominant. They all are. The hamartoma is a non-cancerous or benign growth that's made up of like an abnormal mixture of cells and tissues that are normally found in that area that it occurs. It's not cancerous, and typically you find it incidentally. And this can happen in various parts of the body, but the lungs are typically where we note it. And here with Peutz-Jeghers, you can also have mucocutaneous pigmentation, so on the lip, like the lips, the oral mucosa, stuff like that. There's a risk of GI and pancreatic and breast cancers as well. But yeah, apple core on the left side, iron deficiency on the right side. Bowel changes would be a little bit more left-sided, so like the pencil thin stools, constipation, that stuff. Microsatellite instability is the hallmark of Lynch syndrome. And then you should know for FAP, the APC gene, it's like uphold carrot. This is how I like to think of that. Lynch has the MLH1 microsatellite instabilities. Peutz-Jeghers is the STK11 mutations. So if you're feeling good about that, let's do practice question. We have a 61-year-old man comes to the clinic with fatigue and shortness of breath on exertion. He has no history of GI bleeding, but routine labs reveal a hemoglobin level of 9.5. Colonoscopy reveals a mass in the ascending colon. Biopsy shows a moderately differentiated adenocarcinoma. Which of the following is the most likely underlying mechanism in this patient? Okay, the answer is going to be there's a DNA mismatch repair problem, Lynch syndrome, aflatoxin, you think aspergillus, hepatocellular carcinoma, hepatitis B, also carcinoma there, HPV would be E6, E7 associations, and estrogen, breast cancer patho. So yeah, many causes of colon cancer develop without any symptoms at all. And so if you see a new iron deficiency, like in this patient, and it's going to be like an older man, maybe like a postmenopausal woman, then maybe you should think of colon cancer until you're proven otherwise. And there are 2 major pathways that drive this. There's the adenocarcinoma sequence that involves APC, CRAS, P53, right? APC, then CRAS, mutation, then loss of P53. That's the adenoma carcinoma sequence. And then there's the microsatellite instability. That is the MSI pathway. And in the MSI pathway, that's the mismatch repair problem with Lynch syndrome. And right-sided tends to bleed, while the left-sided tends to obstruct. So here we had a right-sided mass, so it's probably going to be an MSI pathway stuff, so it's a mismatch repair gene problem. All right, the next topic is anytime you have a mean, median, and a mode question, you should just be super thorough. They might ask you, hey, what would change if we have like a 0.5, 0.5, and 0.6, and we change this 0.5 to a 0.6? Well, then it'd be 2 0.6s, and so the mode would change, and also the median and the mean would both rise. Right? So just be super thorough. They're super easy questions. Don't miss those points. That's all I need to say for that question, 54. Okay, for next question, we have a 17-year-old girl who is evaluated for prolonged menstrual periods and easy bruising. She reports frequent nosebleeds in childhood and gum bleeding during dental cleanings. So we're already thinking of von Willebrand's, which of the following is the primary defect. It's the decreased platelet binding to the subendothelial collagen. Impaired platelet adhesion is what you should think of. And von Willebrand factor normally tethers these platelets to the subendothelial collagen of the GP1B. The 2B3A is Glanzmann's, and Glanzmann's is a big old name, and so it has more numbers. Whereas like Bernard Solier, BS, there's only one B in that. So BS, Bernard. And so I like to think of that's GP1B. I wonder if that's an answer choice. No, it's not, but you get the idea. Glanzman's super long name, so it has a super long GP2B, 3A, and that's all you really need to know. It's the aggregation problem, though, not adhesion. Aggregation feels like it has more numbers associated than adhesion does, and that's why I think of it as 2B, 3A, as opposed to just the one. Autoantibodies, ITP, thrombopoietin, a megakaryocytic thrombocytopenia, that's a low platelet count, and vitamin K would be 2, 7, 9, 10. And so you have a normal platelet count there. It's just that there's increased bleeding time because the platelets are there, they just can't stick. You also have mucocutaneous bleeding, so nosebleeds, menorrhagia, gum bleeding. You have increased PTT because von Willebrand carries and stabilizes the factor 8. And ristocetin tests are abnormal. That means it's defective. Bernard Solier, the giant. And I wanted to throw Chediac as well. That's just infections in albino. It's kind of unrelated, but sometimes people mistake that because it also has the giant stuff, but this is a different type of giant. And Glanzmann's, of course, we mentioned that's when you have no aggregation, whereas these guys are no adhesions. All right, for the next question. Here we have a 67-year-old man presenting with fatigue, generalized bone pain. He's lost 8 pounds unintentionally. So maybe some type of cancer. Oh, we got renal issues as well. Hypercalc. I think this is multiple myeloma. And so the answer is going to be D, osteoclastic activation by tumor cytokines. And D, this is multiple myeloma, which does not have PTHRP, that's squamous cell stuff. Vitamin D analogs, granulomatous disease, sarcoid stuff. Parathyroid would not have light chains. GI calcium absorption is vitamin D excess. These Bence-Jones are the light chains. You see bone pain in multiple myeloma and Rouleau formation. There's the crab. Calcemia, renal anemia, bone lesion. This one's super pathognomonic, but you could see the macrophage infiltration stuff. So IL-1 is elevated, TNF-alpha, MIP-1. These are all kind of big giveaways for the mechanism of action for multiple myeloma. Also the RANK-L, so through the activation of NF-kappa B, you cause an increase of the osteoclast, causing these lytic bone lesions, which is indicative of multiple myeloma. Okay, so that's how you think and diagnose multiple myeloma on test day for step 1. You might see like IL-1, TNF-alpha factors, that stuff. Okay, in our next question, we have a 31-year-old woman presenting with intense vulvar itching, burning, and thick white vaginal discharge. She recently completed a course in clindamycin for dental abscess. Pelvic exam shows erythema of the vulva and clumpy white discharge. This is Candida vulvovaginitis. 4.3 is the pH, and first line is fluconazole, which causes the inhibition of ergosterol synthesis via cytochrome P450 inhibition. All right, there are a couple of antifungals and things we got to know. So azoles, that causes the inhibition of ergosterol synthesis, so no ergosterol there. Polyenes like that, those will bind the ergosterol and cause the pore formation. There you should think of amphostatin. Echinocandins, these guys are big players. They inhibit the beta-glucan synthesis, and so it will just cause no cell wall to exist. So if a lot of the azoles and the polyenes like nystatin and stuff, they aren't working, then maybe consider this drug so you can just literally wipe out the cell wall. The stopping of the DNA and the RNA is the job of fluticasine. If you give them terbinafine, then it causes a buildup of squalene, which is toxic. That's used for tinea infection. So antifungal mechanisms like azoles are used for vulvovaginal candidiasis. And you know it was candidiasis because of that thick white cottage cheese stuff. Also the pseudohyphae on the KOH prep tells you it's diagnostic under the microscope. And the pH that is low, like 4.5 or less, will distinguish it from the MS or bacterial vaginosis. And then the recent antibiotics or contraceptive use, those are common triggers here. And so you use an azole antifungal that targets ergosterol synthesis through the CYP450 inhibition. You might also have some interesting associations and risk factors, like one of them is actually diabetes, or immunosuppression, right? It'll impair your host defenses. Pregnancy is one because you have hormonal changes. Fluconazole, miconazole, those guys inhibit the 14-alpha demethylase, which is a CYP450 enzyme. Ergosterol is the fungal cell membrane component. It's like kind of like cholesterol in humans. This is a good way to think about it. And so Candida normally colonizes the vagina as part of the flora, and the antibiotics and the hormonal changes decrease the lactobacilli that increases the Candida overgrowth. And so then Candida starts to make those pseudohyphae in the tissue, and azoles like fluconazole inhibit the CYP450 dependent demethylase, and that causes decreased ergosterol synthesis and also membrane dysfunction. And so it's a fungostatic effect, right? The yeast just can't grow. They can't replicate. It's amazing. And usually on the KOH prep, you'll see the budding yeast and pseudohyphae. So yep, give them fluconazole and know that it inhibits the demethylation through the CYP450. So yes, it's the fungus among us, kind of like the Pokemon. But yep, your azoles, they target the fungal CYP450, 14-alpha demethylase. Resistance can happen through efflux pumps. CYP450 is partially affected, so it can interact with warfarin and phenytoin and those 450 susceptible medications. Penetrates the CNS, used it in crypto, Candida, coccidio. Itraconazole is used in histo. Here's another practice question. Start on medication. How does it work? Blocks linosterol 14 alpha demethylase. Membrane pores is amphocytarin B or nystatin, which there they are on this nice sheet here. Glucan synthase is the echinocannins that stop the cell wall. Thymidylate synthase, the 5-FU flucytosine, stops nucleic acid synthesis, and squalene epoxidation. Terbinafine inhibits squalene epoxidase, so causes the squalene growth, kills your tinea. For the next question, you might see somebody with, I've seen a lot of questions on this on different NBMEs. Blisters, how do the blisters happen? So the pathophys of the blisters is you get mechanical, autoimmune, thermal, infectious injury. You lose the desmosome integrity. Now you get the subepidermal, like in bullous, pemphigoid, seen in frictions and burns. Here's a practice question. 76-year-old man, large tense blisters. Nikolsky sign is negative. Autoantibodies against the hemidesmosomal proteins, bullous, pemphigoid. Negative Nikolsky, positive would have been the shearing on the rubbing, which is pemphigus vulgaris, not bullous. So yeah, those hemidesmosomes, they are super important. They anchor the keratinocytes to the basement membrane. That's just like the cells that produce keratin. The key features are linear IgG and C3. Here's another practice question. 74-year-old woman, several large tense blisters on her trunk. She's got linear deposition of IgG. What's going on? Dysfunction of the anchors to the basal cell to the basement membrane. Bullous pemphigoid. It's when you attack the hemidesmosomes. Think of the H attaching, hemi, attach it to the basement membrane. Now the linkage itself, the desmosomes are attacked in pemphigus vulgaris. Neutrophil migration, selectins and integrins, T cell homing, CLA, and tight junctions would be in the intestinal and the renal epithelium. So seen in elderly, itching, that kind of stuff. Blistering. All right, this one's really interesting. Here we have a 32-year-old man presenting with rapidly enlarging thigh mass. Biopsy has a pleomorphic polydifferentiated cell with scant cytoplasm and hyperchromatic nuclei. We have strong positivity for desmin. All right, so desmin, what is that? Muscle. Anytime I say the word muscle, I got to do some exercises. So yeah, it's smooth muscle, right? Desmin is a muscle-specific intermediate. And here you really have to know your tissue markers, right? So on muscle tumors, you have desmin. And I did this beforehand, right? Those guys are the intermediate filaments in the muscle cells. And they're positive in like rhabdomyolysis or leiomyosarcomas, anything with a myo in it, right? Myo, desmin. The cytokeratin is in the epithelial cells. So that's positive in carcinomas, right? The skin, the glands. For the nerves, you should think of the central, the peripheral, neuronal support, glial cells. And the marker there that you should probably know is GFAP. And GFAP is an astrocyte marker. So glioblastomas, ependymomas. And the last one I think I'll just add for completion is S100. That's for melanocytes like melanomas, Langerhans cells, schwannomas. So they could ask you this in a number of ways. They could say, we got like a 6-year-old boy. He's got a big old mass and it's spindle-shaped tumor. It's got cross striations and it's positive for myogenin and desmin. And then they'll say, hey, what's the diagnosis? And you're going to say, it's a rhabdomyosarcoma or something like that with a myo in it because of the desmin. Cool beans. All right, for this next question, I think it's important to know just what is peritonitis? Like, what even is it? Well, I guess if you break apart the word, it's peritonitis is an inflammation itis of the peritoneal lining of the abdominal cavity. And you're going to see just like acute, painful, and life-threatening presentations. Now, it can be primary, it can be secondary. So primary is like cirrhosis or like a nephrotic syndrome. And secondary would be like a perforation or a GI tract thing. Maybe you have a peptic ulcer that ruptures, or you have appendicitis, diverticulitis, some sort of a trauma. Or you could even have a tertiary peritonitis. And that's after you give treatment. So there's postoperative or immunocompromised patients who will suffer from this. And the big thing here is the rebound tenderness. So if you lift the hand, oh, that's more pain than it was when you were pressing down, right? That is rebound tenderness. Guarding and rigidity, that's the involuntary muscle tightening. Ooh. There's also a board-like abdomen that people describe. It's classic for the surgical abdomen. And you'll have absent bowel sounds. So it's a paralytic ileus. You could also have diffuse abdominal pain, fever, tachycardia. The way to think about this on boards questions is, okay, there's going to be like a trigger. Maybe there's a GI perforation. Maybe there's a bacterial infection. Maybe there's a leak of the bile. Who knows? There's irritants in the peritoneal cavity, right? There's bacteria, there's acid, there's feces. Who knows what? Maybe somebody had their stomach hit open and cat feces got inside. I don't know. A million things, right? Massive inflammatory response. And then you get exudate and neutrophils that flood the cavity. Okay, what is exudate? Well, that's any mass of cells or fluid that has seeped out of the blood vessels, especially in inflammation. That's what exudate means. So you have that in neutrophils all up in your cavity, causing pain, edema, paralytic ileus. And so the signs you look for would be fever, hypotension, and also maybe shock. And you'll especially have shock if you don't treat this thing. So with that being said, we have a 68-year-old man. He's got diffuse abdominal pain, free intraperitoneal air, and thickened sigmoid colon consistent with perforated diverticulitis. There it is. Boom. There's the trigger we talked about. Autopsy shows a yellow tan strands of the liver capsule in the peritoneum, which the following is most likely component. It's fibrin. So he's got this perforated bowel, and I'll move so you can see these explanations. Bacterial peritonitis. He's got the exudate, inflammatory stuff is happening, and it's fibrin that traps the bacteria. The fibrin's like, oh my gosh, guys, we're having a problem. Let's like trap this bacteria so that it can't spread. But if you have like fibrin on your tissues, then that's going to cause some problems. It's not type 4 collagen. That's the basement membrane stuff. It's not elastin. That'd be the stretchiness. Not laminin. Laminin is a big old carbohydrate group that's seen just on the extracellular surface of pretty much every single organism. And hyaluronic acid, that's good for retaining moisture. I don't know if you guys have ever used that. It's like a kind of like a moisturizer. It's seen in like your eyes, like all over your body, keeps the moisture going. All right, for 61, anytime you see the word ischemia and they're talking about the renal tubules, then you should always think of the proximal convoluted tubule. And that's just always the case. And that's all I want you to know for 61. Super easy. I'm not going to harp on something if it's not important or could be stated very quickly and succinctly. Next, on that same vein, what do you do if you have a lot of kind of pale looking, weak looking red blood cells? Well, you just think immediately of iron deficiency anemia. Iron deficiency anemia can be caused by a lot of things like gastrointestinal blood loss. It's microcytic, hypochromic. Pale, you're just losing that iron, right? So it's just pale. It'll look like this, like they're kind of hollowed out a little bit. And I know you guys want a practice question, so I'm going to go ahead and give you one here. 76-year-old woman has exertional fatigue. Look at that anemia. MCV is low. Microcytic. What is the underlying cause? Bleed. It's a GI bleed. Microcytic, hypochromic, low ferritin, iron deficiency anemia every single time. You confirm this with colonoscopy. Bada bing, bada boom. Here are the reasons that it's not these things. B12 hypersegmented, autoimmune, spherocytes, myelodysplastic, would have pancytopenia. Bone marrow aplasia has low stuff. Liver tick, pancytopenia. All right, 63, I'm just going to remind you of the same question of like 61. Just PCT, ischemia. There are ischemic parts of the body that you need to worry about, but if it's in the kidneys, PCT every time. Next, we're going to go to 64. Here we have a 58-year-old male, chronic right flank pain, recurrent fevers, foul-smelling urine. He has a history of multiple urinary tract infections, large radiopaque stone, conforming to the shape of renal calyces, pH of 8.2, leukocyte esterase positive, and struvite crystals. What's the most likely causative organism? What's causing this? The big thing here is this pH. That's super basic, and the one that you should think of then is Proteus mirabilis. Also other Proteuses like Proteus vulgaris. But basically Proteus is a urease positive organism that increases the pH. You get the struvite stones. It's not E. coli. That'd be the most common UTI bug. Not mycoplasma that lacks the cell wall. It's not enterococcus. Doesn't produce urease. And not Klebsiella. It's less common in the stone formation. And really, if they're looking at something basic, then do Proteus mirabilis. All right, for the next one, we're going to distinguish between these two, slip capital femoral epiphysis and Osgood slaughters. All right, so what's the difference? Well, the age group can be similar, but the slipped is usually in growth spurt periods, and Osgood is for athletic kids. And that's pretty much all you need to know. Like that alone will help you distinguish Osgood slaughters because you'll be athletic in that one. And then typically the body type is obese. In a slip capitis, you have displacement of the femoral head, whereas this one's traction apophysitis. Basically, it's like the growing pains, but with the particular place that the muscle attaches, because these kids are strong, they're athletes. Okay, and that's the big difference. Here, we're just going to look at some clinical. If you see Osgood slaughter, sporty teen, below the knee. All right, this next question, we have a 2-year-old boy brought to the pediatrician due to frequent respiratory infections, hepatosplenomegaly, developmental decay, and we see coarse facial features, corneal clouding, and we have a deficiency of alpha-L iduronidase. This is the giveaway here, and the corneal clouding. So it's Hurlers. It can't be Hunters because Hunters need their corneas to see. So it has to be Hurlers. It ain't icell. Why? Because that would be a mannose-6-phosphate thing. So it's not that. Gauche. Here's the explanation for those. Glucocerebrosidase deficiency is Gauche. You'd have hepatosplenomegaly and bone crisis. And Tay-Sachs, I pretend that this is an X and I say hex. Tay-Sachs hex. And that causes cherry red, no hepatosplenomegaly. That's the big deal. Easy peasy, lemon squeezy, right? Sure thing, bubba-ding. All right, next up, here we have a 24-year-old woman, comes to the ED with nausea, vomiting, abdominal pain, history of type 1, examination, she's tachypnic and dehydrated. Which of the following explains the initial evaluation and drop in the potassium? So yeah, her potassium concentration is going to drop. Anytime you see that, you should probably be thinking about insulin. And the answer is indeed potassium shifting out of the cells due to insulin deficiency. She has that acidic thing going on. It's DKA, hyperglycemia, ketosis, anion gap metabolic acidosis. Now, normally insulin deficiency prevents the potassium uptake. So you have too much potassium, and acidosis causes the hydronium ions to shift in the cells. And then the total potassium is low because of the loss through osmotic diuresis and vomiting. It's not B because aldosterone may increase, but it's not the driver. And diuresis contributes to body loss, not initial elevation, and poor intake can worsen hypokalemia. Insulin helps it shift in. Now, I also wanted to do some pituitary stuff and hypothalamus stuff. The hypothalamus stimulates FSH and LH. The anterior pituitary stimulates spermatogenesis in the males and follicular growth in the female. Anterior pituitary also makes LH, which stimulates the Leydig cells. And then the gonads themselves make the testosterone, estrogen,
estrogen and progesterone. Now, the Sertoli cells, those secrete inhibin B, and that inhibits FSH. The granulosa in the female makes hormones. So, and that's like the granulosa in the female. Just wanted to go over some of those and also some other commonly confused ones. FSH, there you get Sertoli cell activation and sperm production with inhibin B. LH, and that's testosterone synthesis. And the testosterone is actually a negative feedback instigator of the testosterone causes negative feedback and also male secondary sex characteristics. And inhibin inhibits FSH only. So the names kind of do what you think they do, which is fortunate. All right, next you have a 29-year-old man, 3-week history of painless bilateral inguinal lymphadenopathy and single painless ulcer, unprotected intercourse, multiple partners. Most appropriate therapy is what? So this is bacterial transpeptidase, but we need to know because of that painless genital ulcer, chancre, the painless bilateral lymphadenopathy is primary syphilis. That's caused by treponema. And the first line is always going to be penicillin because it binds to the bacterial transpeptidase and disrupts the cell wall integrity. It's not 30S. It's aminoglycosides. It's not first line for syphilis. It's not DNA-dependent RNA polymerase. It's rifampin stuff for TB. It's not dihydropteroate synthase. That's inhibited by sulfonamides. And it's not mycolic acid. That's the isoniazid for tuberculosis. It's penicillin. Cell wall synthesis inhibition through bacterial transpeptidase binding. All right. Next, we have a 6-year-old boy brought to the physician due to persistent abdominal mass during routine checkup, they noticed. He's got a smooth, firm, non-tender mass. In abdominal ultrasound, we have a 9-centimeter solid renal mass. Genetic analysis shows deletion of 11p13. Mutation in the gene encoding which protein? The answer is A. So this was a kiddo, so it was Wilms tumor, nephroblastoma. We had a large unilateral flank pain. Histology shows blastemal, the blue cell components. And it's the WT1 gene, which is the paired box, the PAX domain. WT1 is located right there on 11-13. You know that if you watched our chromosome video, you think of that as like the 11L, Wilms. All right, it's not polycystin. That's going to be autosomal dominant polycystic kidney disease. It's not type 4. That's Alport. Not epithelial sodium channel. That's in Little syndrome. And it's not urea transport. That affects the concentrating ability. This is a Wilms. All right, and the last question here. 29-year-old man with HIV presents with the follow-up after a recent change in his antiretroviral therapy regimen. Recent lab has significant decline in the viral load and increasing CD4 T cell count. Raltegravir is most likely to inhibit which of the following steps? Tegravir, integration. It's right in the name. The answer is C. So there are some steps to the HIV replication cycle that are worth knowing. First, you have to attach, right? That attachment, you have GP120 binding to CD4, and those would be your entry. That's your entry step, and so you block it with entry inhibitors like Maraviroc, or any of the CCR5 antagonists. And then we have fusion. And I love these because it's right in the name. Infuvritide, right? It's when you try to fuse with the host membrane. So you have to stop the fusion with the things that have few in their name. Fusion. And then there's the uncoating process. And another big one is any of the navirs. Those are protease inhibitors, right? And the protease inhibitors, they affect that protein processing phase. So with the HIV drugs, when in doubt, it's all in the name. Integravir, it helps with the integration, right? It's used in that step. Infuvritide, the fusion step, right? The navirs, you're never going to be able to protein process. That's how you remember them. All right, we just did 51 all the way to 70. If you found this helpful, like and subscribe. We'll see you guys in the next one. Hello, everybody. Welcome back. Today we're on question 71. I've heard all of your feedback. The majority of you guys wanted no green screen, so you can see all the fun stuff going back in the room. We're on question 71. I've also been working on adding AI-generated images, which should go roughly with each question. The image will correspond to somebody who could have a similar condition, and I'll explain each one. So we have a 6-month-old boy evaluated for weight gain, current respiratory infection. All right, so you can see it just updated. On exam, he's tachypnic, mild subcostal retractions, cardiac auscultation reveals grade 4 to 6 holosystolic murmur at the lower, so it's that left sternal border and that holosystolic 4 to 6 sound, which really cue you into that diagnosis. Now, they could have asked this a different way, so here's a new question. Here we have a 6-month-old infant brought in for evaluation of poor feeding and frequent respiratory infections. Tachypnic, hepatomegaly, grade 4 to 6 holosystolic murmur at the left lower sternal border. And now they're saying which complication is most likely the condition if left untreated. So we established this is a VSD. So there's chronic increased blood flow through the pulmonary vasculature, and that's due to this left to right shunt. And so the answer is going to be pulmonary arterial hypertension. Okay, here's your explanation. Here's some other ones why they're wrong. Aortic dissection is not associated with congenital septal defects. Aortic valve. For that one, you should think of abnormal or previously damaged heart valves and dental procedures. That's subacute associations. So for this next question, there's a 19-year-old man with a known VSD, and on exam, he has a new holosystolic murmur, splinter hemorrhaging of his fingernails. He underwent dental cleaning. That is going to be Streptococcus viridans. It's the most common cause of subacute bacterial endocarditis. on abnormal valves. Staph aureus causes acute endocarditis on normal valves. Enterococcus is seen in the elderly with GU procedures. Staph epidermidis is in prosthetic valves. And Pseudomonas would be rare, but in IV drug use, it would have rapid, severe valve destruction. All right, so the answer is going to be dopamine, but there's a really strong argument for serotonin as well if you chose that. Now, it's not tyrosine, that's an amino acid precursor, which is not metabolized by an MAO, which, by the way, MAO inhibitors block the mitochondrial monoamine oxidase, and that degrades these things. So if you block it, then you have increased serotonin, norepinephrine, dopamine, and epinephrine. Or you could have serotonin syndrome and other problems like that. But this is seen in treatment-resistant depression. That's improved with phenelzine and transcyclopramine, tranylcypramine. So you're blocking the monoamine catabolism, and they mentioned aged cheese and red wine, along with severe headaches and hypertension, because tyramine escapes the first pass mechanism when MAO is inhibited. So tyramine-containing foods like aged meats, cheese, wine, soy, those are contraindicated. Also like tramadol, St. John's wort, linezolid, those can cause serotonin syndrome. And so this MAO normally is going to deaminate 5-HT, norepinephrine, and DA, epinephrine, but you inhibit it, and so you have increased vesicular stores, and it's not serotonin, though that could increase, since we're more dealing with our hypertensive crisis, not as much serotonin syndrome. You know, they could have said something like epinephrine as well, but that hypertensive crisis is less serotonin and more dopaminergic or epinephrine associated. Okay, so in this question, we have an 8-year-old girl. She's been tripping while walking, got double vision when looking to the left. So she can't look to the left. Her parents also know have been dragging her right leg. So her right leg is dragging. And on exam, she's got impaired left eye abduction and broad-based unsteady gait, increased muscle tone on the right lower limb with brisk reflexes. Which of the following is the diagnosis? Is pilocytic astrocytoma of the pons. Slow-growing brain tumor astrocytoma. So she's got the left abducens nerve palsy, cerebral ataxia, right-sided upper motor neuron science. It's not Guillain-Barré, that's ascending paralysis. Dix ataxia, genetic and symmetric. Gait ataxia, neuroblastoma would have lower motor neuron science, not the brainstem stuff, and cereballitis causes bilateral ataxia after a post-viral infection. Cool beans. So yeah, not the ascending, not bilateral problems. We see the brainstem problems, not spinal metastasis, because that would cause lower motor neuron problems, and acute cereballitis would be after some sort of an infection. And so our answer is A. And I think my microphone cut off on this one, so I'm going to redo it. A 22-year-old man will be shown up there. They have severe onset abdominal pain and vomiting for 3 hours. So there's our guy. He has no past medical history. Abdomen is distended. Contrast shows his duodenum does not cross the midline. So he's got a lot of his guts are just on the right side. And normally they're going to be spread without. So he's got some sort of intestinal malrotation. Twisting of the bowel around the narrow mesenteric base. Jejunal atresia is common in neonates. Meekles, diverticulum, has bleeding and obstruction. Stenosis causes chronic partial obstruction. Hirschsprung's, failure to pass meconium. All right, so that's another practice question. My mic was off when I did it though. All right, for this next one, we're talking about phenylalanine elevation. So there's a 2-week-old male newborn found to have elevated serum phenylalanine. His parents follow a low phenylalanine formula strictly, but at 3 months, he develops tremors, fails to meet milestones. Which of the following best explains the symptoms? The answer is defective metabolism of tetrahydrobiopterin. So he's got hyperphenylaninemia with a neurological dysfunction, even though he has dietary therapy. Phenylalanine transporter defect that would impair the absorption but not cause the elevated levels. Lack of tyrosine would not cause the neurological defects you see. Branch chain is seen in maple syrup, not PKU. Homogeneous state oxidase deficiency is alkoptenuria that have the dark urine. All right, so there's your practice question. You can't metabolize phenylalanine. And this is inherited in an autosomal recessive fashion. And you would treat them by just giving BH4, because BH4 is the required cofactor for phenylalanine hydroxylase, also for tyrosine hydroxylase and tryptophan hydroxylase. It drives the synthesis of catecholamines and serotonin. So if it's deficient, then it'll cause increased in placidopamine and serotonin decrease. So you could have neuro findings despite a low phenylalanine diet. And you treat them with BH4, sapropterin, and also L-DOPA, carbidopa, and 5-hydroxytryptophan. But you should just look out for any positive newborn screens with high phenylalanine and worsening neurosymptoms on a low phenylalanine diet. Yep, there's the BH4 defect. All right, a study finds annual death rate from cardiovascular disease is 4.8 out of 1,000 in diabetics and 2.1 out of 1,000 in non-diabetics. The attributable risk is just this minus that. 4.8 minus 2.1 is 2.7. All right, the attributable risk. This is super easy. You just do that minus that and you're good to go. So yep, the attributable risk. So RR is the relative risk and you just subtract them and you're good to go. It's super simple. All right, so now we're on 80. I'm going to keep working on optimizing the system so we can keep generating better images over here. But if you found this enjoyable or helpful, then like and subscribe. Hello, everybody. Welcome back to NBME 29. Today we are going to be starting off strong. Question 81. These videos take several hours to make, so please be sure to like and subscribe. Also, I've been listening to your feedback. There's no green screen today, just my wonderful back room, because that's what you guys decided on in the polls. And we'll start here with our practice question 81. A randomized controlled trial compares a new chemotherapeutic agent to standard care in patients with stage 3 colorectal cancer. After 3 years of follow-up, they report this data. The hazard ratio for recurrence in the new drug compared to the standard therapy is 0.72, and the confidence interval for 95% is between 0.48 and 1.16. So that 0.72 tells us that there is maybe some sort of a reduction recurrence. But this confidence interval means that it's not statistically significant. So the answer is C. There's no statistically significant difference in the recurrence between the groups. So the trick here is you have to determine if this contains 1 or not. And this one does contain 1, and so you can't tell if it's going to be positive or negative. All right, so this next one is commonly seen in elderly women, so I've changed that photo. And our practice question is, a 68-year-old retired librarian presents with persistent upper back pain after reaching to a cupboard. She has a history of rheumatoid arthritis and has been on prednisone for the past 4 years. Physical examination reveals kyphosis, that's like the hunching of the back, and point tenderness over the thoracic spine. Neuroexam is normal, and DEXA, that's like an osteoporosis thing, negative 2.9 at the femoral neck. We've got serum calcium, phosphate, ALP, and PTH within normal limits. What is the most likely finding? Well, she had her glucocorticoid use, and we see fragility and kyphosis, and so there is a loss of the trabecular with preserved mineralization. So it's thinned out. So oftentimes the patient will present with some sort of a condition like polymyalgia rheumatica, for which they're using chronic prednisone. And glucocorticoids actually accelerates bone reabsorption, or you also might have a history of hypertension. Oftentimes in these patients, you'll have multiple vertebral compression fractures after they fall, and then they'll be like, hey, here's a biopsy. And then they'll give you questions about that biopsy, and you have normal mineralization. Whereas osteomalacia and rickets is defective mineralization, so you have a wide osteoid. You should also look out for osteopetrosis, that's increased mineralization. It's thick sclerotic bone, but it's also brittle. Brittle. That's petrosis. There's also Paget's disease of bone. And there you have thickened trabeculae and also mosaic lamellar bone with a high turnover rate. And then cortical thickening is definitely not osteoporosis. It's more like Paget. So that thinned trabeculae, that is osteoporosis, especially if normal labs. Okay, so here's your explanation. So yeah, look out for that silent bone loss, glucocorticoid-induced osteoporosis. And the way to really think about this, to bring this home, is the bone has 2 major components. You have cortical bone, and you have trabecular bone. So the cortical bone is super compact, and that gives you your outer shell. The trabecular bone is really spongy, and it's the inner lattice work, especially inside the vertebrae and the hips. So trabeculae is the thin little struts that distribute the forces and give you the strength. And in osteoporosis, there's normal mineralization, but there's just like less bone. And so osteoclast activity is greater than osteoblast activity, and so there's net bone reabsorption. So both trabecular and cortical bone are thin, but their trabecular bone will go first because it has more surface area and a higher turnover. And that's why thinned trabeculae will show up on biopsy of osteoporosis, because the trabeculae are fewer and thinner, and the cortex is also going to be pretty thin too. But there's mineralization that's normal. So like the mineralization basically refers to the quality of the bone matrix. And there's no wide osteoid seams or defective calcifications, and so it's just osteoporosis. Because if there was defective mineralization, that's called osteomalacia. Basically, that's where the osteoid is laid down, but then it's not calcified, so you get soft bone in osteomalacia. If it were increased mineralization, then that's way too much mineral, and the bone would be super dense, but it's super brittle. Osteopetrosis. And then thickened cortex trabeculae, that's Paget's disease, and that's chaotic remodeling and thick but structurally unsound. This next one, we have a 29-year-old woman presented to the neuroclinic with complaints of persistent muscle weakness in her hands and trouble letting go of objects, so some muscle problems. Progressive thinning of her hair and difficulty climbing stairs. She had cataract surgery at age 25. On exam, percussion of the thenar eminence produces delayed relaxation. Her mother reportedly had mild difficulty with speech as well in her later years, so this is anticipation. So you're thinking, okay, trinucleotide repeat disorders, maybe myotonic dystrophy. Somebody in another chat mentioned, hey, do you have any videos on Huntington? Yes, we do. Trinucleotide repeat disorder video. Check that on the channel. But her younger brother also died of respiratory failure. So this is anticipation involving a repeat expansion of the non-encoding DNA. This is myotonic dystrophy type 1, G. C stands for cataracts, T stands for toupee, and then the G stands for gonadal atrophy or infertility. And that's the triad in myotonic dystrophy that you should know, and that's how you link it up with cataracts, toupee, atrophy. Imprinting would be Angelman, Prader-Willi, chromosomal non-disjunction is trisomy. The key to this one is just kind of recognizing what the condition is because of the cataracts, the toupee, the gonadal atrophy stuff. It could also be seen with myotonia. That's like delayed relaxation after contraction. So and a good example of this is you can't release a handshake. You can't relax. Also hatchet face deformity. So that's like a lack of facial expression. And arrhythmias, cardiomyopathies like cardiac conduction defects. Anticipation is the problem here. Sarcomeric point mutation would be hypertrophic cardiomyopathy. So yeah, watch for the grip myotonia, early cataracts, and cardiac complications. That's the CAG, CAG trinucleotide repeat expansion, autosomal dominant inheritance pattern. You see chorea, athetosis, that's like dance-like movements. And it also comes with cognition impairments like dementia, progressive cognitive decline, psychiatric stuff like depression, irritability, psychosis, and it's atrophy of the caudate nucleus, decreased acetylcholine, and decreased GABA is the way that I like to remember that, because CAG stands for caudate atrophy and decreased GABA, because the caudate nucleus is what's damaged. Whereas you contrast that with myotonic dystrophy, and that's, we discussed cataracts, toupee, gonadal problems. All right, now the reason we have this photo up here is because you also might see you got like a young mother and this mom is having some of the symptoms, or maybe throughout the family you see symptoms of myotonic dystrophy, and then it's going to ask about the little kiddo, and the little kiddo is already seeing those deformities, and so you know it's going to be anticipation. So those trinucleotide repeats are the problem. Hence my little photo there. Let me know in the comments where you would like me to be, if it's better if I hide the answer for a sec or something like that. I don't know. But the reason I have in this photo an elderly man is because you might be seeing this in somebody who's got some sort of a myocardial infarction. And this guy might have some sort of a respiratory problem. Let's say he's got like a bronchospasm. There's this thing that you need to be aware of called aspirin exacerbated respiratory disease, and that is due to COX inhibition and the shunting of arachidonic acid to the leukotrienes. So you're not going to give this guy aspirin, are you? No, because he's got aspirin exacerbated problems, and so you have to give him something else, like an antiplatelet. All right, so this is just one of the demographics you might see in this question, but now let's dive into our question of a 58-year-old woman who is admitted for unstable angina. She undergoes cardiac cath, revealing 90% occlusion of the LAD. A drug-eluting stent is placed. History includes adult onset asthma and episodic wheezing. Aspirin's withheld. What is the mechanism of the drug that's added? All right, you probably heard of clopidogrel, the GREL drugs. Clopidogrel, the mechanism is it blocks the platelet ADP receptor, and you get decreased ADP-mediated activation of GP2B3A receptors. And those guys are going to cause decreased platelet aggregation. And I like to remember aggregation because it's 2 and 3, which are the bigger numbers, whereas adhesion with von Willebrand or Glanzmann is just the 1, which adhesion for some reason does not feel as numerous or as large as aggregation. So it's decreased aggregation due to clopidogrel's inhibition of the ADP receptor. Now they might give you some trap answers, and we'll look at some of these, and I'll move myself out of the way now. Patients with aspirin intolerance are given ADP receptors to prevent aggregation. Thrombin inhibition would be the gatrans, not antiplatelets. Inhibiting cyclooxygenase 1, that's literally the mechanism of action of aspirin. So you can't do that. Don't worry, we won't give them aspirin. We'll give them cyclooxygenase 1 inhibitors. Same thing. Inhibits direct activation of factor 10A. Well, that's the 10A's in their name. I love that. They did that, by the way. XA, and anticoagulants, which are not your primary antiplatelets, and stimulating the prostacyclin analogs. It's used in pulmonary hypertension. They also might tell you other things, for instance, activating adenosine deaminase. Well, adenosine actually inhibits platelet activity. So that would be wrong. Doesn't have anything to do with serotonin either. Anything that inhibits gamma carboxylation is going to be warfarin. And warfarin is not an antiplatelet, it's an anticoagulant. And you might be saying, okay, well, what's the difference? Antiplatelet, anticoagulant. Well, antiplatelets obviously work on the platelets. Examples are aspirin through the COX-1,2 inhibition, which decreases TXA2. Clopidogrel, which literally blocks the ADP. MAB blocks GP2B3A. Dipridamol inhibits phosphodiesterase, increasing CAMP, and causes less platelet aggregation. Now, anticoagulation drugs actually work on that whole cascade, so they inhibit the clotting factors. And you use these for venous clots, DVTs, pulmonary embolisms, AFib. And examples are heparin, direct 10A inhibitors, direct thrombin inhibitors, warfarin, vitamin K dependent gamma carboxylation of 2,7,9,10, proteins C and S. Don't you just love gamma? I think it's the third letter of the Greek alphabet. But yeah, so a big takeaway. Arterial events like the MI and stroke, you need antiplatelets, and then venous events, you need anticoagulant. And the reason why is these arterial clots, they form in high shear stress environments, the arteries. And so platelets dominate. They adhere to the ruptured atherosclerotic plaque. They're composed of platelet-rich stuff, and it looks white. So MI, stroke, antiplatelets. That's why you need aspirin, clopidogrel, that stuff. The venous stuff is the red clots, low flow, low shear, and coagulation cascade. You have a fibrin, mesh, and trapped red blood cells. So it's really all about that shear stress. All right, so post-MI and stroke, antiplatelets, DVT, pulmonary embolism, AFib, anticoagulants, gold beans. All right, for this question, we might see several different demographics, but here we have a middle-aged woman. And in our question, we have a 35-year-old man who's referred to by his employer due to concerns about his persistent isolation and disengagement at work. He lives alone, he has no friends or significant relationships, and says he prefers working the night shift because people are exhausting. This is clear. Schizoid. All right. Avoidance would be if he fears rejection. Odd beliefs and stuff is schizotypal. MD is not depressed and he's not narcissistic. So that's kind of an easy breakdown there. That's kind of all there is to it. I don't want to take more time to explain something if it's a simple piece of logic that gets you there. Some other things you might need to look out for is they prefer solitary activities. There's a lack of desire for close relationships and restricted emotional expression. Schizoid, you should think schizoid. Schizoid, the void of emotions, detached. All right, now I'm giving you guys another example of a demographic you might see on test day. For this condition, my goal is to help you think of a clinical scenario where, sure, in the question segment it says 67-year-old man, but you also might see a 65-year-old woman. And in this question, one of the key and most important factors is the smoking history. He's got a 45-pack year history, crackles, dullness, percussion in the right lower lung field. Chest CT shows 5.2 centimeters, centrally located mass in the right main bronchus. Okay, so there's some really important points here. And our answer is squamous cell, but another one that I want you to think about is small cell. Now, I put the explanation here on the screen for you to see. He's got pneumonia and hypercalcemia. Also, anytime that you say keratin pearls, it's squamous cell. The tumor secretes PTHrP, or parathyroid hormone-related protein, and that leads to hypercalcemia with a low PTH. So it's like doing the job of PTH, but it's like an imposter. That's squamous cell for you. Now, why is it not small cell? Well, what I wanted you guys to know is that small cell is also central. And that one would show neuroendocrine markers, not the keratin pearls. And you'd have rapid growth and early metastasis. So a good answer choice because it's central. Large is peripheral. And that's how I want you to think about it. Just be like large, peripheral, done. A carcinoid tumor would have very differentiated neuroendocrine cells and chromogranin A positive stained. Adenocarcinoma is peripheral. So guys, the easiest way to do this, I promise, is just think peripheral versus central. And how do you know it's central? Well, it has an S sound, central. Squamous cell, small cell, S sound, central. That's the way to think about it. It's the easiest way, I promise. Adenoperipheral, large peripheral, so you cross them out immediately. And then carcinoid tumor, neuroendocrine chromogranin is what should come to mind with carcinoid. But yeah, so speaking of other demographics you might find, it could be an elderly woman. She's a smoker, right? She's just been smoking her whole entire life. And maybe she's got some fever, some coughing, hemoptysis. But the finding is going to have to be a right or left middle lobe consolidation, a hilar mass. So like a central lesion. So squamous cell, small cell, and then adeno and bronchoalveolar carcinoma and large cell, that stuff, that's peripheral. But squamous and small is central and central. You need to know that. And then you have to know parathyroid hormone-like protein is related to squamous, whereas the small cell has all other sorts of goo associated with it. ACTH, SIADH, neuroendocrine goo. I cracked myself up. I don't know why. But yeah, adeno, what's there to say about adeno? It's the most common overall, especially in non-smokers. In fact, don't smoke, guys, because if you go to your doctor's office, they're going to be like, do you smoke? And if you don't smoke, you're probably not going to have squamous cell carcinoma, right? So you're saving yourself a whole form of cancer just by not smoking. So please don't do it to yourself. Unless you have ambitions to take over Europe or conquer Ukraine or some other territory, in which case, smoke all you want. I digress. I'm just trying to think like, what advice would I give to young Hitler? I'd probably be like, yeah, smoke all you want, man. Okay, I should probably just stop this train of thought right now. Anyways, adenocarcinoma is the most common lung cancer overall. Large cell carcinoma, undifferentiated, often peripheral. It's super aggressive. That's large cell. And like lymphomas, those can involve the hilar nodes, but you'd have like systemic B symptoms. Are you familiar with the B symptoms? Like night sweats, weight loss, lymphadenopathy, all that stuff. But smoking really makes the primary lung cancer diagnosis a lot more likely than like a lymphoma. So yeah, squamous cell, central lung cancer, strongly associated with smoking, can cause bronchial obstruction as well, and that could lead to things like post-obstructive pneumonia. But OMG, what's post-obstructive pneumonia? Well, that's an infection that develops in the lung tissue distal to the blocked airway. So it's usually a tumor, but it could be something else, a structure, foreign body. By the way, I have trained an AI model on everything you need to know for step one using widely available step one materials. And so all of these explanations are going to be deliberately curated so that they are high yield for you. And I'd be happy to go into that in another video, but the resources that you're seeing here, I'm not just saying airway obstruction for no reason or distal infection stuff. The only reason you're getting these associations, central lung cancers, squamous and small, because they are important and will be tested on step one. I'll never tell you anything besides my random funny asides and memes that is not high yield for step one. At least that's my goal. And please call me out on that and give me feedback. I love the feedback. All right, moving on. The big clue for the exam is pneumonia that keeps recurring in the same exact location. Over and over again, definitely think post-obstructive pneumonia. So you might see in the proximal right middle lobe bronchus. So you get that pooling in the post-obstructive pneumonia right there. All right, leaving the explanations on the screen for a second there for you. All right, question 86. We got a researcher. This is you. We're studying nerve regeneration in lab rats. Group A receives a crush injury to the sciatic nerve, and group B has the optic nerve. So already what's coming to mind? Sciatic, peripheral, optic, central. At the end of the study, histological examination reveals robust axonal regrowth and remyelination in group A. That's because it's peripheral, but no regeneration in B. What best explains this is the axonal regrowth is inhibited by the CNS glial-derived proteins. So the optic nerve is part of the central nervous system, and it's myelinated by what? Oligodendrocytes. And those guys release inhibitory molecules. You don't need to know those, but like NOGO, A, MAG, all that stuff. And they block axonal regeneration. Basically, some nerves regenerate and some can't. CNS axons will fail to regenerate every single time. You might say, oh, well, the optic chiasm is crossing, but who cares? The axons can't regenerate long before that. So it's not anything to do with neural crest cells either. The PNS, peripheral nervous system, neurons and ganglia are neural crest derived. But the optic nerve is CNS. It's from the diencephalon, the neural tube. So kind of different embryological origin there. And it's pretty much all there is for this one. CNS axons don't regenerate because they're myelinated by oligodendrocytes, which release inhibitory factors, unlike Schwann cells in the peripheral nervous system that can promote regrowth. And you guys might be wondering, okay, why though? From an evolutionary perspective, doesn't it make sense to just always be able to regrow? For my undergrad at Harvard, I studied evolutionary biology and happen to know a little bit about this. Basically, evolution has decided stability should be prioritized over regrowth for the central nervous system. Think about the peripheral nervous system, right? You need to regrow it. You get your limb chopped off. Ouch. You get it crushed, right? A crush injury. We have to regain the movement of our periphery, right? So the Schwann cells go to the rescue. But the CNS, there you have tons of billions of connected neurons. And if you regrow them, all of a sudden my eyeball is connected to my elbow. Not good. You could even get hallucinations, seizures, all that stuff. And so yes, if there were some divine technician that could come down and rewire you, then yes, it's a great idea to regrow them. But in an evolutionary landscape that's prone to mistakes, miswiring, aberrant circuits, and wasted energy on inaccurate repair can all take place. And so Azathoth, or whoever made you, random chance by natural selection, has decided it's in your best interest not even to mess with that. So that's the evolutionary mechanism behind CNS and PNS design trade-offs. Cool beans? Okay, there's the explanation for you. All right, and it's all about the myelination patterns, right? Myelination patterns, the inhibitory proteins of the CNS. You learn something new every day. Kind of fun, kind of quirky, kind of cool. All right, the demographic that you might see in the next question could be man, woman, elderly. Basically what USMLE was trying to do for this topic, at least, is they're trying to say, hey, how could we get somebody in a demographic for colon cancer? And so that's why I've given you this woman up here who meets that criteria maybe. So in our question that I've made myself, we have a 66-year-old man presenting with progressive fatigue, vague abdominal discomfort, decreased appetite over the last 4 months, dark stools, unintentional weight loss, so cancer. Oh, wow. 50-year smoker and alcohol consumption. Hemoglobin is 8, hematocrit 26. Look at that mean corpuscular volume. Normal AST, ALT, ALP. Platelet count is crazy high. Which organ is most likely involved in the metastatic spread? Okay, so the answer is the liver, and let's talk about why. Our labs show us colonic adenocarcinoma, and colon cancer most often metastasizes first to the liver. And how does it do that? Well, there's this awesome thing called the portal venous system, and GI blood will drain and you'll go from the superior inferior mesenteric veins to the portal vein to the liver. And so the colon cancer can metastasize and the liver will get that metastasis. So the liver metastasis is more common than primary liver tumors. Like, for instance, hepatocellular carcinoma. It's even more common than that, right? Now, why is it not the brain? That's the site for lung melanoma and renal metastasis. Why not the lungs? That's common for sarcomas and renal, but colorectal drains from the liver. Skin metastasis is rare, seen in melanoma and breast. And then the bone, typical prostate, breast, and lung. So basically, the hard part about this question is the liver is the most common site for metastasis of the GI cancers. And the reason why, I'll explain here. So blood from the colon and the rectum drains into the SMV, drains the right colon, the IMV drains the left, and they both join the portal vein to the liver. So basically, all these tumor cells are going to be shedding in the venous blood and going straight to the liver. It's the first pass filter. The liver obviously has a huge blood supply, 25% of your cardiac output, and it's got some leaky stuff to it, the fenestrated sinusoids. And you've got some growth factors there, and so it's really good for tumor growth. Now, lung cancer spreads to the brain, adrenal, and bone, right? Because there we have systemic venous return to the rest of the systemic circulation. Prostate and breast, there you have bone metastasis that's common, just because the microenvironment there is really nice for it. And melanoma can spread everywhere. Skin, brain, liver, lung. But how do you know that granny has cancer? Well, I told you about the age, right? So we had cancer risk at that age anyways. And then there's constitutional symptoms, right? We get the weight loss. There's also GI symptoms, the chronic constipation, maybe you'll see. And you could even inspect it and they'll show like some sort of a mass and it'll be like a firm rectal mass. But also look at that MCV, right? Also look at this MCV. Now, in elderly adults, this is iron deficiency anemia until it's proven otherwise. So in this setting, the occult blood loss is from a colorectal tumor, right? That's the number one cause. And if it were gynecological in nature, then you wouldn't find the rectal wall tumor either. If it's hematologic, think a lymphoma, for instance, then the mass would not localize so clearly to the rectum and the labs would be a little bit different too. So you see rectal colonic mass, iron deficiency anemia, and weight loss, that's colonic, And then you think the number one metastasis site is the liver. So that's the answer. All right. Look, I found a picture of you on the web. A research team is developing novel vaccine against smallpox influenza type B using capsular polysaccharides to enhance immunogenicity. They're testing several conjugation strategies in mice. One formulation combines polysaccharides with bacterial protein recognized by toll-like receptor 5. What's the outcome of this approach? Well, the answer is increased switching to IgG via T-dependent activation. Now, the problem here is that polysaccharides like Neisseria meningitidis, or rather the capsule that they possess, by themselves will have T cell independent antigens. So they activate the B cells directly. But the response is mostly IgM, right? And that's short-lived, there's no memory of it. So to get IgG class switching and memory, you need T cell help. So how do we get those T cells in there? Well, we're going to conjugate the polysaccharide to a protein carrier. And the question is, which protein carrier are we going to use? Well, we want something that's strong, immunogenic. We want something that activates antigen-presenting cells, and something that stimulates T helper cells, because that will promote B cell class switching to get that stronger response. And so we conjugate it to flagellin. Toll-like receptor 5 ligand provides T cell dependent antigen presentation and innate immune stimulation. It promotes the class switching, memory B cell formation, and higher titers. It's perfect. Enhanced IgA is mucosal. IgA is good for that, but we're targeting the IgG. Cytotoxic T lymphocytes, cytotoxic 8, think MHC1. So polysaccharides don't enter the cytosolic pathway needed for CD8 positive T cell activation. And immune tolerance, repeat exposure without co-stimulation. That's when you should think of tolerance. And antibodies without T cell involvement. Why would you need that? That's what we're trying to solve. So it would be E. And so basically these pure polysaccharide vaccines, like those that are used against meningococcus, they don't work very well in infants. And that's because they only trigger a very weak IgM response with no memory. But if you add a flagellin, then the whole thing will be treated like it's a protein antigen. And now if it's a protein antigen, the B cells can be like, oh my gosh, let me show this to my MHC2 buddies. And then the T helper cells are going to be like, oh my gosh, let's do a helper response. Oh my gosh, let's make IgG. And that's how we get that reaction. And toll-like receptor 5, that's just icing on the cake. It's not going to be other stuff like dinotrophenol. That's a toxic mitochondrial uncoupler. You wouldn't just use like a sugar, because sugars will just stabilize things. And lipopolysaccharides are immunogenic, but they're too toxic, and sometimes they can share epitopes with host cells. So you would not necessarily want to use a lipopolysaccharide. Palmitic acid is just like a common, lactic acid or fatty acid. Those aren't immunogenic. So yeah, just look out for something immunogenic. something that would help with this situation with the TLR5 ligand, causing the T cell dependent reaction, and flagellan's perfect for that. You get class switching, memory formation, and all that good stuff. Now, this next demographic is probably going to be elderly. It could be a man or a woman, for instance, like what we see up here, who just falls. They could have an anterior trochanter fracture, something like that. And the problem is they've got their like a shortened externally rotated leg or some sort of a hip fracture. And there's a mnemonic that's super helpful for this. P-go-go-Q. P stands for piriformis. G is the gemellus superior. O stands for obturator. G is another one of the gemelluses. I think it's like gemellus inferior. O is also the obturator, but this one's the externus and this one's the internus. So it's the obturator, gemellus, obturator. So G-O-G-O. Q is quadratus femoris. Okay, so P, go, Q. That's the mnemonic. And those are the lateral rotator groups. And they all insert around the greater trochanter, and they're the prime movers for lateral rotation. So here we have a 68-year-old man, difficulty walking, left hip pain after slipping while getting out of the bathtub. His left leg is shortened, so lies externally rotated compared to the right. What contributes to the external rotation of the thigh and may be impaired? Obturator externus would be on that list of P-go-go-Q. And that's all there is to it. Gluteus medius is abduction, because usually people say maximus, and it's abnormal if you say medius. That's how I remember it. Sartorius, Taylor's muscle, hip flexion and knee flexion. Vastus lateralis, knee extension. Adductor longus, well, adduction. So yep, fractured hip, it'll rotate your entire leg out like it's a broken hinge. All right, next our demographic is going to be some young boy or young girl. In this case, we have a young girl who's brought to the clinic after collapsing during a school choir rehearsal. She has no prior medical history, but has required hearing aids since infancy. On exam, she's alerted with normal vitals. Her ECG shows a QT interval of 520. Genetic testing reveals mutation in a gene involved in cardiac repolarization, which the following best describes mutated protein. All right, this is Jivelle Lange Nielsen syndrome. It's congenital long QT syndrome caused by mutations of the voltage-gated potassium channel. So here's our explanation, and you might be wondering, why is it potassium? Well, normal cardiac repolarization has outward potassium currents, and if the potassium channel function is defective, then it's delayed repolarization, and delayed repolarization has a longer QT interval. And so the prolongation predisposes torsade de pointe, syncope, or sudden death. And what's with the deafness, right? The inner ear cells also rely on potassium channels. That's what's interesting about this condition. And they recycle the potassium to the endolymph, which is, just like the fluid in the membranous labyrinth of the ear. And there's dysfunction there, right? So you have congenital sensory neural hearing loss. And this is autosomal recessive, where you have the cardiac problems and you also have the ear problems. There's also another variant of this that's called Romano-Ward, which is autosomal dominant, and that's only involving the cardiac. There's no hearing loss with that one. And they're going to try to get you with all sorts of answers for this one. They could ask about neurotransmitter calcium, for instance. And that can be implicated in epilepsies and some arrhythmias, but definitely not long QT syndrome. They could try to get you talking about cholinergic receptors. That would be the parasympathetic slowing of the heart rate. And that's just not related to QT stuff. They'll get you about gap junctions. And that's involved in propagation, not repolarization. And it's not beta adrenergic, because that could exacerbate it, but the receptor is not mutated. All right, so there you go. Hopefully this has been helpful. These are 10 more questions. If it was, just like and subscribe. Let me know how I can improve. Do you guys like this demographic image for each question? Would you like for it to pertain exactly to this question, or just general demographics so that I can generalize these questions better and open up the conversation that way? Let me know what you think, and we'll see you guys in the next video. Hello, everybody. Today we're going to be continuing with NBME 29. This takes so many hours of work. If you're benefiting from this, please like and subscribe. My goal is to help you pass step 1. Here we go. In our first question, we have a 60-year-old man, comes to the emergency department due to hematemesis, reports progressive fatigue and early satiety. He has a history of alcohol use disorder. On examination, he has distended abdomen and shifting dullness with multiple spider angiomata on his chest. Lab studies show mild thrombocytopenia, and hypoendoscopy reveals prominent gastric varices. Imaging shows splenomegaly and a nodular liver. Increased venous pressure, in which the following vessels is most directly responsible for the formation of gastric varices. So here are the answer choices, and the answer is indeed the left gastric vein. And they can ask this several ways. Middle-aged, older man, he's going to have alcohol use. That's guaranteed, right? Why alcohol use? Because that increases the risk of cirrhosis. And on exam, you see the spider angiomata, the hard nodular liver stuff. That means cirrhosis. That's step 1's way of being like, dude, this guy has a cirrhosed liver. And on CT, you see a mass in the liver. Anytime you have a mass in the liver, what does that mean? Well, that's going to be a possible hepatocellular carcinoma, which is also commonly seen in cirrhotics. And so they'll ask, hey, which vein is going to be developing the hypertension due to this cirrhosis? In order to answer this question, we have to know a little bit about the portal venous anatomy. Let's just call this your liver right here. And plugging into this liver, we have got a portal vein kind of running along like that. So yeah, that's our portal vein. And again, this big thing right here, this is the liver. Here's like our portal vein. Going off of that, you can have this, which is known as the left gastric vein. And of course, this right here is our pancreas, which makes this right here the superior mesenteric vein. Then you have, like your middle colic, your right colic, jejunal, ileal veins. Here's your inferior mesenteric vein. And of course, your splenic vein, which takes you out to your spleen. But right here, that right here is the left gastric vein. And so the portal vein is formed by the splenic vein, superior mesenteric vein, right there. So there's our splenic vein, superior mesenteric vein, and the left gastric vein right there. That's what forms it. And these tributaries include the short gastric veins, right? Those drain into the splenic vein. Anything draining into the portal vein is going to be subject to portal hypertension. And that's because this big old liver right here is cirrhotic. How do we know it's cirrhotic? Because he's an alcoholic, and also because of spiderangiomatous and hard nodular liver. Also, the mass tells us hepatocellular carcinoma, and a common cause of hepatocellular carcinoma is cirrhosis. And so they're going to try to trick you in various ways. They might say like, oh, the hepatic vein. Well, that drains out of the liver into the IVC. And so that's a little more like Budd-Chiari syndrome, the hepatic vein thrombosis, not cirrhosis. All right, so they might try to trick you like that. In our answer right here, we know the left gastric vein drains both the lesser curvature of the stomach and the lower esophagus. And portal hypertension, increased resistance, causes the backup there, causing those varices. Short gastric varices, which also contribute to gastric varices, drains to the splenic vein, which joins the portal vein. The left renal vein would be nutcracker syndrome. Hepatic vein is, as we mentioned, Budd-Chiari syndrome. Right suprarenal drains the adrenal gland, and inferior phrenic drains the diaphragm. So if they try to get you on like renal vein, then you should say, no, that's not the answer. Why? Because that drains the kidney into the IVC. One thing we do know is that this short gastric vein, that drains into the splenic and the portal vein. And so that's affected in portal hypertension. And so you get the high pressure right there. All right, for question 92, I wrote down the word infusion because that's the most important part of this question. We have a 22-year-old female who collapses after a marathon. Look at that blood pressure, super low, neck veins are flat. But then we give her isotonic saline and the heart rate drops to 92. Blood pressure improves to 105. What best describes the new hemodynamic state on the graph showing cardiac and vascular curves? Well, it's going to be the same cardiac function curve, but the vascular function curve is shifted to the right. Now, in our question, we have a 22-year-old female, but you can also have a male as well. Totally fine, demographic-wise. Basically, we have a young trauma patient with large blood loss and hypovolemic shock. The findings then would be tachycardia, hypotension, and lacerations with hemorrhage. Right? That's typically how this could present, or they could just be dehydrated. And then for management, you give them a rapid infusion. You do volume resuscitation. And what happens in hypovolemia is you have a decreased preload, right? That's the right atrial pressure. And you also have a decreased stroke volume and cardiac output. And so the body, how's that going to compensate? Well, the body's going to compensate with increasing your heart rate, increasing your arterial constriction, systemic vascular resistance. But whenever you give fluids, you're increasing the blood volume, right? So you're increasing the mean systemic filling pressure. And on that vascular function curve, it's going to shift it to the right since the venous return improves at any given right atrial pressure. So it's like we have your cardiac output here, you have your central venous pressure right here. And it's like this on the continuum. You start here, you end up here. You go higher in both. The contractility does not change though, right? You get a healthy heart, there are no inotropes that are given. So the curve is going to stay on that exact same line. But the new intersection point is going to move up along the cardiac curve. So you have a higher right atrial pressure. Why do you have a higher right atrial pressure? More preload. There's also higher cardiac output, right? That's the Frank-Starling mechanism. And there's no change in the contractility. And so you're just going to be on that same kind of curve line with the pressure increased and the cardiac output also increased as well. And it's increased because of the Frank-Starling mechanism, right? The contractility being lowered would be like if you were on a different line. So basically the high yield takeaway here is that fluids cause a rightward shift of the vascular function. Inotropes cause an upward shift of the cardiac function curve. Venodilators cause a leftward shift of the vascular curve, and hemorrhages cause a leftward shift as well on the vascular curve. All right, so that's the high yield takeaway for this graph. Okay, next we have a 24-year-old woman. It could also be a young man as well. So we have both represented in the demographics. Presenting with painful swelling of her left forearm 3 days after scraping in our rock climb. Exam shows erythema, warmth, and purulent drainage from the 2 centimeter area. Biopsy reveals an abundant neutrophil in adjacent vasculature, but limited infiltration into the tissues. Further analysis shows reduced endothelial expression of a molecule normally upregulated by TNF-alpha and IL-1 to mediate leukocyte rolling. Which of the following molecules is deficient? All right, so those are the answers. Now, what I want to teach about this question is you might have all sorts of things. An infection, an abscess from a splinter, right? And what's happening is we have neutrophils and also other leukocytes. They have to leave the bloodstream and enter into the tissue, right? And by the way, neutrophilic is just something that is stained by neutral dyes. That's why they call it neutrophilic. These are the white blood cells that are important in the immune system that help to fight your body's infections. And usually you have neutrophilia in infections, inflammation, and other neoplastic processes. So like, cancers can cause them. Think like chronic myeloid leukemia as well. Tumors can cause this. Basically, they are the key components of the immune system, the first responders to infection and inflammation. But you can also see them elevated in cancer and due to stress reactions in certain medications. So they're elevated in a whole lot of things. So basically, our neutrophils and our leukocytes leave the bloodstream. They have to enter the tissue. And this question is essentially asking which adhesion molecule first tethers the leukocytes to the endothelium. So we have to know the leukocyte extravasation sequence. It's super, super testable. I've drawn this a couple times, but first is margination and rolling. And there we have the selectins. So you have E-selectin, P-selectin on the endothelium, and it binds Ciala-Lewis on the leukocytes. And that way it can roll along the vessel wall. So if you know that, you know this answer, and you got it. Tight adhesions is the ICAM, the VCAM. Those bind the integrins. And there you think LFA1, MAC1, VLA4 on the leukocytes. That's the ICAM, the adhesion. Then you have transmigration, also known as diapedesis, that happens with PCAM. That's CD31, which, if you guys know my PEG system, is MAT. And so I imagine him rolling out a mat and then just passing right on through the endothelial cells, because that's what diapedesis, like transmigration, is. And then we have, last one is the migration to the actual site. And that's the chemotaxis. And chemotaxis is directed by IL-8. Also C5a, they love that one for some reason. LTB4, and kallikrein is the last one that they'd ever ask you about. All right, so those are the steps. So we know our answer is selectins. And they could ask you all sorts of things. Here's some examples. The integrins from adhesion, not rolling, you're integrating. Collagen, structural, not involved in the recruitment stuff. Cadherins are the cell junctions, not immune stuff. Matrix metalloproteinases degrade ECM. So yeah, this is essentially a question about the molecular Velcro. It slows down the white blood cells before they fight the infections. You have to know that's the selectins. Cadherins, they help with the adhesion between epithelial, so like the zona adherens, desmosomes. That's more of the cadherin job, so it's not the right answer. Extracellular matrix proteins, that's like the collagen, fibronectin, laminin. That's scaffolding. All right, we're not talking about the scaffolding here. We're talking about the selectins, the Velcro that helps the leukocytes come on in and stay there. G proteins are for intracellular signaling. So yep, we're talking about the rolling step, the rolling phase. All right, here we have a 28-year-old woman found being stranded in the mountains for 6 days. Just so you can see, there are also other demographics it could be. Here's a man. He's also been stranded. Access to melted snow, but there's no food. So she's got water, but no food. Which of the following changes is most likely occurring? Well, I've taken some notes here. We have water, we have no food. That means that we are in a starving state, right? So we're well past the glycogen depletion, because the glycogen stores are usually gone after like 24 hours. And the fuel use is going to change. The brain relies on glucose and also ketone bodies. Muscles and other tissues rely on fatty acid oxidation. So the pathways that are upregulated would be gluconeogenesis, because that's how we're going to make new glucose if we don't have any. Lipolysis and also beta oxidation. Maybe also ketogenesis and protein catabolism, because that will provide us with our gluconeogenic substrates. And the downregulated pathways, because these guys are upregulated, would be your glycolysis, glycogen synthesis. It's already exhausted, right? Fatty acid synthesis and protein synthesis. And how they're going to get you is they're going to ask about these intermediates and substrates. They're going to say, okay, would this be elevated or not? Now, you guys are probably looking at this one from your MCAT days and saying, I've seen that before. Well, that is going to be downregulated. That normally activates glycolysis through PFK1. And in starvation, we suppress that, right? So we're going to bring that down. What about pyruvate kinase? Well, that is the last step of glycolysis, and so that's also going to be down. It's suppressed so that the substrates can go into the gluconeogenesis instead. And then there are some other steps that are involved in gluconeogenesis, right? And that's like glucose-6-phosphatase. That's going to be upregulated. That's the final step in gluconeogenesis, right? That's where you release the free glucose into the blood. And PepCK is the key step in gluconeogenesis as well. So PepCK is going to be elevated, whereas the other guys are going to be decreased. So prolonged fasting, the liver shifts toward the glucose production and also export, not utilization. And so the key aspect of this topic is knowing that PepCK and glucose-6-phosphatase are upregulated, and glycolysis enzymes like pyruvate kinase, PFK1 through fructose 2,6-biphosphate are going to be downregulated. So downregulated, upregulated, glycolysis, gluconeogenesis. And so our answer is increased phosphoenol pyruvate, PEP-CK, and glucose 6-phosphatase. There we go. The answer is D. Pyruvate kinase and fructose 2,6-biphosphate promotes glycolysis. Malonyl-CoA is seen in the fed state, downregulated in fasting. Suppressed G6PAs, well, that's needed to release the glucose in the bloodstream so you can't depress it. High citrate builds up only in high energy fed states. So yeah, your liver actually kind of turns into like a glucose factory after 24 hours of not eating. Your liver's like, let me fix that. So your body's starved of food and it just adapts. Your hormones just change and it just flips your metabolism around. No big deal. All right. In our next question, we have a 35-year-old woman presenting with fatigue, blurry vision, and persistent dry cough. She has recent joint stiffness and painful red nodules in the shins. I'm also giving you this demographic because I think it's super important to also know for test A. Her temperature is 99.5, blood pressure is 120 over 76. Ophthalmologic exam shows anterior uveitis. Bilateral hilar lymphadenopathy is present. We also have elevated ACE levels. Transbronchial biopsy revealed well-formed non-caseating granulomas. This should all be making us think of sarcoidosis. Bilateral hilar lymphadenopathy, uveitis, erythema nodosum. Are you kidding me? This is sarcoidosis 100% of the time. Now, what's the predisposing factor? Well, anytime you see a patient with bilateral hilar adenopathy, lymphadenopathy, and maybe they'll have like a paratracheal enlargement, and on biopsy, they're always going to show you non-caseating granulomas. What they're trying to tell you, they're just screaming it out to you, is sarcoidosis, okay? There's some key diagnostic features for sarcoidosis. Non-caseating granulomas, bilateral hilar lymphadenopathy, and African American population, and also women. Those are the most important things to know. You should also know outside of that it's like 20 to 40 years old. I've never seen a question where they're not. African American, women, 20 to 40, bilateral hilar lymphadenopathy and non-caseating granulomas, just literally click sarcoidosis. It is right every single time. Anytime you see those patient characteristics, it's going to be sarcoidosis. Now, the manifestations are uveitis, erythema nodosum, hypercalcemia. And the hypercalcemia is interestingly from increased alpha hydroxylase activity in the macrophages. And I think this is an important mechanism to know. The macrophages increase alpha hydroxylase. And you could also see restrictive lung disease if it's chronic as well. And so what I'm doing here in this question is I'm just teasing out these risk factors, which are super high yield in the exam these days. Sarcoidosis, non-caseating, hypercalcemia, female sex, it's all strong. Bird exposure is hypersensitivity to pneumonitis. Smoking is not a risk factor for it. In fact, it may actually be protective. Northern European ancestry is not it. It's African American ancestry. And travel to Arizona is coccidiomycosis, caseating granulomas. Now, sarcoidosis is often called, interestingly enough, the great mimic, because it can resemble like everything from like lung cancer to tuberculosis, honestly. Okay, next we have a 13-year-old boy recovering after surgery for a displaced supracondylar humerus fracture. His arm was immobilized in a long arm cast for 4 weeks. After follow-up, he reports difficulty performing push-ups, which he used to do them easily. Physical exam reveals visible muscle thinning of the triceps and deltoid. Which of the following is most likely observed? So we got a young kid, forearm fracture, immobilized, and a cast. And then 3 weeks later, the muscles are no longer going to be used. What happens to these immobilized muscles? For this one, we have to talk about use and disuse. So active, loaded muscles have increased metabolic rate, increased mitochondrial activity, and also increased angiogenesis, and that's through VEGF. You also have increased capillary density, and you have increased local vasodilators like adenosine, lactate, CO2, hydronium ions, right? So you're going to have like increased blood flow. If you're inactive, then you kind of have the opposite. You have decreased trophic stimulation. There's another word for that would be like you have atrophy, increased atrophy. You also have decreased metabolic demand. There's atrophy of the sarcomeres. And most importantly, we decrease your VEGF. There's decreased angiogenesis signals. There's decreased capillary density. So he has his arm immobilized, and the answer is going to be microvascular density. So yeah, you just hold your arm like this, don't even move it, put it in a cast 3 weeks, your muscles are going to shrink, and also the blood supply does too. It starves your muscles. Now, these other answers are interesting. Increased mitochondrial biogenesis would be like if you're training for a marathon, doing endurance training, you could see that. Increased tissue oxygen extraction would be ischemia. HIF, 1-alpha expression, hypoxia. That's when it's not reaching the tissues. And increased intracellular lactate would be anaerobic glycolysis. That's wrong because inactive muscles don't perform anaerobics. Next, we have a 24-year-old man with recurrent generalized tonic-clonic seizures that began 3 weeks ago. Immigrated to the United States from Guatemala. Denies any history of trauma, substance use, or past medical issues. Neurologic exam is unremarkable between episodes. Non-contrast CT of the brain reveals multiple cystic and calcified lesions scattered throughout the cerebral cortex, some with central dot-like structures. Blood tests are normal except for mild eosinophilia. Which of the following is the most likely causal organism? You could also see this in old, young, male, female. And so here I have a young female. This person is usually going to be an immigrant of Guatemala, Mexico, something like that. So multiple cystic calcified lesions, central dot-like structures, and their new onset seizures. Usually the most important things to know about this particular issue is that they're going to be previously healthy. They're from Mexico or Guatemala. They're an immigrant essentially. And then out of the blue, they have some short amount of time where they start to get seizures. And then the CT of the brain shows multiple calcified nodules and also some cysts. So cyst and nodule. Everything else is pretty normal. So it's really that multiple cystic and calcified brain lesions that's in somebody from Latin America that tells you it's neurocystic keratosis. So watch out for that dot sign. Tinea solia, it's the larvae that are responsible. And the seizures are common due to the inflammatory response around these cysts. So the cysts get all ugly, inflammation happens, you have 1 week of just seizing in a previously healthy person from an endemic region, and also you have some nodules. That's pretty much all there is to know about tinea solium. Now they'll try to confuse you, and they'll try to make you think of other conditions like Cryptococcus neoformans, but that one is not going to lead to the symptoms we see in this patient necessarily. Rather, it leads you a little bit more toward meningitis. And that's usually in immunocompromised individuals, not previously healthy people, and definitely you're not going to see multiple cystic lesions. Herpes simplex virus would cause encephalitis, and that's usually in the temporal lobe, necrosis. And HIV predisposes you to opportunistic, so CNS infections. Listeria causes meningitis and abscess. Streptococcus pneumonia, that's meningitis. Toxo would have multiple ring-enhancing lesions in immunocompromised. You have to know that this is a previously healthy child. All right. Or a previously healthy 24-year-old man. Started 3 weeks ago. All right. Here we have a 28-year-old woman. It could also be a 28 or something-year-old man. Just showing you a different demographic. Could be nearly anybody. Nasal congestion, watery rhinorrhea, sneezing for the past couple of days. The symptoms occur every April and October. Okay, so some allergies. You have boggy, pale nasal mucosa with clear discharge. She wants immediate relief for the upcoming job interview. What drug are you going to give her? Probably phenylephrine, short-term relief. Kind of contraindicated in the elderly because of Beer's criteria. Short-term relief would be an alpha-1 adrenergic agonist. So there's our answer B. And the pathophysiology is interesting here. In allergic rhinitis, you have histamine release and parasympathetic activation. And that causes vasodilation and increased secretions of the nasal mucosa. And so for treatment, long-term, you give them intranasal corticosteroids like oral intranasal antihistamines. So you stop those histamines from spreading out. And short-term, immediate relief, you give them an alpha-1 adrenergic agonist. That could be topical oral decongestants. So alpha-1 adrenergic agonists would be like phenylephrine, zoline, pseudoephedrine. Those are alpha-1 activators, vasoconstricting. And so they constrict on that nasal mucosa, and you get decreased edema, decreased secretions, and rapid relief. You also have alpha adrenergic antagonists, and those guys would cause, vasodilation, and that would make things worse. Beta adrenergic agonists, like albuterol, use this for bronchodilation for asthma. Beta adrenergic antagonists would be like propranolol. Nicotinic cholinergic agonists would be like nicotine. That would not even help. So our answer is indeed going to be B. Well, the muscarinic antagonist would have a drying effect, but wouldn't have that relief. It's more used for COPD. H1, histamine receptor antagonism, used for itching and sneezing, slower onset, not ideal for acute relief. Leukotriene, montelukast, used for asthma, not fast acting, and a corticosteroid nasal spray would be long-term control, slower. So a lot of people have allergic rhinitis. The reason why is because that springtime pollen will hit. And so, you got to get some sort of relief. So you got to constrict that nasal mucosal vessel. All right. So here we have a 31-year-old woman with a history of poorly controlled type 1 diabetes, evaluation of chronic bloating and early satiety. It's not specific to female. So I've given you a male over here as well. She started on a new medication that binds to receptor in the smooth muscle of the upper GI tract and improves gastric motility. What describes the mechanism? All right, so we're increasing the contractility of the stomach. Well, there's this thing called the migrating motor complex, the MMC, and that causes the waves of the electrical and contractile activity that occur during fasting about every 90 to 120 minutes. And so the function is going to be it clears the residual food and bacteria between the meals. It's like a housekeeping. And motilin is the hormone that initiates that motor complex. It activates the G protein coupled receptors. It increases the gastric contractions, the antrum, the fundus. It stimulates the peristalsis of the small bowel. And so clinically, like erythromycin, which is a motilin receptor agonist, is used to stimulate the gastric motility. So our answer is B, the activation of the motilin receptors. Gastroparesis, diabetes, impaired MMC, motilin, agonists like erythromycin stimulate it. D2 antagonist, metoclopramide acts this way but causes extraperitoneal symptoms like tardive dyskinesia. It improves motility indirectly, not through the MMC. 5-HT3 blockade, ondansetron, does not stimulate motility, but it does block the emetic pathway. Hydronium potassium ATPase inhibitor, proton pump inhibitor that reduces the acid on the motility. CB1 promotes the hunger. So basically for this question, we need to know that your stomach has its own cleaning cycle every 90 minutes or so. When you're not eating, there's this migrating motor complex. It's powered by motilin, and erythromycin can actually mimic that. So serotonin is more of a modulator of, like that 5-HT, your motility and secretion, but the effects are going to be super broad and stuff. The direct triggering of the MMC, like this question's asking, is going to be motilin. Norepinephrine would be sympathetic, that would decrease motility. Acetylcholine would be a vagal parasympathetic, so it would stimulate secretion and motility, but it's not going to be the most specific example. Bind to the smooth muscle of the upper GI tract and improve the motility. Motilin. 28-year-old healthy man is hiking a mountain lodge situated at elevation where the atmospheric pressure is at 600. Alveolar carbon dioxide partial pressure is 40. Respiratory exchange is 0.8. What is his estimated alveolar partial pressure? All right, so breaking this down, atmospheric pressure is 600. That's where like our altitude is. Fraction of oxygen and ambient air is 0.21. And this is going to stay constant at altitude. The water vapor is constant at 47. So you would subtract that from atmospheric pressure. And then we use the alveolar gas exchange equation, which is going to be this guy right here. So we just plug it in to our equation and we get 66. And we have to subtract the water vapor. That's like the only hard part of this is subtracting the water vapor. And you get 66. Now, I hate this because it's a lot of just memorization, right? The big thing to know is that the fraction of inspired oxygen in room air would be 0.21. You just have to know that. The issue of the water vapor pressure at the body temperature is 47. That's what you need to know. If you know that, you're good to go, okay? These two variables are worth memorizing. And with that, we'll see you soon for the rest of the video. Hello, everybody. NBME 29, question 101. All right, this is an ethics question. We need to make sure that we always validate the emotions. Okay, so here's your practice question. 23-year-old college student is brought by his sister due to changes in behavior the past 8 months. She reports he has isolated himself, stopped attending to classes, and frequently mumbles to himself in his room. He has not bathed, he's unkempt, makes erratic eye contact. His sister begins to cry, saying, "I don't even recognize him." Which of the following is the most appropriate initial response by the physician? The answer is, that must be incredibly difficult. Can you tell me more? Always validate first, right? Whenever anybody describes emotion when discussing a medical concern, the physician should always be like, I agree that it's X emotion that you're feeling. Always validate. After you validate, then you can start to ask the open-ended questions. Okay, they're the trap answers why they're wrong. So here are some notes. Validate emotions, ask open-ended questions, don't jump to diagnosis, don't offer judgmental advice, like, oh, you need to shower. Also be on the lookout for positive symptoms of hallucination. Negative symptoms would be the poor hygiene, social withdrawal. Schizophrenia would have both clusters over 6 months. All right, next we have a 73-year-old man, but it could also be a woman. Here I have that in my demographic photo. Coming for routine evaluation, reporting no significant complaints. Lab shows an M spike of 2.1 on serum protein, electrophoresis, bone marrow biopsy shows 5% plasma cells. His hemoglobin is 13.2, calcium 9, creatinine is 0.9. He denies bone pain and fatigue, weight loss, has no lytic lesions. Which of the following is the diagnosis? Correct answer is D, monoclonal gammopathy of undetermined significance. So there are some things that we have to kind of know here. The M spike would be less than 3 for this condition and also less than 10% of your plasma cells in the marrow. And most important, like on step 1, is to know these CRAB symptoms. You probably heard of CRAB, really good acronym. That's hypercalcemia, renal failure, anemia, bone lesions. He denied those things. It's super important that they mention that. And this condition is benign, but it can progress later on to a melanoma. It's about like 1% per year. There are some other answers like smoldering. And I'd say, okay, what's smoldering myeloma? That's an M spike that's greater than 3 grams per deciliter or greater than 10% plasma cells. And there you would have your CRAB findings, right? So it's all about that hypercalcemia, renal failure, anemia, and the bone lesion stuff. There's also Waldenstrom macroglobulinemia. And there you have an IgM spike, not an IgG spike. There you have like headaches, blurred vision, bleeding, neuropathy, that stuff. Chronic liver disease and chronic inflammation. That causes polyclonal hypergammaglobulinemia, not a sharp monoclonal spike. So what we're going to be doing on a question like this is we have to match it to the vignette, right? Here we have an M spike of less than 10% in the marrow and no CRAB features. Multiple myeloma has those lytic bone lesions, and you need greater than 10% of the plasma. Smoldering multiple myeloma would be asymptomatic with an M spike of greater than 3. Here we had an M spike of less than 3. Waldenstrom has a monoclonal IgM. You know that because the M there. Waldenstrom IgM hyperviscosity. And CLL would have the smudge cells. And the way I like to remember this one is, I can see clearly now the smudge has gone, right? I can see I always remember clean, clearly. Now the smudge is gone. Lymphocytosis with smudge cells. All right, so we got a 73-year-old, totally fine. But now we have an M spike, 5% plasma cells. There's no CRAB, MGUS. Early stage clonal plasma cell disorder. For management, it's just monitoring, labs and symptoms. No treatment is necessarily needed with this. It's monoclonal gammopathy of uncertain significance. So simply, just to make it really clear, anytime you see multiple myeloma, you should look out for CRAB symptoms. And also you need greater than 3 gram per deciliter spike or greater than 10% of the plasma cells. And also you need those CRAB symptoms. Smoldering is greater than 3 spike but no symptoms. Waldenstrom is an IgM spike, not IgG. Chronic liver disease and inflammation would have a polyclonal increase, not just one single sharp spike. So we got this disease, kind of harmless for now, but that's what's going on in this patient. Okay, next we are on 103. Here in a study of vascular permeability, researchers apply a mild heat stimulus on the dorsal skin of rats for 20 seconds and observe biphasic extravasation of the injected dye. First peak occurs in 20 minutes. Second, broader peak after 4 to 6 hours. Follow-up trial group of rats is pre-treated with non-sedating H1 blocker. Which of the following best describes the effect of the antihistamine? Okay, so basically after you get like a burn, you have 2 waves of leakiness, which is another word for extravasation, leakiness. There's an early one and there's a late one. This early one is just minutes after, and it's driven by mast cell histamine, and that is H1. That causes arterial vasodilation and venular endothelial gap formation. And so this causes the plasma to go ahead and leak out. Then there's this later peak that's hours later, and that's driven by the cytokine mediators from the damaged tissue, and it's recruited leukocytes. So like TNF alpha, IL-1, prostaglandins, bradykinin, all that stuff. So an antihistamine will block the early histamine mediator response, and it'll blunt that first one, antihistamine, and not necessarily this second one. Cytokine-mediated inflammation persists independent of histamine, preventing both peaks. Delays onset of the second peak. Cytokines are released. Attenuates only the late peak. Antihistamines do not affect prostaglandins and cytokines. Has no effect. Histamine clearly mediates the initial vascular response. So here's a little explanation if you want to pause. There's that first wave, second wave, first wave. Mast cells dump histamine, get dilation and capillary leakage, early fluid leak, and then cytokines TNF alpha show up. There's a second wave, right? So our first, histamine, mast cells, and then you have the swelling that's caused by the cytokines. Histamine, cytokines. All right, so in this next question, we need to know about the external iliac artery. There's the psoas major, there's our femoral artery, common iliac, external, inferior epigastric, and the deep circumflex iliac artery. There's this inguinal ligament here. Now, there are a couple of things. There's the uteropelvic junction. That's where the renal pelvis meets the ureter. There's the pelvic brim. That's where the ureter crosses the external iliac vessels. So, your renal pelvis, ureters, bladder, ureter, external iliac, psoas major. Just trying to show this from different angles. Uteropelvic junction right here, iliac artery right here. That's a good little drawing. So this uteropelvic junction, that's where the renal pelvis meets the ureter. You can see it right here. Uterovesicular junction, that's where the ureter enters the bladder. And then the pelvic brim is where the ureter crosses the external iliac vessels. All right, so those are kind of the big 3 sites, the ureter narrowing sites, and that's where the stones often will get stuck. And so in this question, they're going to be like, hey, we got like a stone. It's just chilling. It's above the sacroiliac joint. Okay, well, that's going to be the pelvic brim. And at the pelvic brim, the ureter crosses the external iliac vessel, and that is what narrows the passage. So here you can kind of see it in this photo. If I zoom in right there. See how it's kind of crossing right there, right at the pelvic brim, uropelvic junction. Yeah, this is a pretty good photo. You can kind of see these 3 distinct spots where it's going to be narrowed at. And those are the external iliac. So in this question, we have a 28-year-old G1PO, 20 weeks gestation, sudden right-sided cramping, flank pain, anterior thigh with nausea. No fever. Passes anterior to which structure? External iliac artery. Here's the explanation. We kind of looked over this together. But what there is to know is that the ureteral stones are going to get stuck at the 3 most distinct and kind of predictable choke points. Uteropelvic junction, the pelvic brim, uterovesicular junction. So it's where the ureter crosses the external iliac vessels, and then where the ureter actually enters into the bladder. Those are the 3 areas you should know. And so stones just above that sacroiliac joint, that's the pelvic brim. And at that pelvic brim, you're going to cross the external iliac vessel. Ta-da. All right, for this one, we're going back to the drawing board. We are on question 104. So let's talk about an ROC curve. So typically how this plays out is the y-axis. This is like the sensitivity. See how it says true positives? That's the same thing as sensitivity. X-axis is 1 minus the specificity, which is to say the false positive rate. And so, if it's higher up, then that means it's more sensitive. There are fewer false positives. And so if you're looking for like a fatal disease, the most important thing is you don't want to miss anybody who has it, right? You want that cut point to be at where the highest sensitivity is. If you pick a very sensitive cut point, then you're going to get more false positives that has lower specificity. And that's fine if you're screening because positives can then be confirmed with more specific follow-up testing. But false negatives, like missed cases being deadly, that's super bad. So on an ROC curve, like over here, would be the highest sensitivity. So if it's a serious disease, but it's treatable, definitely pick the most sensitive test. And you can remember this by, if it's sensitive, remember SNOUT. Sensitivity being negative rules out the disease. So here it says a new blood-based assay is being developed to detect an aggressive cancer that is asymptomatic early but rapidly fatal if not treated. ROC curve below demonstrates 5 potential cut points based on assay values. The goal is to use this assay for population-wide screening. Which cut point should be selected to maximize early disease detection? And then they're going to give you an ROC curve that kind of looks like this, and it's going to be the one that's highest up, right? Because that's going to be sensitivity. Sensitivity, if you're sensitive, it's truly a positive trait, right? In a person. You want somebody who's sensitive in a person, right? Well, it's truly a positive trait, so it's true positive. You want that to be as high as possible because SNOUT, if it's sensitivity, it has a high sensitivity, but it's negative, that rules out the disease, SNOUT. So the answer is E, which is right here, super high up. The other ones are going to be lower. Yep, ROC stands for receiver operating characteristic. You don't want somebody thinking that they're fine, but they're not if the disease is fatal. If it's not fatal, sure, it's fine. So that's the ROC curve. All right, here we have a 17-year-old male evaluated for academic difficulties and behavioral issues. His teachers report poor social interaction and repetitive speech. On exam, he has long, narrow face, enlarged ears, and macroorchidism. Family history reveals maternal grandfather with late-onset tremor and ataxia. We have a lot of these 250 CGG repeats. That was overkill of them to say. Which of the following describes the consequence of this mutation? It is the transcriptional silencing through DNA methylation. All right, so this, we move on, is Fragile X. The GG stands for giant gonads. That's the way to remember it. But it's a CGG expansion of the 5' UTR of the R1 gene, FR1. So that region becomes hypermethylated, and the methylation blocks the transcription factor, RNA polymerase access, and then the transcription gets silenced. So you decrease FMR1, mRNA. So you can remember this as like the giant gonads, the CGG, or you can say it causes it to go quiet. Causes gene to go quiet, FMR1, giant gonads, Fragile X. The phenotype is intellectual disability, long face, large ears. So maybe another way you can remember this too is the C kind of looks like large ears on a person. See like that? And then giant gonads. All right, so you kind of can imagine a person, and that's just the way that has stuck with me for Fragile X. It's not increased translation. It's not actually translated, it's silenced. Increased intron, splicing affects the mRNA, but the transcript's not made there. Incorporation, it's not applicable. It's in the non-coding region, never entering. Impaired nuclear export, there's no mRNA to export due to the transcriptional silencing. It's the most common inherited cause of intellectual disability. So the splicing defects, that's the intron exon stuff. mRNA degradation, that's poly A issues. Incorporation, the repeats are not transcribed at the mRNA. They're going to silence upstream. So like all these like repeats that you have, the repeats are not transcribed into mRNA. They just silence. So methylation would reduce the binding of RNA polymerase as well. Also, I realized that my photo was kind of blocking everything there, but hopefully you can see my notes here on Fragile X. And now I'm going to move on to 107. All right, here a 71-year-old woman is presenting with difficulty swallowing that began gradually over the past 3 months. She reports occasional coughing while eating and has unintentionally lost 4 pounds. She denies any odynophagia or regurgitation. Her recent medical history shows hypertension and remote history of rheumatic fever. Chest x-ray shows cardiomegaly with a prominent left heart border. Barium esophagram reveals posterior displacement of the mid-esophagus. Which of the following is most likely responsible for these symptoms? Okay, you have to know how the heart sits for this one. So I'm going to go ahead and give you the answer. It's the left atrium that's the most posterior chamber of the heart. It lies just in front of the esophagus and the mediastinum. And if the left atrium enlarges, for instance, if we were to have a dilated cardiomyopathy, right? If something like that were to happen, or you were to have like a mitral valve disease or something like that, then it can press up and displace the esophagus. And that will show up on the barium swallow as a posterior indentation, and that will cause dysphagia, especially to solids. The left ventricle, that's more inferior and also lateral. The right atrium, that forms the right heart border. The right ventricle is the most anterior chamber, and the superior vena cava is not adjacent to the esophagus. So left atrium lies directly anterior to the esophagus and posterior to the mediastinum. So yep, an enlarged heart can make it hard to swallow. That's the main story here. You have to know there's left atrium, which sits like directly in front of your esophagus. And always try to envision like a patient in front of you, staring at you like you're diagnosing them. That left side, the heart's kind of tilted like this, looks like a boot inside of their body. Also on that last one, if you want to remember, LA stands for lies against. Maybe that's an easy way to remember it. It lies against the esophagus. LA, left atrium. Okay, next we have a 26-year-old man presenting to the clinic with recurrent episodes of colored urine that last 1 to 2 days. After episodes of pharyngitis, he denies Listeria or flank pain. Past medical history is unremarkable. Blood pressure is 140/88. Physical exam is normal. Urine analysis shows 3+ blood, 2+ protein, and dysmorphic red blood cells. Renal biopsy shows granule immune deposits in serum. C3 and C4 are normal. Okay, this is IgA nephropathy. So we got a dude, he's got some episodes of some brown urine, hematuria, that appears during a respiratory infection, URI, GI problem. And this is going to be IgA nephropathy, Berger disease. And this happens because of mucosal infections like respiratory GI, and that will trigger an IgA overproduction is the mechanism. And that deposits in the glomerular mesangium. And so on biopsy, you have granular IgA deposits in the mesangium. And you could think of other options like IgD. Nobody really cares about that one. That's only on the autoimmune B cells. Or IgM, that's really early in the process of the immune response. It's not going to be the driver of Berger disease at all. That's IgA. And IgE is allergic reactions, not the kidney. So IgA nephropathy, the infections activate the IgA. You get hematuria with colds or GI problems. Here's an explanation. Linear IgG would be good pasture syndrome, full house pattern, lupus, low complement, and all that stuff. IgM, focal segmental glomerular sclerosis, is a pattern in HIV. Subepithelial humps, IgG and C3 is post-streptococcal glomerulonephritis. So it causes blood in the urine just like a day or two after you have an upper respiratory infection. All right, here's some more information about it. Granular IgA in the mesangium, nephropathy with the young adult, hematuria after upper respiratory infection or GI, red blood cell cast, and normal C3. It's not lupus or good pasture. Linear IgG is a type 2 hypersensitivity reaction where the answer is good pastures. You have a glomerular basement membrane, and inside of that, the alpha-3 chain of type 4 collagen is damaged with those IgGs. So you have linear IgG staining. IgA would be granular, not linear. Also involves the lungs. Hemoptysis would be seen. All right, and this next question, look, it's you, a researcher. Oops, there we go. They're comparing the energy yield of different organic compounds, each containing 6 carbon atoms. Researcher observes that one compound generates significantly more. Which the following characteristic most likely explains the higher ATP yield, has a greater number of hydrogen atoms. So basically, I don't know if you guys have seen those awesome animations, but the human body has like a turbine system where it just shuttles these hydronium ions to make ATP. That's pretty much how it works inside of your cells. And so more hydrogen atoms just means that there's a molecule that is more reduced. So it can donate more electrons to NAD plus and FAD also to make more NADH and FADH2. That causes more ATP for oxidative phosphorylation. And that is why fatty acids, which have it's a very hydrogen-rich molecule, yield more ATP than carbon, than carbs or alcohol, right? Does that make sense? We have all these hydrogens, right? So it's like the turbine can really get going with those fatty acids. It's not like the aldehydes or the keto stuff. That's already partially oxidized, right? So you have fewer electrons that you give up. It's not going to be oxygen atoms, right? It's not oxygen atoms because more oxygen means more oxidized. And so you have less potential for that ATP generation. The amino groups don't drive a lot of electron yield. Nitrogen has to be removed first. The amino groups have to literally go through the urea cycle before the ATP can be harvested. So here's some explanation. Hydroxyl groups partially oxidized, less hydrogen available. The carbonyls have already been oxidized. They already lost their electrons. Peptides, nitrogen containing. So it's all about those hydrogen atoms. Oh yeah. All right, this is a great question. And see if you can get it just only based on the description alone. 20-year-old college student, urgent care, acute chest pain, shortness of breath after playing basketball, denies cough, fever, trauma. He has a history of asthma with albuterol. He's anxious, tachypnic. Vitals are 98.6. His trachea is midline, and auscultation breath sounds are decreased on the right side of his body. Percussion says hyperresonance over the same area. All right, what's the finding? The answer is going to be decreased breath sounds on the right. I know it already said that, but the point here is to identify and describe spontaneous pneumothorax. If you have a young male with asthma and thin body habitus, they might have a ruptured little bleb there, and hyperresonance and decreased breath sounds shows you that you have some air in that pleural space. So there's primary spontaneous pneumothorax. That's a rupture of the apical subpleural blebs, usually in tall, thin males when they're exerting themselves. Tension pneumothorax will also add the tracheal deviation, JVD, and severe hypotension. And for that, you need an emergency needle decompression. So pneumothorax, right? Pneumothorax, you think of the P for popped lung. You have absent breath sounds, hyper-resonant percussion, and sudden chest pain. These are good to know too. Increased tactile phrematous is seen in pneumonia, but is decreased because of air insulation. Crackles, lung disease. Diffuse wheezing would be an asthma. Bronchial breath sounds, left apex would be consolidation. There's about 1 in 20,000 healthy males experiences this. But yeah, somebody's got like the chest pain, shortness of breath all of a sudden, and X-ray shows a left pneumothorax. A left pneumothorax, by the way, would just mean that there's air in the pleural space. And so in pneumothorax, the lung collapses and you hear like very little or no breath sounds on that particular side. And the chest also sounds kind of like hyperresonant and like hollow whenever you tap it. Crackles tell you about pneumonia, fluid, fibrosis. Wheezes tell you about asthma, and rhonk is mucus in the airways. So pneumothorax is the collapsed lung and causes decreased breath sounds on the affected side. So really just to drive this home, what about like a normal pneumothorax? Well, a normal pneumothorax, air gets into the pleural space and the lung on that side collapses. So pressure is inside that pleural space and it starts to equal the atmospheric pressure. It's not building, right? And there's no tracheal deviation in a normal pneumothorax. Or there's like a really mild that's like toward the collapse, but don't worry about that. That's only if there's volume loss, like in atelectasis. Tension pneumothorax, that's where you have that high pressure. Percussion's hyperresonant, just like in pneumothorax. Breath sounds are decreased or absent, but the trachea deviates away from the affected side because of that pressure pushing the mediastinum. Atelectasis is the lung collapse because of that obstruction. So usually in atelectasis, it's like a mucus plug, or maybe you have like some sort of a tumor. And the breath sounds decrease on that affected side. The percussion is dull. So the trachea deviates toward the affected side. The volume loss pulls it over. Pleural effusion is where fluid collects in the pleural space. There, the breath sounds are going to decrease for a pleural effusion. It's going to be dull, and the trachea has a small effusion, usually none. A large effusion, it can deviate away because like the fluid literally pushes it out. And the only other thing we haven't really covered is consolidation. For instance, pneumonia, and that's the alveoli that are filled with pus or fluid. The breath sounds there, bronchial, crackle, zygophony. Percussion's dull, and the trachea stays midline there. So just in general, I think what you should remember is that pressure pushes, right? Tension pneumothorax, large effusion. The trachea goes away, volume decrease like atelectasis, the trachea goes toward you. And then regarding like the breath sounds, percussion, and all that stuff, in the pneumothorax, you have air in the pleural space, right? And so the breath sounds are going to be decreased, but the percussion is going to be hyperresonant, hollow, and the trachea is simple, midline, nothing. But if there's tension, then it deviates away. So that's pneumothorax for you. Breath sounds decrease, percussion's hyperresonant. Atelectasis has a collapsed lung, and there you have the breath sounds decrease. There the percussion is dull, there's no air, and the trachea is toward the affected side. Pleural effusion, you have fluid in the pleural space, so the breath sounds are decreased. You have that dull kind of percussion stuff, and it's away from that effusion. If it's a pleural effusion, fluid. If there's like a lot of fluid pushing it out of the way. Breath sounds for consolidation would be bronchial, maybe some crackles, increased phrematous for consolidation. Percussion's dull and the trachea stays midline. So remember, air is hyperresonant and you have decreased sounds. Fluid, effusion, consolidation, atelectasis would be dull. And then pressure pushes trachea away and volume pulls it toward you, pulls it toward the affected side. All right, that was 100 to 110. So like and subscribe if this was helpful. We'll see you guys in the next video. Hello, everybody. Welcome back. This is my original question 111. A 59-year-old man with a 10-year history of type 2 diabetes and hypertension presents with worsening fatigue, diffuse bone pain. He reports muscle cramps, pruritus on his lower legs. He's taken lisinopril and insulin, lab values, low calcium, high phosphate. H is elevated, creatinine is elevated, normal 25 hydroxyvitamin D, and low 125. What explains these symptoms? All right, so this is chronic kidney disease, secondary hyperparathyroidism. Basically what you look out for in this one is hypocalcemia, hyperphosphatemia, because you can't get rid of it. Why? Because your kidneys aren't working, even though you have low calcium and phosphate. And what happens here is this is chronic kidney disease. So you have decreased GFR, and that causes your phosphate to be retained, which then leads to hypocalcemia. And that's where the PTH starts to rise. So it can help you with your hypocalcemia. So you get that chronic kidney disease, phosphate retention. The phosphate retention binds the serum calcium. And if you can't activate vitamin D, that makes this hypocalcemia problem even worse. So low calcium, high PTH, and low activated
vitamin D. All right, there's the explanation. In metastatic bone lesions, you'd see hypercalcemia. In osteomalacia, you'd see a vitamin D deficiency. Hypo would have low. In primary, has high calcium, are also going to develop bone abnormalities over time. And that's because the kidneys stop doing their job. They stop converting vitamin D to its active form. And without the active form, the 125 form, you can't uptake a sufficient amount of that calcium. All right, now for this next question, I'd like for you to take a look at this drawing that I've done and tell me what is the condition associated with this drawing. Now, I know I'm not the best artist, but it's going to be associated with this question. A young boy, it could be anything, presents with progressive dyspnea and dry cough for the past 3 days. She underwent renal transplantation 8 weeks ago and has been on tacrolimus, mycophenolate, and prednisone. Temperature is at 101.8. Respiratory rate is at 28. And the chest exam shows bilateral crackles. Chest radiography shows diffuse interstitial infiltrates. Bronchoalveolar lavage reveals large mononuclear cells with basophilic nuclear inclusions. PCR detects DNA virus. Which immune cell dysfunction most likely contributed to this condition? All right, we know it's a DNA virus. And in fact, this is going to be a latent herpes virus. This is HV5, which is a correct answer. So CMV pneumonia is an opportunistic T-cell suppressed related infection after a transplant. So the CMV infected cells present viral antigens via the MHC1 complex. And those are recognized by the CD8 positive T cells, and that leads to the perforin, granzyme-mediated killing, the prevention of viral replication. And so you often see this with T cell suppression and post-transplant immunosuppressive therapy. In the histology, you see the ally inclusions. So yeah, CMV is T cell mediated. Eosinophils is against the helminths. Natural killer cells, CMV evades adaptive T cell immunity. All right, here are the associations. Transplants, CD4 below 50, graft versus host disease. It's a DNA virus. You suppress those CD8 positive T cells, and that can cause reactivation in the lungs, causing alveolar damage. Treatment is ganciclovir, valganciclovir. All right, next question. Look, that's you right there. A researcher is studying the binding properties of novel tetrameric protein to its signaling molecule. She constructs a graph of ligand concentration and notices the binding is sigmoidal. That means positive cooperativity among the binding sites. So the receptor ligand binding curve has a sigmoidal shape with a steep increase in the binding over the narrow range of the hormone concentrations. All right, so this is just a question about cooperativity. And this graph right here is going to be a cooperative graph, the sigmoidal shape, whereas this one is not the cooperative graph. Cooperative, sigmoidal. That's all we need to know. All right, for this next question, we have a 16-year-old boy, cystic fibrosis, comes to the clinic, has multiple pulmonary exacerbations in the past 6 months. FEV1 is 45% predicted, BMI 10th percentile. He skips nebulizer treatments because they take too long. He's alert and cooperative. What should be the initial response? It should be acknowledge the challenges of adhering to a time-consuming regimen. So your steps should always be you acknowledge, you validate, and then you problem solve later. So first you have to acknowledge, then later you solve this. Always acknowledge and try to understand what makes the adherence difficult. You have to acknowledge the frustration and explore the barriers. And then you use motivational interviewing, where you express empathy, you roll with the resistance, and you support self-efficacy. And you have to first empathize. You have to say, hey, I know it's hard to miss these insulin injections. First, you have to empathize, and then you have to validate. And then you can solve the problem. Explore those barriers. Acknowledge that it's challenging. For the next question, we have a 45-year-old Vietnamese woman, progressive nasal obstruction and intermittent epistaxis over the last 3 months. She's noticed a fullness of the left side of her neck. She's got a firm, non-tender mass in the left posterior cervical chain. Pharyngoscopy reveals a fibril mass in the lateral wall of the nasopharynx. She's got Epstein's Barr. What is the most likely diagnosis? Nasopharyngeal carcinoma. It's just textbook right there. So nasopharyngeal carcinoma is a malignancy that arises from the epithelium of the nasopharynx. And that's because there's this fossa, there's the recess in the lateral nasopharyngeal wall. And this is really associated with EBV, especially if you see somebody from Southern Asia, Southeast Asia, and North Africa. And this presents with a non-squamous carcinoma, but there are also going to be some keratinizing subtypes as well. The thing to look out for is positive staining on Epstein's Barr virus, nuclear antigens. And so the symptoms are going to be nasal symptoms, right? Congestion, epistaxis, ear symptoms, the eustachian tube obstruction, conductive hearing loss, cranial nerve involvement as well. You can see, hoarseness, dysphagia. You may see some cranial nerve 9 and 10 action, cervical lymphadenopathy as well. And to treat this, we use radiation and chemotherapy. But this is linked, EBV is linked to nasopharyngeal carcinoma, especially in Asian populations. And this is present with epistaxis, nasal obstruction, and cervical node involvement. Now, let's talk about what this is not, because that's also equally important. This is not diffuse large B-cell lymphoma. While EBV can be associated with diffuse large cell, especially in immunocompromised patients, It is a lymphoid neoplasm, not an epithelial carcinoma. So this patient has a keratin-positive tumor, and that means it's epithelial origin, and so it's not going to be a lymphoma. And so it can't be diffuse large cell lymphoma. But you should be thinking of, large B-cell lymphoma in immunocompromised patients in lymphoid neoplasm, but not epithelial carcinoma. That's why it's not diffuse B-cell. Why is it not HPV, like oropharyngeal squamous cell carcinoma, HPV? Well, HPV is associated with oropharyngeal cancers. That's like the tonsils, the base of the tongue, and not the nasopharyngeal. And those tumors also are a little bit different. They stain P16 positive, not EBNA positive. And it's more common in like Western countries. Okay, so not it. Squamous cell carcinoma of the nasal vestibule, that's located in the external nares and unrelated to HPV. So basically, the high-yield recap for this is you got somebody from Southeast Asia with a nasal obstruction, hearing loss, and lymphadenopathy. Then it's going to be a nasopharyngeal carcinoma, likely Epstein-Barr virus. You're going to see keratin, and that shows you that it's an epithelial origin, and Epstein-Barr antigens like the EBNA positivity. That means you have Epstein-Barr virus involvement, and that makes nasopharyngeal carcinoma the best answer. So that is the recap on this question. All right. This question typically going to be an older patient. 61, former pianist, presents with a progressive stiffness and aching of her right thumb and wrist that began over the past 5 months. The pain is aggravated by playing and relieved by rest. That should make you already think of osteoarthritis. So piano, it could be tennis coaching. It could be a lot of things. Repetitive joint use. It's typically in elderly patients, maybe late 50s, early 60s. Osteoarthritis is the degenerative joint disease that's caused by mechanical wear and tear. You literally break down that articular cartilage, and that causes the formation of subchondral sclerosis, osteophytes, and joint space narrowing. So look out for that repetitive stress. Synovial findings are going to be non-inflammatory and also less than 2K white blood cell. Clear fluid, normal glucose, no crystals. So osteoarthritis is a mechanical joint disease. Morning stiffness, less than 30 minutes, improves with use. Synovial fluid is non-inflammatory. So there's pseudogout, will be the deposition of calcium pyrophosphate dehydrate in the joint cartilage. That's pseudogout. And that would typically be with larger joints, like the knee, wrist, shoulder. And there you would have positively bifringent rhomboid-shaped crystals. If the answer were something like the deposition of calcium pyrophosphate. Positively bifringent rhomboid-shaped crystals. So that's pseudogout. Also, immune complex-mediated synovial inflammation is seen in rheumatoid arthritis and other autoimmune inflammatory arthritides. Rheumatoid arthritis is symmetrical and polyarticular. It also has morning stiffness and inflammatory synovial fluid. So you have a lot of white blood cells in the fluid. It's not going to be an acute bacterial infection in the joint space either. Here we have joint space narrowing. But if they were to say there's like some infection in the joint space, then that could be septic arthritis. And that has acute onset, severe pain, erythema, warmth, purulent synovial fluid. White blood cells are going to be galore, just like 50K of them, just all around. And if it said monosodium urate, then that's just gout. That'd be sudden painful swollen joint in the first MTP. So you'd have the needle-shaped negatively bifringent if it were gout. All right, so that's how to distinguish between all of these different conditions. Here you can read about them here. All right, next we have a 28-year-old man going to the clinic with 4 months of persistent diarrhea. The stool has blood in it, constant feeling of needing to defecate even after using the toilet. Colonoscopy shows mucosal inflammation from the rectum to the splenic flexure. Crypt abscesses and distortion. Which of the following complications is this patient most at risk for developing? The answer is colorectal carcinoma because this is ulcerative colitis. So the things to look out for are bloody diarrhea, tenesmus, which is the continual recurrent need to evacuate the bowels, left lower quadrant pain, erythema nodosum, and also with UC you have the friable mucosa and continuous involvement starting at the rectum. And the biopsy shows crypt abscesses and mucosa, submucosa limited inflammation. So what happens here is it starts in the rectum and it extends proximally in a continuous fashion. And so inflammation is limited to the mucosa and the submucosa. It's not transmural. And the biopsy has crypt abscesses. There's not skip lesions or granulomas. So that's ulcerative colitis. Mucosal, submucosal, inflammation, continuous involvement, always rectal involvement. Every single time, gonna have rectal. That's why we wanted to mention the tenesmus in this question. Always rectal involvement, crypt abscesses, no granulomas. There's a risk of colorectal carcinoma and it's associated with primary sclerosing cholangitis and Pianka. All right, now some other answer choices that they could have given you are like transmural inflammation with granuloma formation. That would be Crohn's disease, because Crohn's disease, it's a different beast, but there are a lot of similarities. Crohn's has skip lesions. There's also cobblestone mucosa, and it can affect any part of the GI tract, any part. This is also associated with fistula, strictures, and non-casing granulomas. Now, they're also going to try to get you on diverticulitis,
And that's common in elderly adults. And you would see left lower quadrant pain there. You would not have bloody diarrhea. And there's also not going to be diffuse mucosal inflammation on colonoscopy. And they could also try to get you on another question with C. diff. And that is typically after antibiotic use, you have watery diarrhea there. And endoscopy shows a yellow-white pseudomembrane that's not continuous mucosal ulceration. They could also try to ask about ischemia, acute mesenteric ischemia. Usually it'll be like an SMA occlusion, something like that. And that's associated with sudden onset severe pain, lactic acidosis, and also risk factors like atrial fibrillation. But this person just has ulcerative colitis, just a chronic disease causing bloody diarrhea and inflammation starting in the rectum. That's what you need to know about ulcerative colitis. The inflammation is limited to just the surface layers of the colon, and it spreads in a continuous path, unlike Crohn's disease, which just skips all around and then it digs super deep into the bowel wall. All right, for the next question, we have a 46-year-old man. He's got bipolar disorder, treated with lithium. He's drinking tons of water. And what we know about lithium is that it actually impairs the ability of that collecting duct to reclaim the water because it stops that ADH. So what describes the tubular fluid tonicity relative to the plasma? Let's talk about the pathophysiology here. Lithium therapy for bipolar disorders disrupts the V2 channels. And so you get hypernatremia and increased serum osmolality. Why? Because that water leaves. The water is gone. It can't be reuptaken by those V2 channels anymore. So the lithium inhibits the V2 receptor signaling. The collecting duct fails to absorb the water. And now the urine is just full of water. So the medullary gradient gets washed out. And so then you just lose the ability to concentrate at all. And hypernatremia, polydipsia, polyuria, you have no improvement even after you give them desmopressin. Now, we have to know what's happening in the proximal convoluted tubule, and that's the segment that reabsorbs 65% of the filtered sodium and water. That happens isotonically. Because both solutes and the water are reabsorbed proportionally, the tubular fluid osmolality remains isotonic. And that's always true. It's true in every condition, even nephrogenic diabetes insipidus. And the DCT, the distal convoluted tubule, is impermeable to water, but it actively reabsorbs sodium. And so the tubular fluid becomes dilute or hypotonic as the solutes are removed. But in normal and DI patients, the segment will be lowering the tubular osmolality. So you'll see hypotonicity there. And the medullary collecting duct is at the end. And in healthy patients, that's the site of the ADH action. And that's where water is reabsorbed through the aquaporins. But in nephrogenic DI, aquaporin insertion will fail because of that lithium that interferes with the V2 receptor-mediated CAMP signaling. And so no water is absorbed. And so it's going to be dilute and hypotonic even in the medulla where the interstitial osmolality is high. So even though you have high plasma osmolality, the urine is dilute because of the collecting ducts. And desmopressin fails to concentrate it. Whereas it would really help if this were just central DI. So without that CAMP, aquaporins can't work. Proximal tubule is going to be normal, but the collecting duct is hypotonic because these guys are watertight. And then you can't absorb it at the end, so it's also hypotonic as well. All right, there are the kidneys. All right, here's the next question. We have a 43-year-old man admitted with a high-grade fever, altered mental status, and painful swollen right thigh. Had minor surgery, 104, super high fever, knee with palpable crepitus. He is obtunded, withdrawals from painful stimuli. Here are the labs. What describes the mechanism? All right, so for this question, we have to know what's happening, and this is toxic shock syndrome. How do we know? We got a fever, hypotension, multiple organ dysfunction, so renal and hepatic, and there's diffuse erythematic rash after a nasal surgery, and that's a known risk factor for toxic shock. And that's because of the nasal packing that's colonized by Staphylococcus aureus. So toxic shock is caused by Staphylococcus aureus via the TSST1 pathway or Streptococcus pyogenes through exotoxin A or C. And they both share the same mechanism for toxic shock. And the mechanism is you have that toxic shock syndrome toxin, TSST1, that binds non-specifically to the T receptors and the MHC class II molecules on the antigen presenting cells. It bypasses the normal antigen specificity and it activates 20% of the T cells at once. And so that's a huge, as you can imagine, cytokine release. And so now you're just swarmed in IL-2, IFN gamma from T cells, IL-1, TNF alpha from macrophages, and that leads to a cytokine storm. So you have shock, organ failure, and rash. So that's our answer is C. Trap answers, caspase, cleavage to apoptosis. Definitely not toxic shock. That's like a viral bacterial manipulation. Inactivation of VF2, that's diphtheria and Pseudomonas. Lecithin hydrolysis is Clostridium perfringens alpha toxin. Serum protease disrupting the junctions is exfoliative toxin of Staph aureus and scalded skin syndrome. That is exfoliative toxin in Staph aureus and scalded skin syndrome. So yep, it's the bacteria that makes your immune system go into overdrive. All right, for the next question, we got a little baby, 4-day-old infant
presents with vomiting, lethargy, poor feeding. Examination reveals signs of dehydration and ambiguous genitalia. Sodium is 122, potassium 6.5. So that's a low sodium, high potassium. Glucose of 48. Oh, genetically female. So this is congenital adrenal hyperplasia. And they give us the 17 is markedly elevated as well. And that's diagnostic for it. 11 beta hydroxylase. That'd be hypertension due to excess 11-deoxycorticosterone. But this patient is hypotensive. And so that can't be the answer. So it's going to be 21 hydroxylase deficiency causing that elevated 17. Aromatase, that's involved in the maternal virilization during pregnancy, does not cause salt wasting at all. 17 alpha hydroxylase, that would cause hypertension and sexual infantilism. And this guy right here is super rare, probably won't see it on test day. But the takeaway for this question is that 21 hydroxylase is required to make cortisol and aldosterone. And so deficiency leads to lower cortisol, lower aldosterone, and increased androgens. So you get the virilization in the XX infants. And 21 hydroxylase deficiency is the most common cause of congenital adrenal hyperplasia, and it affects newborns with ambiguous genitalia, salt wasting crisis, so hypernatremia, hypercalcemia, and dehydration, and also elevated 17-hydroxyprogesterone. You give them glucocorticoids and mineral corticoid replacement. All right, in this question, we have a 10-year-old boy brought to the pediatric clinic for evaluation of skin nodules and fatigue on exertion. His father died at 36 from myocardial infarction. Fundoscopic exam shows gray-white deposits near the corneal margins. Lab shows total cholesterol 620, LDL 540. All right, so what's happening here? You could see these firm yellow nodules, these tendon xanthomas. He might also have some corneal problems, some corneal arcus, and elevated LDL cholesterol. These are hallmarks of familial hypercholesteremia, and this is due to a defective or absent LDL receptor mediated endocytosis. So you have high LDL, right? Like, look at that. That's extremely high. Tendon xanthomas, so like the Achilles and extensor tendons, and lipid deposition as well can occur in the cornea, and premature cardiovascular symptoms, so like chest pain, dyspnea, things like that. And so the answer is going to be the impaired clathrin-dependent LDL receptor endocytosis. And so the pathophysiology of familial hypercholesterolemia is a mutation of the LDL receptor or on the ApoB100 or the PCK9, those proteins. And the LDL receptors on the hepatocytes bind the LDL to internalize it through the receptor-mediated endocytosis, and that relies on the clathrin-coated pits. So yeah, if you see somebody who has like a heart attack before they have their driver's license, then they probably have FH. Look for tendons and corneal arcus and LDL levels above 500, just a dead giveaway. And then you have to know the mechanism. Cabulin deficiency, non-clathrin endocytosis, not LDL. So that's why A is wrong. These are the mutations. They're different diseases. ApoC2 would raise triglycerides because you can't clear the chylomicrons. And snare defect affects the vesicle fusion. All right. Hopefully you guys found this helpful. If you did, please consider liking and subscribing. And we'll see you guys in the next video. Hello, everybody. Welcome back. I feel like I just figured out how to use this microphone. This is NBME 29. I've created original questions that cover topics that I believe are important for you to have mastered by the time you finish this exam. So here we go. Our first question involves a 66-year-old man. It could also be a female, hence our demographic photo here. With chronic kidney disease and hypertension, presents with sudden onset left ankle pain and swelling. He has difficulty bearing weight and reports chills and fatigue. Temperature is 101.8. On examination, left ankle is warm, erythematous and tender. Novial fluid, white blood cell count of 78K, 94% neutrophils. Gram shows abundant neutrophils, but no bacteria. Which of the following is most likely the cause of the patient's symptoms? Okay, so in this type of patient, you're going to see, typically it's some sort of like a sudden fever. They might have like a very painful knee, and then maybe also diabetes, something like that. All these things are pointing to infection risk. And then you look at the joint fluid, and what do we see? White blood cell count that's pretty high, neutrophils, septic arthritis. And also they could tell you that, hey, there are no crystals, then it's not gout or pseudo-gout. And also they'll mention that it's cloudy. They'll give you some detractor answers. For instance, they'll say, oh, is it gout? Well, no, that has uric acid crystals and fewer white blood cells. Is it pseudo-gout? No, pseudo-gout would have calcium crystals, and there's none of that. What about DVT? Well, that would cause a leg swelling, not that hot red joint. Okay, so that's the way to think about this question. The cause is septic arthritis. That's the cause. Calcium pyrophosphate is pseudo-gout rhomboid crystals. Erythema nodosum would have the nodules in the shins. Skin manifestation. Reactive arthritis is post-infectious, and it'd be asymmetric oligoarthritis after some sort of an infection. Not going to be as acute. Arthrosis, bloody aspirate. So yeah, septic arthritis can actually just destroy a joint in like 48 hours. They'll present with acute, red, hot joint pain
and also some systemic signs like fever. In our next question, we have a 9-month-old boy from Middle Eastern descent brought to the clinic for pallor, porphyritic, hepatosplenomegaly. Lab testing reveals a hemoglobin level of 5.8. Now, this could be a male, could be a female. Peripheral smear shows microcytic hypochromic RBCs with numerous nucleated red cells. Genetic testing confirms a mutation affecting intron-exon splicing of both beta globin alleles. What explains the anemia? It's the accumulation of unpaired alpha globin chains. So normal adult hemoglobin, so HbA has 2 alpha and also 2 beta chains. And in thalassemia major, mutations like splice site defects will greatly reduce the beta globin production. And so alpha globin is still going to be made normally, and so there's an imbalance. There are too many alpha chains and not enough beta chains. And so extra alpha chains will clump together. You'll get these alpha 4 tetramers, which are insoluble, and they damage the red blood cells and they cause severe anemia. So those would be increased. Beta tetramers would be a feature of alpha thalassemia, which makes sense because 2 alphas, 2 betas is what's needed for adult hemoglobin. And so the answer is the accumulation of the unpaired alpha chains. That's what's happening here. So yep, it's beta thalassemia major. Gamma globin tetramers would be Bart's, seen in alpha thalassemia. Low EPO would be anemia of chronic disease. Delta globin. Here we should definitely just be thinking of like alpha, beta for your thalassemias. Beta thalassemia would have decreased beta chains, and so you have excess alpha chains. Alpha thalassemia has decreased alpha chains, so you have excess beta chains, or, your gamma tetramers. The thalassemia essentially denotes the deficiency, is the way to think about that. Okay, next we have a 27-year-old woman with a history of schizoaffective disorder brought to the emergency department due to confusion and muscle stiffness. This could also be, a man, elderly woman, whatever. She recently started on risperidone 4 days ago following an acute psychotic episode. After arrival, her temperature is 40 degrees Celsius, so 105 holy Toledo muffins. That's high. Heart rate 130. Physical exam reveals generalized muscle rigidity. Okay, so already I know that this is neuroleptic malignant syndrome because look at that fever. Oh my goodness. They took a dopamine blocking antipsychotic and now their fever is through the roof. Definitely neuroleptic malignant syndrome. So they probably started risperidone, could be haloperidol, like a high potency antipsychotic. And now they have a super high fever, muscle rigidity, that lead pipe rigidity is how it's commonly known. So the answer is indeed C, neuroleptic malignant syndrome. After you have a dopamine blocking antipsychotic, you get that muscle rigidity, altered mental status. They'll be disoriented. They might be agitated. They have autonomic instabilities, tachycardia, labile, BP, increased CK. The muscle breakdown from the rigidity will also take place. The mechanism of action is important. The cause here is you have that antagonism of your D2 receptors, your nigrostriatal, and your pathways are going to be blocked from antipsychotics like haloperidol, risperidone. Nigrostriatal blockade causes severe muscle rigidity, that lead pipe rigidity. And the hypothalamic blockade causes the loss of the dopamine regulation and autonomic instability and hyperthermia. So you have sustained rigidity, muscle breakdown, and that increases your CK and rhabdomyolysis. So first of all, how do we treat this? We have to stop the antipsychotic. You have to give supportive care, right? Hydration, cooling. Dantrolene is going to inhibit the ryanodine receptors in the skeletal muscle, right? You got to inhibit those with dantrolene. And that would cause less calcium release and so less rigidity, less heat. Bromocriptine, mantidine, these are dopamine agonists and they restore the dopamine signaling. Neuroleptic malignant syndrome is too much dopamine blockade. Decreased dopamine activity causes rigidity, fever, and autonomic dysfunction. That's what's going on. Serotonin syndrome, hyperreflexia clonus, malignant hyperthermia, exposure to anesthetics, no surgical anesthesia history there, so it's not going to be malignant hyperthermia. Tardive dyskinesia would be lip smacking, chorea, that stuff. And this is super important because it has a mortality rate of 20% if it's untreated. Next, we have a 2-year-old girl with adenosine deaminase deficiency undergoing experimental gene therapy with an integrating retroviral vector. After initial improvements in immune function, she returns with persistent fevers, fatigue, cervical lymphadenopathy. Peripheral blood smear reveals lymphoblasts. Flow cytometry reveals T-cell markers. Karyotyping is normal, but molecular analysis reveals vector insertion upstream of the TAL1 gene. What explains the mechanism of her condition? Adenosine deaminase deficiency. All right, so this is probably going to be a young kiddo, boy, girl. We got some T-cell markers and vector insertion upstream of the gene. All right, so what's happened here? This is T-cell leukemia after gene therapy. And this is a risk when retroviral vectors integrate near the oncogenes like TAL1 gene. So this is a mechanism called insertional mutagenesis. You activate the oncogenes and it leads to clonal malignant transformation. And there are some things to watch out for questions like this. What comes to mind should be you should be on your radar. You should be thinking about like P53, because the P53 deactivation, that's common in tons of cancers, but retroviral gene is going to be different. You could be thinking about PRB, phosphorylation, that's downstream cell cycle control. It's not caused by retroviral insertion. You should be thinking of other cancer associations, maybe that 922 Philadelphia chromosome for BCR-ABL, the Philadelphia chromosome for CML, other reverse transcription like, P10 is a tumor suppressor. But we're looking for what causes our leukemia. Here it's going to be the integration of a transgene near a proto-oncogene. And it's important if you have a adenosine deaminase deficiency, then you've got SCID, right? The boy in the bubble disease. It's an X-linked severe combined immunodeficiency disorder. And so you're going to use retroviral gene therapy. So a virus carries a normal copy of the missing gene, and it integrates into the child's bone marrow, the stem cells. Those are the cells that make the normal immune cells. And at first it's working, but then years later, the child gets like T-cell leukemia. So the question that they're really asking is like, okay, how did this happen with this kid who had SCID? They're asking what went wrong. Well, retroviruses don't choose where they insert the DNA. They just kind of integrate randomly into the host genomes. And so some unlucky ones, the virus inserts the DNA right next to an oncogene. And that causes the oncogene to be turned on too strongly. And then you get cell growth, which is cancer. So this is insertional mutagenesis. Now, what you should know about P53, PRB, and also P10 is that these guys are tumor suppressor genes. So the mutations there would cause cancer, not from retroviral insertion. So the Philadelphia chromosome, the BCR-ABL, CML, that's not related to gene therapy at all. But the big takeaway for this question is that retroviral gene therapies have risks. They can cause random integration and activation of oncogenes. And if you activate your oncogenes, then boom, you got leukemia. So that's what they're testing you on. All right, question 125, 65-year-old woman, history of type 2 diabetes and hypertension, presents with confusion, progressive fatigue over the last 3 days. It could be an elderly man as well. She missed her dialysis session early that week. Vitals show heart rate of 98, T of 36 degrees Celsius. She has periorbital and pedal edema. Neurological exam shows us asterixis. What's the cause of her disturbance here? And they give us a ton of labs. All right, so what's going on in these labs? Do they give us a pH? Oh yeah, there it is. Okay, I was like, wow, where's the pH? 7.3. Okay, so that's low. So we're dealing with acidemia. HCO3 at 12. Okay, well that's low. So that's metabolic acidosis. PCO2 is at 25. That's also low. So that means the lungs are compensating with some hyperventilation. And now let's calculate that anion gap. And anytime you do the anion gap, it is the sodium minus all the negative stuff. So like chloride, bicarbonate. And we're going to get a pretty high anion gap when we do that. Normally it's like less than 12. This is going to be pretty high. And so the causes of the anion gap, elevated anion gap metabolic acidosis are mud piles. So that would be methanol, uremia, which is to say renal failure. D stands for DKA. P is propylene glycol. You're gonna glycol. Ghostbusters. I is INH, or iron. L is lactic acidosis. E is ethylene glycol. It's mud piles. So it's salicylates. So here we have severe congestive heart failure. So very high creatinine, 8.4, also high BUN. There's no ketones in the urine, no glucose in the urine, no drinking alcohol. So it's not ketoacidosis. And so it's going to be uremia from acute kidney injury due to congestive heart failure. Why? Because the kidneys are not being perfused. So we got some uremia going on here. That edema, uremia. The sick kidneys cannot excrete the acids, so you get uremia, high anion gap metabolic acidosis. That's what's going on in this question. Okay, here we got a 31-year-old woman presented with 9-month history of progressive vision difficulties. Notice some spontaneous nipple discharge. Pretty easy question. This is going to be probably that a nipple discharge is probably going to be prolactinoma that inhibits the gonadotropin releasing hormone. So that's our answer. Maybe a way that we could make this question a little harder is we can look at a kind of diagram like this. And here we have to know that this right here is pointing to the hypothalamus. This right here is the thalamus. That's going to be like the midbrain. And here's where you'd have like a pituitary problem, pituitary adenoma. And that could be like some optic chiasm compression of the pituitary adenoma. But here she's got visual testing, unable to see objects. And in this case, we have hyperprolactinemia suppressing the GnRH, manifesting amenorrhea and low LH and FSH. The pituitary mass is pressing against the optic chiasm, explaining her bitemporal hemianopia, which looks like that. It's the loss of the vision on the outer half. Okay, in our next question, we could have a 29-year-old pesticide factory worker. Maybe it's male, maybe it's a female. Brought emergency department, complains of blurry vision, excessive sweating, and abdominal cramping, diaphoretic bradycardia, and wheezing with pinpoint pupils, parasympathetic activation. Colleague mentioned he was exposed to some barrel of organic phosphate. The toxin most likely forms a covalent bond with which amino acid residue? You just have to memorize this one. It's serine. This is DFP, disopropyl fluorophosphate. It's an organophosphate that irreversibly inhibits acetylcholinesterase by binding to the serine residue at its active site. So acetylcholinesterase is the enzyme that normally breaks down acetylcholine. And at its active site, there's a serine amino acid that does the actual chemical cutting. So you get an organophosphate that would stick to the serine and it'll block it forever. So acetylcholinesterases can't work. So acetylcholine builds up and you get an overstimulation of the nerves and you get a cholinergic crisis. So to answer this one correctly, we have to know the mechanism of organophosphate poisoning, especially at the molecular level. Organophosphates, maybe a child has this as a pesticide. It's a chemical like disopropyl fluorophosphate is a potent irreversible inhibitor of acetylcholinesterase. And so it binds to the serine residue at the active site of acetylcholinesterase enzymes. You might think it's histidine, and that is part of the catalytic triad, but organophosphates do not bind to histidine. It participates in proton transfer during the catalysis, but it is not the nucleophile itself. So a pesticide-like chemical is poisoning a kiddo or poisoning somebody, and it irreversibly inhibits acetylcholinesterase, and that an enzyme, you have to know, uses the serine residue to break down acetylcholine. The toxin covalently binds to the serine and it stops the enzyme and it causes too much acetylcholine, which leads to sweating, the twitching, and the weakness. And so serine is going to be the target there. Next, we have a 61-year-old woman. It could also be a man, so I've drawn a man there. Brought to the emergency department by her daughter who says the patient began speaking nonsense. Okay, so this is probably going to be Wernicke's aphasia, nonsense. They could also say, all right, we got like an old woman or a man brought to the emergency room by her daughter. And basically what they're trying to get you to understand is the language processing region of the brain, like Wernicke's area, and the way that Wernicke's area and Wernicke's aphasia looks. And it's the left posterior superior temporal gyrus. That's Wernicke's area. All right, it lies in the dominant hemisphere, usually the left, and it corresponds to the Brodmann's area 22. But there, if you have like an MCA, like a middle cerebral artery stroke, then you can have fluent aphasia, where the speech is fluent and has normal grammar, but the rate is nonsensical. Or paraphasia, word substitutions, neologisms, made up and invented words, impaired repetition, or a lack of insight. So Wernicke is just word salad, right? MCA stroke, posterior superior temporal gyrus. So the answer is the inability to repeat simple phrases here. Where you have, that's also involved, Wernicke's aphasia, so the Wernicke's area is also involved in repetition. So repetition would definitely be impaired there. Slow effortful would be Broca's, hemiparesis of the right arm, Broca's aphasia with frontal lobe involvement. Right-sided sensory neglect, parietal lesion, inability to recall 3 objects would be short-term memory problems. This is Wernicke's aphasia. All right, here we have a 3-year-old male infant born 36-week gestation, develops irritability, poor feeding, intermittent tonic-clonic movements. Temperature 96.6. Examination shows tense, bulging anterior frontanelle. His mother did not receive prenatal care and her membranes ruptured 32 hours prior to delivery. Lab studies show leukocytosis and blood cultures pending, which of the following organism is most likely responsible. So you might see some elevated protein in the labs. Maybe the glucose would be low. White blood cells are going to be like elevated. There's a neutrophil predominance. Basically, we have to understand neonatal bacterial meningitis and the pathogen based on the clinical signs and lab findings, all that stuff. Now, E. coli is the most common cause of early onset neonatal meningitis, especially in the first 72 hours of life. So some risk factors they might usually say is the lack of prenatal care, premature rupture of the membranes, prematurity, and this is a gram-negative lactose fermenting rod. And you can easily identify this on McConkey agar. It causes fulminant presentation, so poor feeding, temperature instability, bulging fronts and seizures and coma. CSF findings in bacterial meningitis are going to include high white blood cell count with neutrophil predominance, low glucose, and elevated protein. The elevated protein is due to the increased permeability and the inflammation. Low glucose is because the bacteria are just going to be chomping away. They're going to be eating that glucose. High white blood cell with neutrophil predominance makes some sense too. Basically, this E. coli is just causing the sepsis, causing the meningitis in this kiddo, and it's just hours or days after the birth, which kind of gives it away. You give them ampicillin and gentamicin as well for empiric first-line treatment. Now, the question is, how do we distinguish this from other diseases? Well, hypothermia, seizure, bulging frontanelle means we got a CNS infection, and E. coli across the blood-brain barrier. Listeria is much less common, especially in the absence of maternal food exposure. Strep pneumonia, be rust-colored, otitis media. Staph epidermidis has shunt-associated infections, more like with a catheter. Neisseria, meningitis, you'd see that in college dorm rooms. Early onset neonatal meningitis is probably going to be E. coli, just because usually they'll give you some sort of a CSF culture that'll make it really clear. They might even tell you it's a gram-negative rod if they're being easy. Lactose fermenter that's unique to E. coli. Neisseria meningitis, that affects older infants, children, and adolescents, not neonates. Streptococcus pneumonia is more common in toddlers and older children. So this is really just a timeline thing. Listeria could be a early neonatal meningitis, but it's a gram-positive rod, not a gram-negative rod. And it's usually with like some contaminated food or transplacental transmission, something like that for listeria. So the big kind of takeaway here is that we have a newborn with seizures and a bulging fontanelle, which is neonatal meningitis. CSF has a bacterial infection, and usually the culture will show like lactose fermenting stuff, and that will point it to E. coli. But yep, crosses the blood-brain barrier, E. coli. Let's do one more question here. All right, here we have a 30-year-old woman, fatigue, dark urine, diffuse itching for the past 10 days, returned from a trip abroad. She was prescribed azithromycin doxycycline for presumed respiratory infection. Began to get a new contraceptive pill 6 weeks ago. On examination, she has mild scleral icterus and excoriations on the forearm. Lab studies reveal, high bilirubin. Which of the following is most likely in this patient? Wow, look at that GGT. Normal is like 0 to 30. That's 280. So this is going to be some sort of a drug-induced liver injury. The total bilirubin should be way lower than that. Usually like 0.1 to 1.2. Direct, that's also like super crazy high. Should be like nothing to like 0.0, to 0.3. Alkaline phosphatase, it's also super high. Should be 40 to 120. AST about 80 to 40, that's super high. ALT about 7 to 50 something, 56. That's a little bit high. The GGT is off the charts, my guy. All right, so we have some form of drug-induced liver injury. The answer is dilated bile caniculi containing bile plugs. So they have cholestatic symptoms, right? Pruritus, scleral icterus, dark urine. Started taking a new pill, that helps to understand it's the medication causing this. But the lab values really just give this away. We have disproportionate, like super elevated alkaline phosphatase and GGT relative to the AST and the ALT. And that's going to be suggestive of cholestasis. That's the slowing or like the blockage of the bile flow from the liver to the small intestine. There's also direct hyperbilirubinemia that supports the impaired flow of the bile. And so the reason why it's these bile plugs is because we know it's cholestasis. Here's another way of saying drug-induced cholestasis is marked by canalicular dilation of the bile plugs, elevated ALP, GGT, and mild ALT, AST elevation as well. And it's associated with oral contraceptive and antibiotics like amoxicillin, clavulanate, and also herbal toxins. Now, it's not going to be some form of necrosis that would show super high ALT and AST, like in the thousands here, but there's no evidence of that. We're not seeing any signs of chronic liver disease like hypoalbuminemia and prolonged PT. Hepatocellular ballooning and degeneration would be steatohepatitis from alcoholic or also non-alcoholic fatty liver diseases would be hepatocellular ballooning. And that's associated with macrovesicular steatosis. That's over time, not acute. Iron deposition in hepatocytes and the Kupffer cells. That would be hereditary hemochromatosis, would be Kupffer cells. Iron deposition for sure. And so there you'd have elevated ferritin, transferrin, saturation. So basically, we have a woman who's developed some drug-induced cholestasis after starting herbal supplements. Her labs show high bilirubin, high LP, GGT, classic for cholestatic drug-induced liver injury. So it shuts down the bile transport system. Oral contraceptives can do that especially when they combine with antibiotics. So cholestatic drug-induced liver injury is what's going on with this patient right here. All right, if you found this helpful, then like and subscribe. We'll see you guys in the next one. Welcome back to NBME 29. Today we're continuing with question 11. These are all original questions. Like and subscribe. So here, a 3-year-old girl is brought to the clinic by her parents due to concerns about developmental regression. She had a normal development until about 18 months of age when she began losing the ability to speak and stopped using utensils or toys with her hands. Over the past several months, she has developed repetitive clapping motions and frequently wrings her hands together. Parents noticed her head appears smaller compared to other children her age. Physical exam, she has a blank facial expression and she periodically hyperventilates. Which of the following is the most likely underlying mechanism of this condition? Okay, those are our answer choices. So this condition is Rett syndrome. It's a mutation in the MECP2 gene, which is an X-linked dominant mutation that's usually lethal in males. So MECP2, it's a critical transcription repressor that keeps the genes in check in the neurons. When it fails, the neurons can't mature normally. And usually this is going to be present in girls between about 6 to 18 months who are developing normally, and then they start to regress. So you should look for the loss of language, hand function, microcephaly, and also the hand wringing movements. There are also going to be some strange breathing patterns. And here's a more in-depth breakdown. Tetra P would be Fragile X. Deletion of 15q is Angelman's. Imprinting would be like Prader-Willi's. There you see obesity, hypotonia as well. And tumor suppressor loss is Lee-Fraumeni, not related to neurodevelopmental regression. So the big clue here is the regression The mutation on MECP2 in the X chromosome is the answer. Okay, for our next question, we have a 76-year-old woman. She's brought to the emergency department for sudden onset, severe upper abdominal discomfort, and repeated dry heaving after a large meal. She's got intermittent bloating, difficulty swallowing, especially after lying down. She denies recent alcohol use or prior history of ulcers. Vitals show hypotension and tachycardia. Physical exam has epigastric tenderness and mild abdominal distension. A nasogastric tube cannot be advanced to the stomach. Chest x-ray shows large retrocardiac air fluid level. What's the most likely predisposing factor for this condition? And the answer is a paraesophageal hernia allowing gastric displacement. So when the stomach rotates on itself, it causes a rare and life-threatening emergency called gastric volvulus. You should think about it like a twisted balloon. The air and the contents just can't escape. And so you get what's called Borchards' triad. You have epigastric pain, dry heaving, and the inability to pass an NG tube. So there's that twisting and inability to pass. Now, what lets this happen? Most often, it's a paraesophageal hernia. It's a type of hernia where part of the stomach will slip through the diaphragm beside the esophagus. That kind of looks like this. We have our normal diaphragm, normal stomach, weak diaphragm, hiatal hernia, and here is our paraesophageal hernia. There's our paraesophageal hiatal hernia. So part of the stomach is literally slipping through the diaphragm beside the esophagus. And the clues that tell us it's an underlying chronic hernia condition would be that history of post-meal bloating and dysphagia. So that's why our answer is D. Trap answers, gallstone migration. There you'd have intermittent right upper quadrant pain and pancreatitis. Duodenal ulcer with fibrosis. That would present with chronic outlet obstruction. So in that gastric outlet obstruction is where you have persistent vomiting, early satiety, because there's a mechanical obstruction. And this is seen, or causes of this are peptic ulcer disease, gastric cancer, and infiltrative diseases. You'd have non-bilious vomiting. It's associated with peptic ulcer disease, gastric cancer, chronic NSAID use, pancreatic carcinoma. It also has some infectious causes like TB. And all that's happening here is there's chronic inflammation or a tumor that causes a progressive narrowing of this pyloric canal you can see here. And so gastric emptying becomes impaired and you get retention of the gastric contents. That can cause vomiting, so you get a loss of hydronium and also chloride. And so you get metabolic alkalosis. And then the kidney will compensate and you get paradoxical aciduria. That's where you try to conserve sodium at the expense of hydrogen. So all this to say that's duodenal ulcer with fibrosis would be that condition. Malrotation with the Ladd bands is common in infants that would have bilious vomiting. And intussusception has the current jelly stools and colicky abdominal pain. Okay, next. We'll call that last one a bonus and we'll call this one 12. Here we have a 72-year-old male presents to the emergency department because he fainted while getting up from the toilet. He's got mild diarrhea for the past 2 days, not been eating or drinking. Well, he takes lisinopril and chlorthalidone for hypertension. Supine blood pressure is 132. After standing 2 minutes, his blood pressure drops to 98. What describes the immediate changes that occur when you're standing up? So I've drawn this person laying down and then standing up. There's less blood return, so it's hypovolemic state, causes less venous return, and there's going to be less of that firing because there's less blood to fire those receptors. And then that lack of perfusion of oxygen or increase of CO2 is going to cause cerebral perfusion to decrease. So this is hemodynamic orthostatic hypotension. This is seen in hypovolemia or shock states. You have decreased blood pressure and cerebral hypoperfusion. So when you stand up suddenly, then gravity pulls the blood into the legs, and that causes decreased venous return. And so you have a decreased preload. That decreases the stroke volume as you decrease the cardiac output, and that decreases the arterial pressure that's sensed by the baroreceptors in the carotid sinus and also the aortic arch. And the decreased baroreceptor firing normally increases the sympathetic tone, but here you have decreased parasympathetic firing. And so in autonomic failure, this compensation is blunted, and so you have cerebral hypoperfusion and syncope. Usually we describe this as a 20 millimeter mercury systolic blood pressure or a greater than 10 change in diastolic pressure drop whenever you stand. And the culprits that you'll often see with this are like your diuretics, alpha blockers, TCA, Parkinson meds, diabetes, that kind of thing. And that decreased cerebral perfusion comes directly from that decreased mean arterial pressure. When the MAP fails, then the cerebral blood flow will drop. And so you might have brain hypoxia, so you get dizziness, blurred vision, syncope, weakness. And the brain is just super sensitive to the drops in perfusion. For instance, even a 10 to 15 millimeter mercury drop in MAP can reduce the cerebral blood flow by about 20 to 30%. And that's enough to cause syncope in vulnerable patients. That's why they're typically going to be elderly, like the 72-year-old male. For this next question, we have a 39-year-old male undergoing evaluation for chronic mucocutaneous candidiasis. As part of the immune workup, he receives intradermal injection of heat-killed candida. After 48 hours, a test site shows 15 millimeters area of induration with surrounding erythema. Which of the following is most likely the predominant immune cell type at the injection site? The answer is macrophages. So here we have a positive candida skin test, very similar to a PPD test. They're both type 4 hypersensitivity reactions. The delay is driven by Th1 cell activation, and then that attracts your macrophages. Plasma would be type 2 and 3. Phils is type 1. Neutrophils are acute. not delayed. Natural killers would target the virally infected ones, but not the primary mediators here. So basically, if you inject Candida antigen into somebody's skin and you check back a couple of days later, then you're no longer testing just for a fungus, you're actually testing for the T cells, because that indurated hump at 48 hours is not pus. That is the result of a type 4 hypersensitivity reaction. And that is driven by Th1 cells and macrophages. So macrophages are the main effectors. They're recruited by interferon gamma from the activated T cells, and they release the enzymes and the cytokines that cause the tissue swelling and the firmness. So it's all about the cell-mediated immunity. Okay, next, this is an ethics lesson. We would all do well to listen and validate before speaking. So always think about patient autonomy, think about listening to what their concern is, ask them more questions about it. So we'll make up a question, this guy's got diabetes, type 1. He says, oh, I'm not sure, all you've done is stick me once. And instead of saying just, trust me, I'm a doctor, or do you want antidepressants? Or something crazy like that, you just say, could you tell me about some of your concerns? Or could you tell me what you think this is? Try to open up the conversation. Question marks are always a good thing. Patient anxiety often masks deep fears. So you have to have empathetic listening. Don't jump to facts without emotional validation, or else you can shut down the conversation. For this question, let me ask you, are these your rods? No, these are our rods. You guessed it. The next whose answer is acute myelogenous leukemia. Well, you might come up with central pallor, thrombocytopenia, and that's what we've done here. A 35-year-old man has fatigue, easy bruising, nosebleeds. He's got some petechia over his lower limbs and mild pallor. Look at those platelets. And we have numerous large blasts with open chromatin and a few containing needle-shaped cytoplasmic inclusions, our rods. In your question, you might also have mentioned 15 to 17 translocation, increased risk of DIC. You talk about Down syndrome, where you have an increased risk of AML, or mutations in the myeloid progenitor cells. Could have mentioned the cytopenias, low HB, white blood cells that could be high, the CD13 positive on the flow cytometry. Basically, could have gone a lot of ways. But acute myeloid leukemia is a clonal malignancy of myeloid progenitor cells in where? The bone marrow. Now, this is characterized by super rapid proliferation of the immature myeloid cells. Those are called myeloblasts. You get bone marrow failure because of the crowding out of the normal hematopoiesis. And this can happen at any age, but it's most commonly in adults that are greater than 65 years old, but any age. And what causes this is a genetic mutation at 1517. That's the APL subtype. That involves the PML RAR alpha fusion gene, and you treat it with all trans-retinoic acid. There are some risk factors to look out for on test day. One would be chemo or radiation. You can have therapy-related AML, myeloid dysplastic syndrome. That can progress to AML, and then of course Down syndrome, especially if it's before the age of 5, can predispose you as well. And some lesser known ones are the benzene exposure, smoking, industrial solvents, Fanconi anemia, Bloom syndrome, and other DNA repair mechanisms. But the pathophys for AML is very important. You have myeloid stem cells that acquire mutations, and then they start to just bang out all these immature precursors, and then those fail to differentiate. And so you get a bunch of blasts in the marrow. And that crowds out the normal cells. You get anemia, thrombocytopenia, neutropenia. You can't make stuff because the bone marrow ain't working anymore. It's too crowded. And so the blasts then start to spill into the blood. So you have an elevated white blood cell count and possibly DIC, at least in acute thrombolytic leukemia. So usually you'll see greater than 20% myeloblasts in the bone marrow. That's diagnostic for it. And then our rods, not your rods, are the red needle-like inclusions in the cytoplasm of the blasts. And also, importantly, you see MPO positivity on these stains. But that's probably too easy. They won't tell you that. Cool. That's question 15 in a nutshell. Now for this next one, we have a 65-year-old woman. She's brought to the ER. She's got fever, chills, productive cough for the last 4 days. Her sputum is yellow-green. She has pleuritic chest pain and mild shortness of breath. Temperature is 39 to 102.4 degrees Fahrenheit. Which of the following findings is most likely present? The answer is increased tactile fremitus over the left lower lobe. This is interesting because when pneumonia hits, the sound actually travels better because the lung tissue is going to be consolidated. So in lobar pneumonia, you're not going to block the sound, you're going to amplify it. So increased tactile fremitus and bronchial breath sounds. You can also have egophony, the E to A change sound. If you hear dullness to percussion and harsh tubular breathing sounds in the periphery, then that's a huge big red flag for pneumonia. So here are some of the buzzwords we talked about. Here are the associations. So pleural effusion would have decreased fremitus and dullness and decreased breath sounds. Pneumo would have decreased fremitus, but hyperresonance. That's super important for your attention for pneumothorax, air. And then lobar pneumonia has all three sounds increased. The pathophys is that there's an infection of the alveolar exudate that replaces the air with fluid and pus. that increases the conduction because it's consolidated in the vibrations you can hear, and the percussion is dull. It's not hyperresonant because it's filled with fluid content. So yeah, the vibrations don't lie. Importantly, the signs of pneumonia are going to be like the cough, you get the fever or like some yellow sputum, stuff like that. Also, maybe they'll have some pain on the right side of their chest whenever they breathe in, and then they'll have like some sort of a fever. So you look at that, you say, oh my gosh, that's pneumonia. Pneumonia is going to have consolidation of that pus in the alveolar exudate. That air is going to be gone, so it's going to be consolidated. So all these sounds are going to be increasing on the affected side. So you have increased tactile fremitus. Does that make sense? If that made sense, then be sure to like and subscribe. Next, we're going to talk about the kidney. So there's a 68-year-old man. He's admitted to the ICU following septic shock secondary to peritonitis. He was hypotensive. Now in day 2, his urine output decreases. Which of the following nephron segments is most likely to show irreversible injury? And that's the proximal convoluted tubule. Now, I want to do something fun on this question. First, I'm going to explain, but then I want to talk about how this applies to the rest of the human body. So we have ischemic acute tubular necrosis after septic shock. The proximal tubule is the most susceptible to that. It's the first site injured during hyperperfusion. And you can look at the iron sodium to confirm intrinsic renal failure. The collecting duct is also affected but less metabolically active than the proximal. It's less susceptible. Glomeruli, DCT, these are all less metabolically active and so not as susceptible. So the part that works the hardest is the part that breaks under pressure is the proximal. Now, with that being said, what are some other areas of ischemic necrosis and lesions that you can have? So we mentioned the proximal tubule, but a huge one is obviously going to be the brain. That's the most sensitive tissue to hypoxia and hypoperfusion. There you have irreversible neuronal injury that can happen even just 3 to 5 minutes out. And so the especially vulnerable areas are like the hippocampus, the Purkinje cells of the cerebellum, neocortex layers, that stuff. Also, the heart. Ever heard of a heart attack? It's kind of a thing, huh? So the subendocardium of the left ventricle is the most at-risk area. It's the furthest from the coronary blood supply and experiences the highest pressure during systole. Okay, now how about the intestines? There's some watershed areas that are vulnerable. One is the splenic flexure region. That's between the SMA and the rectosigmoidal junction. That's between the IMA and the hypogastric. It's poorly perfused, so you get hypotension and ischemic colitis in the elderly and post-op patients. Now, the big one is the retina. So those guys have high oxygen demand and there's no collateral flow. And so if you have central retinal artery occlusions, then you can have painless vision loss. No oxygen, central retinal artery is occluded. Cool beans. Okay, our next topic is going to be the sun. Mr. Sun came up and he smiled at me. So what is this crazy weird thing that I've drawn? That is a cholesterol precursor that's found in the skin. It plays 2 roles. And then 2, it's a precursor to vitamin D3. And it has to be exposed to UVB sunlight. So it's formed in the cholesterol synthesis pathway just before the cholesterol itself. And it plays a big role in vitamin D production. So in the epidermis, the UVB hits it. It converts it to pre-vitamin D3. And then vitamin D3, cholecalciferol, travels to the liver. And I'll write this down. And we get the activated 1,25-dihydroxy-vitamin D, which is calcitriol. And that's our active vitamin D. So skin, liver, kidney. And if you have kidney failure, then you can have low active vitamin D, right? Liver disease. And then sunscreen will cause decreased vitamin D synthesis. And I think we're ready for a question. So we have a 16-year-old male, moved to California, spending most days skateboarding on the beach. He's got the juice. Okay, anyways, past 3 months, he's grown 6 centimeters in height, increased appetite and energy. Alkaline phosphatase levels are within normal range for his age. Which of the following is most directly responsible for his increased intestinal calcium absorption? The answer is the transcriptional effects of UV-activated dermal cholecalciferol. So that's the conversion of that 7-dehydrocholesterol and the vitamin D3 in the skin. That causes our active vitamin D, and that helps us get our calcium and phosphate absorption. So here's the pathway. Irradiation, 7-dehydrocholesterol to cholecalciferol, vitamin D3. Liver makes it into 25. Kidney, through 1-alpha-hydroxylase, converts it to 125. And we get the transcription of our channels, and that binds calcium inside of the enterocytes, allows more calcium to be absorbed. So there's a pathway from the sun to calcium in your body, pointing to me, or thank you, sun. All right, this one's going to be super duper buzzy. We have a 70-year-old man presenting to primary care physician for evaluation of gait instability. His wife notices progressive worsening handwriting, difficulty rising from chairs, and hallucinations. They could also say cogwheel rigidity. This is definitely Parkinson. So what is the protein composition? The answer is alpha-synuclein. This is a memorization question. So what is alpha-synuclein? It is a neuronal protein that's involved in the synaptic vessels regulation and neurotransmitter release, especially dopamine, and it's found in the presynaptic terminals. And when it's misfolded, alpha-synuclein becomes insoluble and it can aggregate, and that'll cause Lewy bodies, right? And so this is involved in Parkinson disease, where the Lewy bodies in the substantia nigra, pars compacta, and I'll show you that. There we go. There's a healthy. There's a substantia nigra, right? You lose that dopamine. And another one is Lewy body dementia, and that's in the cortical neurons. So that would be our Lewy body dementia. So if you look at alpha-synuclein, you think, oh man, one's Parkinson's, one's Lewy body dementia. Yeah, but it's multiple things, right? There's also multi-system atrophy. There are a lot of alpha-synucleinopathies. But the pathophys is basically you have alpha-synuclein that misfolds. It can aggregate into like Lewy bodies, and then it impairs neuronal function and survival. So look out for Lewy bodies and also Parkinson's stuff, but the answer is definitely alpha-synuclein. Think of A for abnormal synapse, alpha. Okay, there is our explanation. I'll move myself out of the way so you can see. Lewy bodies, alpha-synuclein. Beta amyloid is Alzheimer's. Tau is Alzheimer's frontotemporal, so different changes in the personality. Lewy would have hallucinations, Lewy bodies. Prion protein associated with spongiform changes. TDP43 found in ALS. Okay, now for this one, we have a clinical trial. We're evaluating the antihypertensive drug utility. 40 patients in stage 1 hypertension are randomly assigned to receive either the new drug or a different one. 8 weeks later, we get the means, and we want to determine if there's a difference in the means. What are you going to do? Student t-test. It's how you compare the means of two things. Unpaired student t. Chi-squared, categorical data, male, female, dead, alive. Paired is when the same subjects are measured twice, before and after. ANOVA is for 3 or more, and linear regression predicts the dependent variable based on a couple independent variables. So a student t-test would calculate the p-value based on the difference of the means. This guy over here, you look at the difference between them, the standard deviations, the sample sizes, all that stuff, and if the p-value is less than 0.05, you reject the null hypothesis, and it means that this new method probably had an effect. Student t is 2 grouped means, paired t-test is before and after, ANOVA is 3 or more, and chi-squared is for proportions. All right, guys, hopefully that was helpful. We just finished 10 more questions. Please be sure to like and subscribe if you found this interesting. Make sure you guys get your physical exercise in today. Let's not waste any time. Let's dive right in. 17-year-old girl is brought to the emergency department with high fever, photophobia, and petechial rash. She has a history of 2 prior hospitalizations for Neisseria. That should immediately make us think of deficiency in the MAC complex formation. And indeed, our correct answer is the deficiency of the terminal complement components. All right, so this is a very easy question. I want to break it down simply. The terminal complement pathway, which is C5 to C9, forms what's called the membrane attack complex. And the MAC creates pores in the membrane of gram-negative bacteria. And so a deficiency in these complements, especially C6, 7, 8, or 9, causes an inefficient MAC formation. And that allows for these gram-negative bacterium, for instance, Neisseria infections, think Neisseria meningitis or Neisseria gonorrhea, to be able to form. And other infections are not as common because opsonization, which occurs via the C3b pathway, is usually intact. So this is a really basic immunology question. It's about the complement system. You should look for a deficiency in C5 to C9 if you have recurrent Neisseria bacteremia. All right, there's our explanation. Let's look at the trap answers and why they're wrong. C1 esterase inhibitor. So that deficiency causes what's known as hereditary angioedema, not infections. And the pathophys there is you have increased bradykinin because of the unchecked kallikreins, which are the family of the serine proteases that are involved in all sorts of things like blood pressure regulation, inflammation, tissue remodeling, all that stuff. So with C1 esterase inhibitors, you should think of the condition known as bradykinin-mediated angioedema because that's life-threatening swelling of the deep layers of the skin or the mucosal tissues. And this is actually different than histamine-mediated angioedema, which often includes like hives and itching. This type is non-pitting and it's not accomplished by urticaria. I don't want to get too deep into the weeds here, but this pathophys involves the contact system, which is a plasma protein cascade that's responsible for inflammation, and that causes an excessive accumulation of bradykinin. And bradykinin is a vasodilator that increases the vascular permeability and leads to fluid leaking from the blood vessels into the surrounding tissues. And so C1 esterase inhibitor, that's a key enzyme that normally inhibits that contact system. And so if it's deficient or dysfunctional, hereditary angioedema or something else, that will cause uncontrolled activation of the pathway. And then you have unchecked kallikrein activity, and plasma kallikrein will not be properly inhibited, and that's what causes the excessive bradykinin. Also be on the lookout for angiotensin-converting enzyme ACE. That's a metabolizer of bradykinin, and so if you give somebody an ACE inhibitor, that will block that process, and it leads to bradykinin buildup, and that can be a life-threatening angioedema. All right, so we dove way into that option. IgA deficiency would have recurrent mucosal infections. Does not explain the Neisseria, so think mucus for that one. Factor H deficiency, atypical hemolytic uremic syndrome that regulates the alternative pathway, which is not selective for Neisseria. And beta-2 microglobulin deficiency would be an absent MHC class 1. And so that's associated with CD8 positive T cell, which remember MHC 1 times 8 equals 8, whereas MHC class 2 times 4 would equal 8. So this is not Neisseria. But individuals who do not have the C5 to C9 complexes are at about 7,000-fold increased risk of getting Neisseria infections. Okay, so there are the buzzwords and the associations. One thing I want to note is that factor B and H should make you think of the alternative complement pathway. Factor B makes C3 convertase, and factor H regulates that convertase. And so if those are deficient, you have uncontrolled complement, and that's atypical HUS, not Neisseria infections. And then the other thing to know is that these beta-2 microglobulins are components of the MHC class 1 molecules, and so deficiency impairs CD8 positive T cell activation. The long story made short here, that recurrent Neisseria infection should make you think of MAC C5 to C9. All right, for our next topic, I like this title, Don't Drink and Dose. So let's dive in. We have a 21-year-old college student presenting with follow-up after beginning treatment for chlamydial urethritis with oral doxycycline. He reports that despite strict adherence to his dosing schedule, his symptoms have not improved over the last 5 days. Further questioning reveals that he takes his medication every morning with a bunch of milk products. Which of the following is likely the explanation for the reduced efficacy? The answer is complexation with dietary calcium. So we have a patient coming in with acne treatment using tetracycline, but it stops working when he has milk, essentially. So to answer this question, we have to know what tetracyclines are, like tetracycline, doxycycline, monocycline. These are bacteriostatic antibiotics that inhibit protein synthesis by binding to the 30S ribosomal subunit. And they are highly sensitive to a process known as chelation. And that's when the bi or polydentate ligand bonds with a metal or a metal ion, and it forms a stable ring structure known as a chelate ring. Usually chelation is a treatment for people who have too much metal in their body. It removes the metals and other elements, right? Because the chelator is attached to the metals in your body, and your body can then get rid of those metals through the urine and the feces. And as we were saying, are super susceptible and sensitive to chelation. So divalent cations like calcium, iron, magnesium, they bind to tetracyclines in the GI tract. And this forms insoluble complexes that cannot be absorbed, and so you have decreased bioavailability. And the thing that you should know then, okay, why are we talking about all of these awesome divalent cations? Well, milk contains calcium. Check the charge. Divalent. So that chelates tetracycline and it prevents its reabsorption. So this is an antimicrobial tetracycline question in the pharmacology realm. You do not take milk, that is to say calcium, a divalent ion, or antacids. Why? Because that's also going to have magnesium, which is also divalent, or any iron-containing preparations because divalent cations can inhibit the drug's absorption in the gut. A, enhance metabolism by hepatic enzymes. Nope, doesn't use the CYP heavily. C, competition with other ones. That'd be like warfarin displacement. It has nothing to do with the protein binding competition with warfarin. Degradation in acidic environment, that's acid labile drugs, and altered renal excretion. Doxycycline is mostly fecally excreted. So yeah, drinking milk can actually make your antibiotics stop working. Also be on the lookout for things like iron supplements. In another world, they could have asked this question differently. Calcium supplements, antacids, magnesium is divalent, even, zinc. Just be aware of the effect that chelators can have on tetracyclines and anything that binds the 30S subunit. In our next question, we have a 56-year-old woman presenting with worsening fatigue and decreased urine output over the past 2 weeks. She also notes spotting of blood after intercourse and pelvic discomfort. Her past medical history includes chronic tobacco use and no recurrent gynecologic exams. Lab results show elevated serum creatinine and BUN. Pelvic ultrasound shows bilateral hydroureters and hydronephrosis. No stones or masses are noted in the kidneys and ureters. Pelvic examination reveals ulcerated cervical lesion. Which of the following is most likely the cause of her renal findings? Before diving into the answer, I want to explain the lay of the land. Cervical cancer, when it's locally invasive, can spread laterally and involve the perimetrium and the ureters, especially near the uretrovesicular junction. And that is what's causing in this patient the bilateral ureteral obstruction, and that leads to the hydroureters, hydronephrosis, and postrenal azotemia. And what is postrenal azotemia? That's when you have an increased BUN to creatinine ratio. So this is a reproductive female gynecological tumor question. You just have to know the only common cancer that causes bilateral ureteral obstruction due to a local invasion. It's invasive squamous cell carcinoma of the cervix. It can invade locally and invade the ureters, and that can then cause the renal failure. And the most common site of the distant metastasis in cervical cancer is actually going to be the lungs. Now, I just wanted to clarify postrenal azotemia and how it relates to BUN and creatinine. So azotemia is just a fancy word of saying, hey, we've got elevated androgynous waste products, primarily BUN, and there are 3 categories that you should know. There's pre-renal, intrinsic, and post-renal. Intrinsic is where you actually have damage to the kidney itself. There you should think of acute tubular necrosis. Postrenal is an obstruction of urinary outflow. Stones, in this case, cervical cancer. And so in postrenal azotemia, what happens is you have an obstruction. The urine backs up to the Bowman space. If you have increased hydrostatic pressure, that reduces. Well, GFR depends on the Starling forces across the glomerular capillary membrane. There's a blockage downstream, right? Like cervical cancer compressing against the ureters. The urine
then backs up to the renal pelvis, and then in the collecting ducts and the tubules, and ultimately all the way into Bowman's space. Bowman's like, yo, because of this blockage, you're in my space. Now, why does this lower GFR? Well, that increased pressure in the Bowman space pushes against the filtration of the plasma from the capillary. And so even if glomerular pressures are high, the net filtration pressure will drop as the GFR decreases. Maybe a good analogy for this is imagine you're trying to pour water through a hose into a bottle, but then the bottle is like full and it's like sealed. That water has nowhere to go. And so pressure is going to build up and stop more water from flowing. So just to make sure that we're getting this topic right, and again, I don't want to go too much into the weeds, but this is super important. You should know what pressure increases in post-renal acute kidney injury, and that is hydrostatic pressure. And where does it occur? In Bowman's space. And then what's the immediate effect? It decreases the GFR. That's what's important. Okay, I felt like I had to explain that briefly. And you should know there are all sorts of BUN creatinine ratios. For pre-renal, you've got like 20-1 BUN to creatinine. For intrinsic, it's less than 15. It's at 15-1, but then later it's less, 15-1. So in early post-renal, the BUN is increased because urea reabsorption continues and creatinine stays low in the serum. But don't get too bogged down on that. This is just outflow obstruction, stones, BPH neoplasms. That's what we're looking at. Maybe even congenital abnormalities that stop that flow. It's post-renal. So obstruction, you have elevated BUN to creatinine ratio. Cool beans? I think those are some cool beans. All right, here are some of the answer choices. Clear cell would be a renal mass. High-grade serous. Carcinoma of the ovary might compress them if large, but it's less common. Bilateral unless it's super big. And adenocarcinoma of the colon, you'd have change in the bowel habits and obstruction would need to be extensive and posterior. So cervical cancer can cause kidney failure because it doesn't necessarily stay locally. It invades the tissues next to the cervix and it compresses the ureters. So yep, that's cervical cancer. All right, here we have a 62-year-old man. It could also be a female. Middle-aged, it could be a lot of things. I'm going to go ahead and pop up right here a 62-year-old man. So he's got a history of rheumatic heart disease presenting with sudden onset diffuse abdominal pain for the last 3 hours. He describes the pain as 10 out of 10 constant. On exam, he's AFib, diaphoretic, and has a irregular pulse. What's the mechanism behind his condition? The answer is a mural thrombus formation and embolization. So it's acute mesenteric ischemia due to embolism of the left atrial thrombus. He's got mitral stenosis, and it predisposes him to thrombus formation. So the SMA is the most common abdominal vessel that gets blocked in a cardiac embolus. And that's because you recognize the irregular results here, which is AFib. So the atria stops contracting effectively, and so the blood starts to pool. Then that causes a thrombus. So you can see this in several different ways. They could have asked about, a male, they have abdominal pain, irregular pulse. That's always going to be the case. And every single time you see that, it's AFib. They might say there's an opening snap or there's some diastolic murmur. That's mitral stenosis, right? And on imaging, you could see maybe the small bowel and colon distension. Basically, what's happened is there's acute mesenteric ischemia. There's embolization, which is the procedure where block or close off a blood vessel using a substance called an embolizing agent. And it's used to treat different conditions like abnormal blood vessels, internal bleeding, tumors, all that stuff. But the cause could be the embolization of the atrial thrombus due to AFib. So AFib causes the stasis of the blood in the left atrium, especially when it's enlarged, such as in mitral stenosis. And so that leads to thrombus formation, embolization to systemic circulation, and the superior mesenteric artery is super susceptible. Why? Because it's got high flow. A lot of blood going through there, and it's also got a narrow angle. And so you can have a sudden occlusion of the SMA that causes ischemia, and that's why the small intestine is having problems, and the transverse colon are having problems. It's sudden abdominal pain that is out of proportion to the exam. This is severe. In the question stem, we had severe pain, so it's not it. Hypotension-induced watershed infarction. That affects the splenic flexure and the rectosigmoidal junction. That's seen in shock states affecting the low flow areas, not the SMA. They could also ask about hemorrhaging. Well, that would lead to hypoperfusion and non-occlusive ischemia. So that's in the watershed areas like B. Spasm of splenic arteries. That'd be in cocaine use, intense vasoconstriction, and local thrombosis due to endothelial erosion. You don't have atherosclerosis history, so embolism is primary here. It's not some sort of a plaque rupture, right? That'd be atherosclerosis, like a coronary artery disease or something like that. And that can trigger a local thrombus, but it's a lot less likely in the embolism in somebody who has AFib and no atherosclerotic risk factors. And a thrombosis is very possible, but you'd have to look out for something like a hypercoagulable state, antiphospholipid syndrome, or cancer. So it's less likely in the embolism. If somebody's got AFib, that's usually going to be the cause of the embolism. So the most common artery that's affected by embolic acute mesenteric ischemia is definitely the SMA. And the classic EKG finding is irregular rhythm, and that's AFib, and the valvular disease that predisposes you to AFib, and also left atrial enlargement, which is the cause of this patient's condition, is mitral stenosis. All right, in our next question, we have a 60-year-old woman with a 10
your history of poorly controlled type 2 diabetes. This could also be a man as well. So I've got my demographic photo representing that. Discomfort in the lower legs for the past 3 months. She says the pain is worse at night and describes it as tingling fire ants crawling up from my feet. She finds some relief warming her feet. On exam, she has decreased vibratory sensation and pinpricking of below the knees, diminished ankle reflex, and intact motor strength. Which of the following describes the nature of her pain? The answer is burning pain. And what we have to do is recognize that male or female, what this patient is experiencing is called, it's diabetic peripheral neuropathy. The most common type is symmetric distal sensory motor polyneuropathy, and it's burning. Because neuropathic pain is described as burning or tingling, electric shocks, pins and needles. That's what people feel. It's worse at night. And that's because it's unmasked whenever it's not, the patient's not distracted. It's improved by warmth, like a hot bath, and vasodilation can actually improve that microcirculation. So what we have here is an endocrine question, diabetes, diabetic complications. We have a symmetric distal sensory motor polyneuropathy, glove and stocking distribution with burning and tingling pain. Stabbing is for radiculopathy or localized nerve impingement. Cramping for muscle fatigue, aching, musculoskeletal or inflammatory pain, and tightness could be spasticity or claudication. And what's crazy is 50% of diabetic patients develop peripheral neuropathy sometime in their life. So it starts with just some numbness, maybe some tingling in the toes. Then you have a lot of burning pain that people recognize in the nighttime. It's not colicky pain that's seen in visceral pain, like the renal colic or bowel obstruction. And it's like often sharp. And the cramping itself is often due to muscle ischemia or an electrolyte imbalance. A sharp pain is somatic pain and trauma, not burning or electrical pain. And so they might also ask you what type of nerve fibers are affected first in diabetic neuropathy. And the answer there is the small fibers, pain and temperature. That explains the burning pain. And those guys are the vibration fibers, the proprioception fibers. And so the treatment for this is you give them TCAs, which is kind of confusing at first, but amitriptyline is what you give these patients. SNRIs like duloxetine and gabapentin or pregabalin, but you have to avoid long-term treatments of like opioids. Those are not first line for neuropathic pain. Neuropathic, you give them a TCA, SNRI, or gabapentin. All right, so diabetic, small fibers to large fibers, burning pain, TCAs, SNRIs, gabapentin. That's the lay of the land. That's what you need to know. All right, next, a 48-year-old man with a 25-pack-year history of smoking presents to his primary care physician with motivation to quit smoking. This could be male, female, obviously, so my demographic just chosen a female. He's tried nicotine patches and bupropion without success. He is prescribed a medication that mildly stimulates nicotinic receptors while simultaneously reducing the reward effects of nicotine. What's the pharmacologic classification of this agent? It is a partial agonist at the nicotinic acetylcholine receptor. So we have a heavy smoker, right? They could have tons of packs a day for a long time, and they've tried quitting and they need pharmacologic help. And so the doctor will choose a drug that has to do two things. One, has to reduce cravings, and it also has to block the CNS stimulation from nicotine. So we need a drug that acts at the nicotinic receptor but is not fully activated. And so we need a partial agonist. So they've given them Chantix, also known as varenicline. It's the partial agonist at that nicotinic acetylcholine receptor. In the CNS, it stimulates the receptor just enough to reduce these cravings, but it also blocks the full activation of nicotine, so it blunts that reward pathway. And so the dual action helps people prevent and reduce their withdrawal syndromes, but also prevents the relapse because it makes smoking less rewarding. So pharmacologically, you have the psych drugs that cause the smoke cessation here, and it's cycline as a partial agonist at the nicotinic receptors. Now, it's not a complete agonist, right? Full agonists like nicotine itself would just activate the receptor fully. And so you need replacement therapy like patches or gum to do that. But it would not block the CNS stimulation. It would just mimic smoking. Antagonists would block nicotine from binding, but it does not reduce the cravings. Bupropion is close. It's an atypical antidepressant, and it's also a nicotinic antagonist and dopamine norepinephrine reuptake inhibitor, but it's not as effective at reducing those cravings directly. And it's not an inverse agonist because that's rare in a clinical pharm. And that would do the opposite of the receptor activation. So that would even worsen the withdrawal. So you definitely would not use that there. And so we have to know for this question, what is varenicline's mechanism of action? And for that, we have to know it's a partial agonist of the alpha-4 beta-2 nicotinic acetylcholine receptor. And what are the major side effects of it? Nausea, vivid dreams, neuropsychiatric symptoms like depression, suicidal ideation. But we should also know some pharmacologic options for smoking cessation. So we talked about varenicline, that's partial agonist. We also have talked about bupropion, that's norepinephrine and dopamine reuptake inhibitor, and also a nicotinic antagonist. And then there's nicotine replacement therapy, just the gum and the patches. That is a full agonist. And so the question is, why do we care about nicotinic receptors in smoking cessation? Well, nicotine and nicotinic receptors, what's the connection there? Because nicotine binds and stimulates the nicotinic acetylcholine receptors in the central nervous system, right? That's how nicotine works. And so nicotine is an exogenous agonist at the CNS nicotinic receptor. And so you have a dopamine release because of that, and that causes the addiction. It's the dopamine release, the nicotine, exogenous influence, nicotinic receptors, nicotine, nicotinic, dopamine. That's the whole shtick. And so nicotine crosses that BBB, the blood-brain barrier, and it binds to the alpha-4 beta-2 subtype of the acetylcholine receptor in the ventral tegmental area, the VTA, and that leads to the dopamine release into the nucleus accumbens, and then you have reward. You're like, oh my gosh, I really love that sensation. And so varenicline helps because it's a partial agonist at the alpha-4 beta-2 receptor of the nicotinic acetylcholine receptor, and it stimulates just enough to reduce those cravings. It's a partial dopamine release. It's like, okay, I kind of like that, but it also blocks the nicotine from binding, right? So it blunts the full reward. And so you get less withdrawal, less reinforcement if you relapse, and it's easier to quit. So varenicline, partial agonist at the nicotinic acetylcholine receptor. Cool beans? Got to reduce those cravings. Got to block that nicotinic reward. All right, our next question, we have a 42-year-old man presenting with 10 days of severe right-sided headaches. The last 20 to 40 minutes, he says the pain is excruciating, centered behind his eye, occurs daily at 2 a.m., waking him from sleep. So this is recurrent, unilateral, short-duration, severe headache with autonomic features like trigger pattern, with alcohol, and also like a nocturnal timing. So all these things are pointing us to a cluster headache. And that is indeed our answer. So we have recurrent, short duration, severe headaches. Oftentimes what they'll do is they'll pick a side. Usually they'll say like, we got the left side. It's like 30, 60 minutes. It occurs daily. Usually at night, there's some tearing and redness of the eye, and it's ipsilateral. There's nasal congestion that's also, and then when we drink alcohol, it causes more pain to occur. So basically what you should look out for a cluster headache is unilateral and severe, and it's behind the eye or the temple. And it's associated with autonomic symptoms on the same side. So think lacrimation, conjunctival injection, nasal congestion, rhinorrhea, and sometimes ptosis or meiosis, like partial Horner syndrome. And it occurs in clusters. You should also know that 100% oxygen is abortive and verapamil is prophylactic. So migraine with autonomic features, these are longer, 4 to 72 hours, and not male predominant. Paroxysmal hemicrania, response to endomethacin. That's going to be rare in men. And also, you're really not going to see that tested on step 1. Many more frequent attacks would be seen there. Trigeminal neuralgia would have electric shock pain that's triggered whenever you touch something. Temporal arteritis is jaw claudication, and the ESR would be elevated. And here you have vision changes as well. So alcohol is the trigger, but it's not. The pathogenesis involves the hypothalamic activation, not just vasodilation. Allergic rhinitis can mimic some of the symptoms like lacrimation and congestion, but it's usually mild, not painful. It's not just basic allergies, right? There's no like severe headache there. It's not triggered by alcohol, would not be non-episodic. And it's not like a CNS neoplasia, because there you'd have the brain tumors that are progressive and constant dull headache, and it's often worse in the morning or with a Valsalva maneuver. And it would not cause a reproducible, short, sharp daily attack, especially wouldn't have ipsilateral autonomic symptoms. And that giant cell arthritis we talked about, another big factor there is it occurs in patients that are greater than 50 years old. Headache is often diffuse and it's localized to the temples. And it's seen with jaw claudication, vision loss, and elevated ESR levels. This patient is actually pretty young, relatively speaking, and so it's not going to be a jaw claudication issue with temporal arteritis, giant cell arteritis. So yeah, the first line abortive treatment for the cluster headache is 100% oxygen. Give them a non-rebreather mask, and first line prophylactic is verapamil. And what helps you distinguish this from other headaches? You have the male is greater than female, nocturnal onset, seasonal pattern. And the pain is like super, super severe. That's cluster headache. All right, here we have a 2-year-old boy. It could be a girl as well. So I've given the demographic picture of a girl. Looks like she's tugging on her ear. She's got some fussiness, runny nose and cough, pulls her ear and she cries. Which of the following describes the anatomical route? The answer is pharynx to the auditory tube to the middle ear. This is acute otitis media because it travels in the nasopharynx to the middle ear via the auditory tube in young children. Inflammation traps and you get the infection. So oftentimes they have a history of chronic otitis media, and they have a sore throat, mild cough, ear pain, irritability. They pull on their ear, that kind of stuff. There's usually some fluid behind the tympanic membrane, and all of that leads you to think of acute otitis media. And so you have to know the way that spreads. So the eustachian tube is another word for the auditory tube. And that's why students will miss this particular topic, because they don't realize the eustachian tube is the auditory tube. And it connects the nasopharynx to the middle ear. And so in children, you have a really tiny, short, and wide tube, and it's more horizontal than in adults. And that makes it easier for upper respiratory infection pathogens to ascend from the nasopharynx into the middle ear. And so you have the result of fluid accumulation and inflammation, which is, going to lead to otitis media. So this is just like head, ear, nose, and throat question, otitis media, infection of the middle ear. The pathogens ascend from the nasopharynx via the eustachian tube to the middle ear. It's not the laryngopharynx. The eustachian tube connects to the middle ear, not the inner ear. Oropharynx, there's no communication like that. Nasal is unrelated to the cochlea. Tracheal is part of the lower respiratory tract. There's no direct connection to the eustachian tube. And mastoid to middle is adjacent to the middle, but the secondary sites of infection. And this is actually super common. 80% of children are going to experience at least one episode of otitis media in their life by the age of 3. It's that horizontal construction in the young little kids, the shorter ear, the wider ear, the horizontal ear, all that stuff. Acute otitis media goes through the eustachian tube to the middle ear. All right, if anybody asks, just say that my numbers are modern art because that is a wonky looking 3. In this question, we have 800 adults after 3 months, 180 in the intervention and 40 skipped multiple sessions. We want to see the primary outcome based on the original group. This is intention to treat, so you analyze all based on the initial group allocation. This is super simple. It's just intention to treat analysis. All participants are analyzed in groups that they were in originally. That's all there is to this. It's super simple. Intention to treat. Moving on to the next one. All right, step 1 loves to ask about anastomosis. We have a 68-year-old man with a history of hypertension and smoking undergoing elective open surgical repair of the infrarenal abdominal aortic aneurysm. Intraoperatively, the left testicular artery is ligated to allow vascular access. Postoperatively, he has no signs of testicular ischemia. Which artery is most likely maintaining perfusion to the left testes? All right, so the key to this question is knowing where the testicular artery originates and who backs it up when it's lost. The answer is the artery to the ductus deferens, if the testicular artery is damaged or ligated. So this is just an anastomosis question. So here's the explanation. Superior vesicular artery supplies the dome. Internal pudental gives rise to the scrotal branches, but not anastomosis with the testes. Middle rectal artery supplies the rectum. Superficial epigastric is a branch of the femoral artery, supplies the lower abdomen. All right, so this is just an anastomosis question. And on the step exam, you can see a lot of these anastomosis questions. Like there's the SMA to the IMA. If you have a AAA repair, then the IMA is sacrificed, so you need the SMA collaterals. Here's a practice question about that. Basically, a guy undergoes a procedure. What do you do? Middle colic via the arc of Reolin, that's the collateral pathway for the middle colic artery. So just know that the SMA touched the IMA. And there are all sorts of anastomoses to know, like GI tract, SMA, IMA, celiac with SMA, portal with systemic. You have esophagus, the esophageal varices, rectum, the anorectal varices, and the umbilicus, the caput medusa. That's the paraumbilical with the epigastrics. Rectum has the superior rectal with the middle inferior, and left gastric with the azygos. The pelvic reproductive, you have testicular ovarian artery with the artery of the ductus deferens or the uterine artery. So uterine, ovarian, artery of the ductus deferens, testicular. Know those two things together. Uterine artery, ovarian artery. In a hysterectomy, ligation of uterine artery must spare the ureter, and ovarian artery preserves the perfusion to the ovary. In the thoracic wall, you have internal thoracics and intercostals, bronchial and pulmonary arteries. In the lower limb, you have inferior epigastric and superior. The deep circumflex with the iliolumbar supplies the iliac crest. The brain has the circle of Willis, anterior and posterior communicating arteries. And so here's a big old list. These are all the anastomoses that you probably need to know on test day. Celiac SMA, ovarian uterine, portal systemic, SMA IMA, bronchial pulmonary, IMA external iliac, thoracic, intercostals. If you guys found this helpful, then please consider liking and subscribing, and we'll see you guys in the next video. Hello everybody, welcome back. We're on NBME 29-141. These are all original questions. Here we go. A 55-year-old woman with long-standing history of autoimmune hepatitis presents with confusion and irritability. Now in this question we have a woman, but in the relevant demographic I've displayed a man, and that's just to demonstrate how you shouldn't be locked into the female demographic for this particular condition. But I'm going to go ahead and change it to a female now. You can visualize this patient. Her daughter reports the patient was recently treated for cellulitis and hasn't had a bowel movement in 3 days. Vital signs are stable. On exam, she is disoriented and has flapping tremor when asked to extend her arms. Her abdomen is distended. Labs show AST of 86, ALT of 74, ammonia is 118, BUN is at 10, creatinine is 0.9. Which of the following best explains her symptoms? So that flapping tremor is called asterixis. And the correct answer to this question is hyperammonemia. It's hepatic encephalopathy triggered by constipation and infection, leading to elevated ammonia and CNS toxicity. Asterixis is the key sign, that flapping hand tremor. And that is due to metabolic encephalopathy, which is most often from hyperammonemia. And you can also see cirrhosis, that's portosystemic shunting and decreasing the ammonia clearance. And if you decrease the ammonia clearance, then some of it can actually cross the blood-brain barrier. And that can cause astrocyte swelling and then cerebral edema. And so the symptoms that you'll see in a patient who has this disorder or who has a lot of ammonia would be confusion, drowsiness, asterixis, stigmata of cirrhosis like jaundice, spider angiomata, as caput medusae. Some things that precipitate this are GI bleeds, infections, hypokalemia, constipation, sedatives. And for treatment, you give them lactulose and rifaximin to reduce the gut flora ammonia production. So if you see that flapping tremor and cirrhosis stigmata and altered mental status, then it's going to be hyperammonemia or hepatic encephalopathy. And that can be the case even if they don't literally give you the ammonia levels. So just to make sure we got this down, a question that you should be able to answer is, what is the pathophysiology of astroxis in cirrhosis? And that's the buildup of ammonia, right? It's the impaired astrocyte metabolism. And the astrocytes are the glial cells, which are non-neuronal cells that support and protect the neurons in the central nervous system, the brain and the spinal cord. You should also know of some other systemic conditions besides liver failure that can cause astroxis, and that would be renal failure, uremia, and hypercapnia, which is CO2 retention. So let's talk about the difference between hepatic encephalopathy, and you do need to know this for step 1, and uremic encephalopathy or renal failure. So in hepatic, you start with the cirrhosis. That leads to a CO2 necrosis, causing dyspnea, confusion, cyanosis. COPD exacerbation and astrocysis can be seen there. But those are the only causes on step 1 that would lead to astrocysis, which is the flapping tremor. And it's actually defined as the sudden brief lapses in sustained posture whenever, like the hand is flapping, whenever the arms and wrists are extended. But I would conceptualize this as metabolic encephalopathy. Encephalopathy is just a fancy way of saying conditions that affect the function of the brain and cause changes in the mental state. Anything that disrupts the brain's normal activity and leads to symptoms like confusion, altered consciousness, and seizures would be classified as an encephalopathy. So that could be infections, viral, like encephalitis, bacterial, like meningitis, or even parasitic infections. It could be trauma, head injury, stroke, tumors, autoimmune disorders, multiple sclerosis, lupus, and even genetics. But encephalopathy most commonly would be confusion, altered mental state, seizures, memory problems, difficulty speaking and understanding language, that sort of thing. Usually when we diagnose it, we do blood tests for infections, metabolic imbalances, and imaging studies due to CT or an MRI of the brain to rule out structural abnormalities. And you can also get an EEG that monitors the brain activity and detects seizures. All right, that about wraps it up. Let's go to the next question. 142, we have a 68-year-old woman with a history of chronic insomnia and weight loss. It started on citalopram after being diagnosed with major depressive disorder. This medication primarily enhances the serotonergic signaling from neurons located at which structure? Well, it's serotonin, the Ralph nuclei. So SSRIs inhibit the reuptake of serotonin. We all know this. And the Ralph nuclei is the primary search nuclei. And so you should really pick this with anything related to serotonin. Now, you have cell bodies in the midline brainstem reticular formation, like the midbrain, the pons, and the medulla. And the neurons here convert L-tryptophan to serotonin, 5-HT. And they project widely to the cortex, the hippocampus, the hypothalamus, and the spinal cord. So fluoxetine, sertraline, paroxetine, those guys all block the serotonin transporter. And so you increase the serotonin in the synaptic cleft. That obviously increases your sleep, your appetite regulation. So serotonin is synthesized in the RAF nuclei. So here I've updated the patient demographic for this question. Here's some trap answers and why they're wrong. VTA is dopaminergic, involved in the reward. We had a question about that on our last set of 10. Hypothalamus regulates homeostasis, but not the source of serotonin. The locus coeruleus produces norepinephrine. Nucleus bacillus is cholinergic, so it's important in Alzheimer's. This is just depression. You should know the mechanism of serotonin causing 5-HT to stay longer in the cleft. L-tryptophan is a metabolic precursor for serotonin synthesis. Okay, for the next question, it could be a man or a woman. Here we have a 41-year-old man with chronic tension-type headaches has started on a new medication for prophylaxis. 1 week later, he presents with abdominal bloating, constipation, and difficulty urinating. Vitals are stable. He has dry mucous membranes and decreased bowel sounds on exam. Neurologic exam is normal. Which of the following neurotransmitter effects is most likely responsible for his current symptoms? So here's our patient demographic. Well, it could be a female. And our answer is D, muscarinic acetylcholine receptor blockade. So they have constipation and dry mouth and urinary retention. Those are anticholinergic symptoms. And this could be because they use a tricyclic antidepressant to stop the headache. TCAs block muscarinic receptors. Now, this is really interesting because the question stem is going to give you constipation and they're going to give you urinary retention and they started a new antidepressant, or they'll have you infer the antidepressant. Feeling blue, started on something new. Constipation, urinary retention. Okay, so all these things are happening at once, and you have to know the mechanism of action because they're going to ask like which neurotransmitter blockade is actually causing this. And so tricyclic antidepressants, these are known as TCAs, they are less selective, and so they block a lot of things. They block 5-HT and norepinephrine uptake, and that's the therapeutic part of it, right? They're muscarinic acetylcholine receptor blockers, and that is going to contribute to the side effect profile. You typically don't want those, but that's how they're going to test you. Because of that constipation, that urinary stuff is because of that muscarinic acetylcholine receptor stuff. And it's because the TCAs, which were taken for the depression. So the depression was treated with TCAs. The TCAs caused, through the blocking of muscarinic stuff, the constipation and the urinary symptoms. That's the way these problems work. And that's why I think they're kind of interesting. They're good questions. Now, they also can block the histamine. These are H1 receptors, and that causes sedation and weight gain. They block alpha-1 adrenergics. They block the muscarinics. and that causes the anticholinergic effects, the urinary retention, constipation, the dry mouth. And they're going to try to get you, anytime you see a question about TCAs, they'll try to trick you in all sorts of ways. One of them that they love asking is dopamine. And dopamine is blocked by antipsychotics, causing extrapyramidal symptoms. You might see some hyperprolactinemia, but not constipation and urinary problems. So it's not going to be dopamine associated. And let's look at the answers here. So dopamine antagonism would be antipsychotics, not constipation. Alpha-1 blockade causes orthostatic hypotension. H1 antagonism, sedation, weight gain, and GABA agonism would be benzos and barbs, sedation but not anticholinergic effects. So yeah, antidepressants can make you stop pooping, at least TCAs. All right, so those are the buzzwords: dry mouth, urinary retention, constipation, hot as a hair, dry as a bone, blind as a bat, red as a beet, mad as a hatter, anticholinergic, toxidrome pneumonic. Elderly patient, they're super sensitive to it. TCAs, the triptylines for MDD, also for migraine prophylaxis, and the blocking of the H1 receptors can cause that sedation, and the alpha-1 adrenergic blockade causes orthostatic hypotension. There's the pathophys that we kind of talked about. It is blocking the muscarinic receptors, and so you have less contraction of the bladder, less peristalsis, and that would be urinary retention and constipation, respectively. Blockage of the salivary glands, that's the dry mouth, and the central effects of delirium and confusion in the elderly. I think we covered that question pretty thoroughly. Okay, so the next question, we have a 28-year-old Olympic sprinter who has undergone muscle performance testing. During the experiment, her vastus lateralis is electrically stimulated to contract under isotonic conditions at varying loads. Researchers observed the maximal shortening velocity of the muscle does not increase beyond a certain point, despite higher frequencies of stimulation and sufficient ATP availability. What determines the maximal velocity of muscle fiber shortening under these conditions? The answer is myosin ATPase activity. Now here I actually want to go up to the buzzwords first: cross-bridge cycling. You know about the actin and the myosin heads. ATP hydrolysis is required to reset the myosin, and isotonic contraction is when the muscle shortens under constant tension. And the rate-limiting step here is how fast myosin can detach and recock and reattach. It's biochemical, it's not electrical. Type 2 is the fast fibers, higher myosin ATPase activity. Thyroid hormone increases expression of the fast myosin heavy chains. And so faster ATPase causes faster detachment and attachment and quicker shortening. And here's the motor neuron fires, acetylcholine is released into the neuromuscular junction, then it depolarizes, calcium is released, exposes the actin, myosin binds the actin, power stroke, sarcomere shortens, ATP binds myosin, detaches from actin, hydrolyzed, restocks, and so it's the rate of the shortening that affects the rate of the cycle. Now, isotonic contraction is when the muscle generates a constant tension while the length is changing. That's isotonic contraction. There's concentric, that's muscle shortening while contracting, and there's eccentric, that's muscle lengthening under the tension. The speed of shortening is determined by how fast the cross bridges cycle between actin and myosin. I remember they tested me on the actin-myosin binding. In one of my biology classes at Harvard, we had to list all of the steps to the cycle, and I think that's overkill. But I would say one of the most important things to know is that first you have the myosin and the ADP, the binding of the actin, the cross bridge formation, and then ATP binds myosin, and that's the detachment phase. And then you have ATP hydrolysis, and that's where the myosin is recocked and the cycle will repeat. So faster ATP binding and hydrolysis means you have faster myosin cycling, which means you have faster sarcomere shortening. And so the rate of the cross-bridge turnover determines the max velocity of the isotonic contraction. Wow, we got in the weeds there. Let's make this super simple. Isotonic contraction are the changes in length under constant load. The speed is determined by how fast the cycle happens. Faster cycle, faster shortening. Okay, 3 things we need to know. What determines max velocity? That's the rate of the cycling, the ATP turnover. And in smooth muscle, why is contraction slower? That's because the cycling is slower, which allows for sustained tone. Okay, and if any of you guys are like, oh my gosh, what's going on? Then look at these buzzwords right here. And you see this right here, lifting a dumbbell. That's where the muscle shortens while you're holding a constant weight. That would be isotonic contraction. The muscle is shortening while holding a constant weight. What makes the muscle shorten? The myosin pulls the actin. That causes the sarcomere to shorten, and then the muscle shortens. What controls the speed of that though? Well, the speed is how fast the myosin head can grab the actin, pull and do the power stroke, let go, where the ATP binds, and then reset and try again. That cycle is called the cross-bridge cycle. And so faster recycling means faster shortening. And they can try to trip you up in all sorts of ways. They could ask about the action potential amplitude, the frequency. Well, the amplitude is just all or nothing, right? It doesn't change how fast the contraction happens. The frequency, more frequency, would just mean stronger force, not faster shortening. And it actually does not involve your sodium, potassium ATPase, because that's just involved in the maintenance of the ion balance, not the contraction speed itself. So the big takeaway here is the maximum rate of muscle shortening depends on how fast the myosin heads cycle cross bridges with actin, and that's powered by ATP. So if you choose ATP on that, you'll be right. The force is how many cross bridges are working, and the speed is how fast the cross bridge cycles. All right, this could be a boy or a girl. Here we have a 6-month-old girl is evaluated for macrocephaly and delayed motor milestones. Her parents report she's unable to sit, unsupported, and has poor head control. Physical exam shows hypotonia and increased head circumference. Neurologic exam reveals downward gaze and increased limb tone. MRI of the brain demonstrates a large fluid-filled cavity in the place of the cerebellar vermis, enlargement of the fourth ventricle, elevation of the tentorium. Which of the following embryological structures is most likely implicated in this patient's condition? And we have all these classic answers. So we unfortunately have to know the step 1 embryology chart for the brain vesicles and the adult derivatives. Now the diencephalon is derived from the prosencephalon. The adult structure that is formed is the thalamus and the hypothalamus and the retina. And this is from the third ventricle. The mesencephalon is derived from the mesencephalon. And the adult structure that's formed would be the midbrain. And you should associate the mesencephalon with the cerebral aqueduct. The metencephalon is derived from rhombencephalon, and that gives rise to the pons and the cerebellum, and that's the upper fourth. And the telencephalon is derived from the prosencephalon, and that forms the cerebral hemispheres, basal ganglia, and it's associated with the lateral ventricles. Okay, so the metencephalon would be associated with your pons, cerebellum, fourth ventricle, that's Dandy Walker. The mesencephalon, of the midbrain, that'd be associated with cranial nerve 3, 4 nuclei, and the cerebral aqueduct obstruction, so hydrocephalus. The diencephalon would be the thalamus, the hypothalamus, and the retina. And there you'd see like craniopharyngioma, compressing the hypothalamus. And the telencephalon, defects in the telencephalon would cause holoprosencephaly. And so if the question mentions the cerebellum and the fourth ventricle, then you should think of the metacephalon. And if it mentions the cerebral hemispheres and the lateral ventricles, then you should think of the telencephalon. L for lateral. Telencephalon, lateral ventricles. Telencephalon, lateral ventricles. Midbrain, M for midbrain. And so here it's the cerebellum and the fourth ventricle that we're talking about. And so it is the metencephalon. This is Dandy Walker malformation, failed development of the cerebellar vermis. They're the trap answers and why they're wrong. And so the hindbrain, specifically the metencephalon, is supposed to form the cerebellum and the fourth ventricle, but it's not here. All right, next we have a 6-year-old boy presenting with evaluation due to rapidly growing nodular lesions on his scalp and cheeks. His parents mentioned that he's allergic to the sun, reminds me of bench warmers, and had frequent blistering sunburns after brief outdoor play during infancy. All right, this could be a female as well, but I'm going to go ahead and give you both. So I'll generate a photo of this patient over here. There we go. Which of the following DNA processes is most likely defective in this patient? Blistering sunburns. All right, this is xeroderma pigmentosum. How do I know? Early onset, photosensitivity, and increased cancer risk. You'll see recurrent blistering, severe sunburns after sun exposure. That's why they said he's allergic to the sun. Also freckling, dry, atrophic skin. And the mechanism for this is kind of one you just memorized. In fact, one of the earliest videos of the 790 I have on my channel was about nucleotide excision repair. Now, how this works, I'll go over to 146, is it starts with the sun, right? The sun has UV light, and that forms pyridamine, thymidine, dimers. And nucleotide excision repair removes those. So it's doing a great job removing those. And the mechanism is endonuclease cuts out the damaged DNA segment. DNA polymerase fills in that gap, and DNA ligase seals the strand. That's the mechanism by which nucleotide excision repair deals with the formation of pyridamine dimers by UV light. But if you have a defect there, then your pyridamine dimers will persist, and you have mutations and skin cancer. The sun is indeed a deadly laser. And so this occurs in the G1 phase of the cell cycle, and you see skin cancer in children. I would have designed it differently, but it was not up to me. And they'll try to get you with different answer choices. For instance, base excision repair. What's that all about? Well, that's just fixing the damaged bases, right? The deamination of cytosine to uracil, not UV dimers. They could also get you with mismatch repair. That fixes the DNA replication errors. And anytime you see mismatch repair, you should immediately be thinking of Lynch syndrome. ATM kinase. Ataxia telangiectasia. You'll see recurrent infections and cerebellar atrophy. Exonuclease proofreading. That'd be errors in DNA replication, not the UV damage. Base excision would be from oxidative and alkylated base damage. Mismatch repair, microsatellite instability, think Lynch. So if you see on test day a kid who's not old enough to even ride a bike and he already has skin cancer, then what's actually happening is xeroderma pigmentosum. There's the pathophys that I kind of spelled out earlier. You accumulate those oncogenes and the tumor suppressor mutations because that NER pathway does not identify the bulky lesions and remove them via endonuclease. So you could definitely see endonuclease as an option here. In fact, I believe in the UWorld Bank, there is a question where the answer is endonucleases, and it's xeroderma pigmentosum. You can see why. That's how they ask about this condition. UV light exposure, how do you get rid of them? Endonuclease activity, but it's defective here, so you get skin cancer in a young kiddo. All right, next question. Okay, here there is a 69-year-old man with diabetes. It could be a female as well, probably a similar age though. Undergoing emergent percutaneous coronary intervention for an inferior ST elevation myocardial infarction. Coronary angiography reveals a left dominant circulation and critical stenosis in the vessel perfusing the diaphragmatic surface of the heart and atrioventricular node. They plan to place a stent. Through which vessel must the catheter pass in order to reach the affected vessel? All right, I'm going to update the patient demographic so you can see this particular patient that we're talking about. Here he is. Nice guy. All right, now this question is easy to miss unless you have all of the blood supply of the heart down pat. We have to go from the left coronary artery to the posterior descending. Now, the way to think about this for exams is a right dominant heart is different from a left dominant heart. And in right dominant, the RCA gives rise to the PDA. But in a left dominant heart, the left circumflex gives rise to the PDA. That's the difference. And if it's codominant, then both the RCA and the left circumflex contribute. So there's a patient with a left dominant circulation, and so the catheter has to be put in the circumflex, and then it goes to the PDA. It's kind of like a memorization thing. Now, if it's right dominant, then sure, it's just the right coronary artery. That's 85% of the cases. The RCA supplies the PDA and the AV node. But in left dominant, the left circumflex supplies the PDA and the AV node. Now, I want to make this simple for every single heart supply question that you ever get in the future. Let's name the arteries, for instance. Here we have the anterior interventricular artery, LAD, and that supplies the anterior left ventricle wall, the anterior 2/3 of the interventricular septum. So left coronary gives rise to LAD, and it supplies the anterior 2/3 of the interventricular septum. Left coronary also gives rise to the left circumflex. That supplies the lateral and the posterior left ventricular wall. Now, the aorta gives rise to the right coronary artery. That would involve the inferior wall of the left ventricle. And then this question is asking about the tough case with our PDA, posterior descending. And that's tricky because in right dominant individuals, it's the RCA, but in left dominant individuals, it's the left circumflex. Okay, so the PDA is the weird one. And the way to think about this is like public display of affection. I just think it's right. You're right if you think it's right, PDA. And you're left alone if you circumvent the PDA. Whatever gets you there. But most of the time, the PDA origin comes from the right coronary artery. Most of the time. It's like in 85% of people. But they always have to ask about the 5 or the 8% of people from which it comes from the left circumflex. And that's the left dominant heart. And sometimes it's codominant as well. So left dominant, you really got to watch out. And if it's left dominant, it's probably going to be the circumflex. That's how I think about it. All right. In our next question, we have a 6-year-old boy brought to the clinic with recurrent joint swelling and behavioral issue. He bites. Oh, that's sad. Self-mutilation. All right, so that immediately cues us into C. This is Leishman syndrome. You treat it with allopurinol and febuxostat. That's the decreasing of the xanthine oxidase activity. This is one of the first conditions that I covered in my, I believe it's NBME 26, question 1. Yeah, this is like one of the saddest little conditions. It's intellectual disabilities that are seen since infancy. You know, the biting of the lip and the fingers. You have severe gout as well. Uric acid crystals, hematuria, and flank pain. It's an X-linked inheritance pattern. You should watch the NBME 26 recap video where I covered topics like this. But HGPRT is the key enzyme in the purine salvage pathway and its function to turn into GMP. Definitely go watch that video if you want a more in-depth explanation, but without HGPRT, you cannot salvage purines. And then they get shunted into degradation. And then that increases the uric acid, and that leads to gout, kidney stones, and then the neuro symptoms. You treat it with allopurinol and febuxostat. That blocks the xanthine oxidase to decrease the uric acid production. But it's Leishman syndrome is absent HGPRT. A way you can remember this one is, you know, it's a really sad symptom that they have, the self-biting and stuff. And you could think that they have an absent parent. And then I like to think of HGPRT. The PRT kind of sounds like parent, absent parent. Helps me remember that Leishman syndrome with the poor behavior in the child, the neurosymptoms caused by the increase of that uric acid is because of like absent parent behavior. Whatever helps. Increasing uric acid, intellectual disability, self-mutilation, aggression, gout, and chorioathetosis. And that's just a movement disorder that's marked by a combination of chorea with the rapid, jerky, and involuntary movements, and athetosis, which involves the slow wiring and twisty movements. All right, so there's the explanation. Adenosine deaminase is SCID, orotate phosphoryl transferase is megaloblastic anemia unresponsive to B12. Xanthine oxidase is treated with allopurinol. Carbamyl phosphate synthetase 2 is a de novo pyridamine synthesis defect. This is a purine salvage pathway. And they could try to confuse you. They could give you glycine pathways, which would cause encephalopathy if it were defective, or they could give you serine problems, or even xanthine oxidase. But xanthine oxidase converts xanthine to uric acid, and so deficiency causes decreased uric acid and increased xanthine stones, which is the opposite problem. There's not a deficiency in xanthine oxidase. It's quite the opposite, my friend. So, yep, gout, aggression, retardation, tonic movements, dystonia. That's what you should look out for. HGPRT. All right, so here, this could be a man or a woman. So I'll go ahead and give you a demographic of both. First, we'll start with the woman, and then we'll move over to what it might look like on a man. So a 29-year-old man comes to a clinic due to recurrent clusters of painful blisters on the left side of his face. By the way, let me know if you'd like both of the patient demographics or if you'd just prefer the one relevant to the question. I think it's good to expand your horizons so you don't just lock in on one patient demographic for cold sores, for instance. But I digress. Would love to hear feedback. 29-year-old man, he's got the blisters as you can see there. Similar issues in college triggered by stress. Group vesicles of arithmetic base along the maxillary distribution. Okay, so it follows a distribution. What enabled the virus to establish the latency? It's retrograde axon transport. All right, so you might see painful blisters on the lips and it's recurrent and has like maybe a 10-year history. That's going to be herpes. It's HSV1, usually. HSV2 is also possible. And they love this question. How does HSV get from the skin to the sensory ganglion for the latency? So the way that this works is HSV infects the epithelial cells of the mucocutaneous sites. So it's going to be the lips, and the virus then hijacks the neuronal microtubules and it moves retrograde. That means backward or toward the cell body into the trigeminal ganglion for oral lesions. And there it establishes latency. And it's basically a fancy way of saying you're hiding. It's like a game of hide and seek in the immune system. And on reactivation, HSV then travels anterograde, which is forward toward the axon terminal. Retrograde backward toward the cell body. Grade is toward that terminal. I'll say it again. Retrograde backward toward the body. Like retro arcade games, they're old times. So you go backward toward the body, the opposite way of where the synapse would travel. And then they can go anterograde afterwards and they go forward toward the axon terminal back to the skin, causing the vesicles. That's usually what they like to ask about this. Now, let's look at some of these answer choices. This is pretty much what I said here in the explanation, more or less. It does also mention that there's movement that uses the dynein motor protein to move against the polarity toward the neuronal soma. But anterograde is reactivation. Exocytosis would be the releasing of viral particles, not how they move within neurons. Protein translation happens inside the affected cells. Neurotransmitter diffusion is irrelevant. HSV does not use synapses and neurotransmitters to spread. Some key terms here are action potential, which is electrical signaling, and that's not used by viruses for transport. Protein synthesis, which is needed to replicate the virus, but it's not the way that latency is established. And so maybe 3 questions that I would ask to make sure that you'd have this topic down pat would be 1, which process establishes the HSV latency? And that's retrograde axon transport. 2, which process reactivates it? That's anterograde axon transport. And then 3, which antiviral is a guanosine analog that blocks viral DNA polymerase? And that's acyclovir. Also valcyclovir or famiciclovir. The cyclovirs. These are antivirals. They are guanosine analogs that block viral DNA polymerase. And I actually have seen this on a test question before, that the mechanism for acyclovir, valcyclovir, and famiciclovir is that they are guanosine analogs. And they are activated by viral thymidine kinase. They are phosphorylated, and then you inhibit the viral DNA polymerase. So there's a chain termination. It's used in HSV1, 2, VZV as well, so chickenpox. It's not great for CMV because it's a poor substrate for CMV's kinase. Ganciclovir is a guanoside analog for CMV, so ganciclovir is a little bit better for CM cytomegalovirus. And ribavirin is a guanosine analog for RSV and HCV. But acyclovir is activated, so think acyclovir. Associate this with HSV1 and 2, but acyclovir for activated by viral kinase, and it's used for all herpes. AAA, all herpes activated by viral kinase, HSV or VZV, and VZV as well. Now I have to tell you one more thing because you're going to get tested on this. Acyclovir, valcyclovir, famiciclovir, these mechanisms are guanosine analogs. We talked about this. Ganciclovir is a guanosine analog that inhibits viral DNA polymerase, and then foscarnet is a pyrophosphate analog that directly inhibits viral DNA. There's no activation required for foscarnet. Cidofovir requires only a host kinase, not the viral kinase. So just make sure you know the difference there. This guy right here is going to be seen with CMV retinitis. That's like its use. The use for acyclovir, valcyclovir, and famiciclovir is going to be HSV1 and VZV. The use for ganciclovir is CMV. And you can remember that because G kind of looks like a C, ganciclovir. It requires a viral kinase, and thymidine kinase is required for acyclovir. But foscarnet does not need kinase activation, and cidofovir requires only the host kinase. All right, this next question is super crazy easy, so I'm not going to dwell on it a lot. It's just the difference between precision and accuracy. The answer is method A is more precise than B, because A has less coefficient of variation, and B has this, and that's how you know it's precision. So precision is another way of saying consistency. Look at these dots, they're consistently in the same spot, but they're not accurate because they're not in the middle. Look at this dot, it's accurate, but then it's maybe not precise because all of the other ones are randomly placed. All right, so precision is consistency, and the coefficient of variation quantifies how consistent measurements are relative to the mean. And so the lower CV means greater precision, okay? Super easy question. And we have done the first 150. If you found this helpful, please like and subscribe. If not, just let me know how I can improve. I'm always happy to continue improving this channel. If you guys need tutoring from a Harvard tutor, just let me know. That's a good way to guarantee that you'll pass this exam. We'll see you guys in the next video. Hello, everybody, and welcome back to NBME 29. All of these questions that you're about to see are original. They are made by me. They are not copied from the NBME, but it's everything that I think you should know by the time you take your Step 1 exam. So let's dive right in. Question 151. A 16-year-old girl is referred to the endocrinologist for evaluation of primary amenorrhea. She is short for her age and has a broad chest with widely spaced nipples. This is Turner syndrome. She has 45X in 12 out of 20 metaphases and XX in the remaining cells. Which best explains the patient's karyotype? The answer is postzygotic mitotic non-disjunction. So you have two cell lines that are different, which is mosaicism, and mosaic Turners arises from mitotic post-fertilization events. This is from non-disjunction early in embryogenesis. So some of the daughter cells lose an X and the others are normal. Here's our explanation. Meiotic non-disjunction would be all cells affected. It'd be uniform across the board, just the X, for instance. X-linked deletion is the loss of a gene, not a whole chromosome. So it wouldn't create the 45X karyotype. Genomic imprinting would have different gene expression, not chromosomal loss, and balanced translocation would not have monosomy. So up to 30% of Turner syndrome cases aren't 45X across the board. Some have mosaicism, so their body is made up of two different cell populations. So Turners, remember there's mosaic Turners caused by mitotic error, postzygotic, and non-mosaic Turners, which is a meiotic error, which is all cell lines affected. In our next question, a healthy 28-year-old woman comes for preconception counseling. Her husband has a family history of autosomal recessive metabolic disorder that affects glycolysis degradation. His younger brother was affected, but both parents are healthy. The disorder affects 1 out of every 90,000 individuals in the general population. The patient has no family history of genetic conditions and is not consenting. Based on this information, what's the approximate probability that the patient is a carrier? So here we use Hardy-Weinberg. Disease incidence is Q squared, which is equivalent to 1 over 90K. That's the first step. And then we take the square root of both sides, which gives us 1 over 300. And the carrier frequency is 2pq. So 2 times q times p gives you 1 over 150. All right, so this is the formula you need to know for Hardy-Weinberg equilibrium. That's the rare disease in question. So we take the square root, 1 over 300, and we get 150 as our answer. And the reason that we know a p is 1 is because p plus q is always 1, and q is super, super small. And so P is very close to 1, so I approximated it as 1. That's Hardy-Weinberg equilibrium. Okay, here we have a 62-year-old woman, could also be a man, hence the relevant demographic. Undergoing chemotherapy for breast cancer, presents with easy bruising and small red spots on her lower legs. She denies recent trauma. On examination, there are numerous 1 to 2 millimeter non-blanching erythematous macules on the shins and forearms. Her gums are slightly bleeding during oral exam. Which of the following is the underlying cause of these symptoms? So it seems like she has chemotherapy-induced thrombocytopenia. There's the photo of our patient. This has led to petechia. So the answer is going to be suppression of megakaryocyte precursors. So let's look at the brief explanation. Bone marrow suppression has led to petechiae. Autobody-mediated red blood cell destruction would be spirocytes and jaundice. Inhibition of vitamin K affects the coagulation cascade, not the platelets. Activation of plasminogen to plasmin would cause bleeding from multiple sites. That's the increased D-dimer seen in DIC. Congenital deficiency of factor 8 would be hemophilia. So really tiny, non-blanching, super small petechiae indicates that we probably have a primary hemostasis problem. You should think of low platelets whenever you see this, or platelet dysfunction. So you got petechiae and mucocutaneous bleeding. You have in the gums, epistaxis, and that means we have a decreased platelet count. It's impaired production from the megakaryocytes because of all the destruction. So primary hemostasis involves the platelets, cause of petechiae, purpura, and mucosal bleeding. Secondary hemostasis would be coagulation factors. That's deep tissue, joints, muscle bleeds, and large ecchymosis. So a protein C deficiency would be a risk for thrombosis, not bleeding. Okay, so here's what's happening. We have the small red purple dots showing up in the skin because there are a lot of vessels under stress there. Because you don't have enough platelets and so the blood is leaking out. So there are not enough platelets. You can see this because she's getting chemotherapy. Chemo hurts the bone marrow, so you can't make the platelets. No platelets means bleeding, petechiae. That's what's happening here. Here are the traps to avoid. Vitamin K relates with PT. Hemophilia would be joint bleeding. Red blood cell problems would be anemia. Too much plasmin is DIC. All right, in this next question, a 45-year-old man begins a new medication that acts as an allosteric inhibitor of the liver enzyme involved in fatty acid oxidation. Kinetic analysis with and without medication shows a rightward shift on the curve. Maximal velocity remains unchanged. The answer is increased Km because this is allosteric inhibition. So here's allosteric inhibition. It alters the active site. Here are the differences between competitive, uncompetitive, non-competitive, and mixed. The Bmax always goes down except for competitive. And here, the effect on the Km is increased, and it's binding to the enzyme. That's competitive inhibition. And it's important to know in competitive inhibition, you're binding to the active site, and allosteric, you're binding elsewhere. So here we have an allosteric inhibitor, not a molecule that's competing for that active site. It's all about the active site, because competitive is reversible with the increased substrate, and allosteric is a regulatory site that affects the enzyme conformation. And it's the shape of the curve that can tell you if it's competitive inhibition versus allosteric. So for instance, here would be a simple one, and here is an allosteric one. And the way to think about this is in our simple one, here you have an enzyme, let's say, and that makes this the active site. And so you have a substrate that comes and binds right there. Whereas in the allosteric one, we have an effector that binds right here, and it causes that different looking graph. All right, there we go. So here's the entire chart. So you can see allosterics working on different enzymes. Hyperbolic would be competitive. Sigmoidal is allosteric. Okay, in the next question, we have a 27-year-old woman presenting with acute pelvic pain and light vaginal spotting. She reports her last menstrual period was 7 weeks ago. Medical history is notable for prior chlamydia infection 2 years ago treated with antibiotics. Urine pregnancy test is positive and transvaginal ultrasound shows no intrauterine gestational sac. Serum beta HCG is 1,800. Which of the following most likely contributed to the patient's condition? It's a history of treated chlamydial infection. They could also say it's some other gonococcal or gonorrhea infection that she had. The reason being chlamydia can cause tubal inflammation and scarring, and that predisposes you to ectopic pregnancy. High beta HCG points to an ectopic gestation. Look at that level. So on step 1, the big risk factors for ectopic pregnancy are going to be pelvic inflammatory disease that's most often caused by chlamydia or Neisseria. Also tubal surgery that can leave behind scarring in a previous ectopic pregnancy increases the risk, and intrauterine devices and in vitro fertilization. So it's going to be some previous infection, history of treated chlamydia infection or gonorrhea that's going to be the answer to the question like this. All right, so there's your explanation. Here are the trap answers and why they're wrong. I think we're going to move on to the next question. All right, so here we have a 6-year-old girl, could also be a young boy as well, is brought to the pediatrician for evaluation of worsening scalp tenderness. Her parents report that she has been more irritable and tired of the last week. Physical exam shows a soft, mildly tender mass on the left parietal bone. CT scan shows a 3-centimeter lytic lesion in the parietal skull. A biopsy reveals numerous mononuclear cells with nuclear grooves and infiltrate-rich eosinophils. We have positive CD1A and S100. All right, so when I'm looking at this question, what I see is a young person. They have some lytic skull lesions. They have eosinophil infiltrate, and then S100 positivity and CD1 positivity. So you should look out for those skull lytic lesions, the tenderness over the occipital bone, and all this should make you think of Langerhans cell histiocytosis. So the pathophys here is there's clonal proliferation of the Langerhans cells. These are specialized dendritic cells, and they call them Burbeck granules. They're like tennis racket shaped. And in the immunohistochemistry will show CD1 positivity and S100 positivity and Langerhans positivity. All right, so look out for bone lesions. Also, it's seen with the skin rash, and it can involve the bone marrow, the lungs, the lymph nodes, the endocrine glands. So you have a child with lytic bone lesions, a skin rash, recurrent otitis media, and a mass infecting the mastoid. So it's Langerhans cell histiocytosis. You see Burbeck granules and CD1A, S100, and Langerhans positive. Look for the bone lesions. And if you see an eczema-like rash, diabetes insipidus, indicating posterior pituitary involvement, then it's HSC triad. So here are the trap answers: osteoid osteoma, nocturnal pain relieved by NSAIDs in the femur and tibia, not the skull. Ewing sarcoma is onion skin, periosteal reaction, presents with systemic symptoms. Aneurysmal bone cyst would be blood-filled space on imaging, typically multiloculated without that CD1A positivity. And you should look out for those Burbeck granules. Now, it's not enough to just think of bone lesions and you're done on step 1. There are several conditions which can cause bone lesions. And the one we're talking about is LCH, which is Langerhans cell histiocytosis. And that's in children. The location is going to be the skull, the ribs, and the long bones. In this condition, you see lytic bone lesions, skin rash, recurrent otitis media, diabetes insipidus, the Hanschler-Christensen triad. And really look out for that CD1A positivity. Now, there's another condition that can cause these lytic lesions, and that is Ewing sarcoma. And Ewing sarcoma is commonly seen in boys that are younger than 15. They have long bone, lytic lesions, diaphysis, pelvis, the ribs. And there you have very painful, often systemic symptoms. They have fever. And one thing with Ewing is going to be an increased ESR. Now, another lytic lesion problem is osteosarcoma. That's bimodal, so elderly patients with Paget and radiation are going to be the demographic for osteosarcoma, or they could just be like 10 to 20, but it's bimodal. So not in between, more on the extremes of the age chart, but not right there. You'll see pain, swelling, and that has a sunburst pattern with a Codman's triangle and malignant osteoblasts. And the last lytic lesion that you should know is metastasis to the bone that's seen in adults, and typically that involves the axial skeleton, so the spine, the pelvis, the ribs, the skull. And maybe you should also think of a solitary bone cyst as another option. That's seen in children and adolescents. In the metaphysis of the long bones, it's incidental, and it's like a fluid-filled cavity. It's benign, it's not malignant. So, just to sum all this up, Langerhans cell histiocytosis is going to be seen in children with skull lesions and a rash. It's a dendritic problem. Ewing would be, ooh, they have onion skin. They also have that translocation for Ewing as well. Osteosarcoma has the sunburst near the knee in the teens. Metastasis is commonly seen in adults. It's the most common malignant bone lesion overall. And then cysts are just benign. Okay, so those are all of the lesion associations you need to know for step 1. All right, so for this one, we are conducting a study where we start with the exposure status, exposed versus unexposed. And then we track them over time and we compare the outcomes. That's a cohort study. And so relative risk is used in these studies. Odds ratio is used for case control, and cross-sectional is used in a prevalence ratio. These 3 things are what you need to memorize. Cool? Okay, in this question, we have a 62-year-old man admitted to the ICU with acute necrotizing pancreatitis. Day 3, he develops worsening dyspnea and hypoxia. He's intubated. Chest x-ray shows bilateral diffuse opacities. PaO2 to FiO2 ratio is 130 millimeters mercury. Bronchoalveolar lavage shows no organisms. Lung biopsy shows alveolar septal thickening and eosinophilic material lining of the alveolar spaces. What describes the primary mechanism responsible for his lung findings? Okay, so this guy has ARDS, and the answer is neutrophil-induced injury to pulmonary epithelium and endothelium. It's non-cardiogenic cause of edema. This is acute respiratory distress syndrome. And the timeline is interesting here because this develops within days after some sort of trauma or sepsis event. The findings are dyspnea, hypoxemia. Hypoxemia is low oxygen in the blood. Diffuse crackling and bilateral fluffy infiltrates on the chest x-ray. Now, the pathology here is a cytokine storm in burn patients. That causes neutrophil activation and then injury to the alveolar epithelium. And that increases the vascular permeability, causing protein-rich exudate to fill the alveoli, and that causes hyaline membrane formation. Okay, so the big keyword to look for is hyaline membrane formation. On autopsy, it'll be firm hyperemic lungs with widened septa and hyaline membranes. That's ARDS. It's not immune complex deposition. That'd be glomerulonephritis or vasculitis. It's not type 2 pneumocyte loss. That's seen in neonatal RDS, but acute respiratory distress syndrome involves both of them with neutrophil predominance. Type 1 hypersensitivity would be anaphylaxis and asthma's IgE mediated. It's not relevant here. And fibroblasts would be idiopathic pulmonary fibrosis. ARDS is acute, not chronic interstitial lung disease. And this is a pretty serious condition. It's something like 40% of patients who are in the ICU with ARDS are not going to survive. All right, so here's the breakdown. Macrophages release cytokines like TNF-alpha and IL-1, which summon neutrophils. And there's that inflammation because of trauma, sepsis, or severe pancreatitis. The neutrophils dump enzymes and ROS that shred the alveolar epithelium that leads to protein-rich fluid entering into the alveoli. And those guys make the hyaline membranes that you see. And the patient then has severe hypoxia because of these hyaline formations. The lungs aren't working very well, and the PaO2 ratio drops, Berlin's criteria for ARDS. So this is neutrophil-induced injury to the pulmonary epithelium. All right, in our next question, we have a 72-year-old man, or it also could be a woman, as seen in this question, has a history of poorly controlled hypertension, type 2 diabetes. This is probably going to be a stroke something. Yep, she has wide flailing movements of her left arm and leg. He is alerted and oriented, could be male or female. Neurological exam reveals no cranial nerve abnormalities. MRI shows a small infarct in the deep brain structure. Which one is it? It's the subthalamic nucleus. Hemibolismus, damage in the contralateral subthalamic nucleus. It inhibits things through the indirect pathway. And so if you lose that inhibition, then that causes uncontrolled movement. And this is often due to lacunar strokes in the setting of hypertension and diabetes. So here are the associations, but the answer is going to be C, the subthalamic nucleus. So you can see it right there. Now, the associations, hypertension would lead to lacunar strokes. So that's like the small vessels deep inside of your brain, including the basal ganglia. Non-ketotic hyperglycemia can mimic hemibolismus due to metabolic insult to the basal ganglia. Huntington's disease would have chorea, not hemibolismus. And Wilson's would be copper deposition of the basal ganglia. So here you have an ischemic stroke of the subthalamic nucleus, often lacunar. The thalamus becomes overactive because you lose that indirect pathway, the decreasing of the inhibition. And it's unilateral because it's just going to be on that one side of the contralateral limbs. Now, there's a difference between chorea and hemibolismus. Chorea is involuntary, regular, purposeless flowing movements. Affects the distal limbs, the face, and the trunk. Continuous, but unpredictable. It's dance-like. Hemibolismus is sudden, wild, and flinging. Unilateral. Much faster. Chorias and Huntington's and Sydenham choria affects the caudate nucleus, whereas subthalamic nucleus is contralateral hemiballismus. All right, this next question is going to be really easy. Typically, it's going to be a young boy, but it could also be a female. 9-year-old girl is brought to the clinic because her teachers report that she often daydreams during class, forgets assignments, and seems to struggle with completing tasks at home. She says she takes hours to finish homework unless supervised. No history of seizures, trauma, vision, and hearing issues. She meets developmental milestones and is otherwise healthy. They're going to give her a treatment. She's got ADHD. What are they going to give her? The answer is C, promotion of presynaptic dopamine and norepinephrine release. So she has inattentive ADHD. So you give her a stimulant and it increases dopamine and norepinephrine release in the prefrontal cortex. So inattention with hyperactivity across settings during childhood, the first line stimulant would be methylphenidate or amphetamine salts. These guys increase the presynaptic release of dopamine and norepinephrine, and also the attention. The reward processing is dopamine, the attention is norepinephrine. NMDA receptor blockade would be in ketamine, unrelated to ADHD. Potentiating GABA would be benzos, barbiturates, and that would be sedative. Serotonin reuptake inhibition is used in depression and anxiety, and alpha-2 antagonist would increase norepinephrine, but not in a controlled way. They're adjunctive, not primary therapy. So you can give them as part of something, but it's not the primary therapy. And this is crazy because 10% of children in the United States are diagnosed with ADHD. So distractibility, impulsivity, poor task completion as early as kindergarten. You give them stimulants, they power the brain, boosting dopamine and norepinephrine. It just lets you focus. So we got a 9-year-old girl, inattentive ADHD, promote those presynaptic dopamine and norepinephrine release, and you're good to go. Hopefully you guys have found this helpful. If it was, like and subscribe, and we'll see you guys in the next video. All right, our patient demographic could be a male or a female, so I'm going to include the female here. We're now in question 161. Again, all these questions are completely original. I've made them for you to prepare for step 1. They're not copied from the NBME, but it's everything that you need to know by the time you finish your preparation for step 1. So here we go. 55-year-old woman, history of major depressive disorder and chronic alcohol use is admitted for severe nausea and fatigue. Lab show low sodium, and she started on intravenous saline therapy. 3 days later, she becomes unable to speak and shows profound weakness in all limbs. Neurologic exam reveals an awake and alert patient with dysarthria, bilateral Babinski signs, and marked quadriplegia. Sensation and eye movements are intact. Which of the following structures is affected? The answer, as you can see, is the pons. The reason why this is osmotic demyelination syndrome. Here I've taken some notes as I've gone through all these questions beforehand. But the big thing you should know is somebody walks into the clinic and they've got super severe hyponatremia. And then they're started on some saline therapy, 0.9% saline. And then later they develop dysarthria, which is the difficult or unclear articulation of speech that otherwise is totally linguistically normal. Also quadriparesis, which is weakness or paralysis in all 4 limbs, so arms and legs, quad, and the Babinski sign. And all these symptoms should make you think of a brainstem issue, specifically in the brainstem, the pons. And it's classic central pontine myelinolysis, or CPM. This is also known as osmotic demyelination syndrome, ODS. And the pathophys is important to understand. When you have chronic hyponatremia and it's corrected way too rapidly, then water is going to ሲፍት out of the brain cells, and that causes demyelination, particularly in the pons, because the pons has the corticospinal and the corticobulbar tract and the corticobulbar tracts. So that's what causes the dysarthria, dysphagia, the locked-in syndrome if it's super severe. So this is a question in neurology about demyelinating disorder. Let's talk about what it's not. Internal capsule, that'd be motor stroke. That would cause hemiparesis, not quadriplegia with dysarthria. Pure motor for internal capsule. Internal, I just want you to link that to motor. Cerebellar vermis, that would cause some truncal ataxia. Probably shouldn't move away from the mic to demonstrate what that looks like. But there you'd have preserved eye movement. The medulla, that would be involved in cranial nerve 9 to 12 dysfunction, not locked in. So you should think respiration issues would be seen there. Basal ganglia would have movement disorders like chorea and rigidity. All right, so there's our guy. There's our patient. They got the slurred speech, quadriplegia, Babinski sign. That's what you should look out for. And I wanted to make an image so that you guys can kind of see this in your mind, because all these test questions can feel pretty abstract, but you should pretend each test question is a new patient. And now I really want to break down some specifics here. You might have also been tempted to put something like myasthenia gravis, or say that this is related to the neuromuscular junction. It is, however, not related to the neuromuscular junction, because disorders like myasthenia gravis do not cause upper motor neuron signs, and that's what Babinski's reflex is. Plus, this would have no connection to sodium, which was our big clue. You might have been tempted to put Guillain-Barré syndrome or something like that, like a peripheral nerve disease, but that presents with areflexia and ascending paralysis, not upper motor neuron signs, and a normal mental status. By the way, my favorite artist, Sufjan Stevens, had Guillain-Barré syndrome, so look that up if you're curious. It's good to have an anchor in your mind about these things. So yes, this is osmotic demyelination syndrome, and the actual cause is the rapid correction of the hyponatremia. You would see acute paralysis, dysarthria, dysphagia, locked-in syndrome. And the way that you remember this is you say this phrase in your head. From low to high, the pawns will die. All right, so put that on a t-shirt. From low to high, the pawns will die. Rapid increase of the sodium causes CPM. Now, quick recall drill. And by the way, in the comments, let me know if you want me to go into this much depth or if you prefer that I go quicker. But just a quick recap, which tracts are affected in central pontine myelinitis? The answer is the cortical spinal and the cortical bulbar. The next recap question, what is the safe rate for sodium correction? We mentioned this was too quick, so how quickly should you do it? Well, the answer is about 6 to 8 milliequivalents per liter per day, and some sources can say it's up to 10 to 12, but lower is going to be safer for chronic hyponatremia. All right, so the big tip that I would give you with this question is anytime you see an alcoholic or a malnourished patient that has severe hyponatremia and they have neurologic symptoms after the sodium correction, then you should immediately be thinking of osmotic demyelination syndrome. And the first time I was going over this question, I drew this out for you guys too, so you can see low sodium. By the way, if this is helpful, please consider liking and subscribing. Videos take dozens of hours to make, and I'm doing it so that you have another way to study for step 1, step 2, step 3. Let me know in the comments if you like the patient photo and also a relevant demographic photo. All right, let's not waste any more time. Next question. But basically, we got a 45-year-old man presenting with a 6-month history of intermittent chest discomfort. This could be a woman as well, hence my relevant demographic photo up there in the corner. Typically occurs after dinner, especially when he eats fried or spicy foods. He has gained 20 pounds over the past year and often lies on the couch shortly after meals. He denies weight loss, difficulty swelling, and gastrointestinal bleeding. He has tried over-the-counter antacids with partial relief, and physical examination is normal. Which of the following mechanisms is most likely contributing to his symptoms? Okay, we have a couple of options here. We have to understand what's going on. So the symptoms are postprandial burning chest pain that worsens with large or fatty meals. The timing, they don't really mention this in this question, but typically it's daytime, and it worsens after you have fried foods. And antacids were great, but now it's refractory. There's no dysphagia, there's no weight loss, there's no bleeding, and the history has maybe some recurrent symptoms. If this is a female, you might see this happens whenever she's pregnant or something like that. And so we should have a differential diagnosis list, and one of the top differentials should be gastroesophageal reflux disease, GERD. You heard with PERD. Just kidding. That's a Parks and Rec quote. But this is GERD, and so the answer is going to be vagal stimulation causing transient lower esophageal sphincter relaxation. And the pathophys is important. The lower esophageal sphincter normally prevents acid from refluxing up. And so if that's too relaxed, the vagus nerve is mediating that transient lower esophageal sphincter relaxation after meals. If it's too relaxed, then it allows the gastric contents to then enter into the esophagus. And so fatty foods, large meals and chocolate, that kind of stuff, increases these relaxations, and repeated acid exposure causes mucosal irritation. And then that's what causes the symptoms of heartburn and regurgitation. All right, so here's the explanation. I've kind of said most of this already, but it's triggered by the vagal pathways that help it to relax to allow the gastric contents to reflux into the esophagus after lying down or having fatty meals. Why is it not somatostatin-induced decrease in bicarb? Well, that inhibits the acid, not bicarbonate, and so it helps, not hurt. And it asks what's contributing to this. And so somatostatin is actually helping, not contributing to that. Gastrin overproduction, pepsinogen is not the driver. Acid reflux is. Secrete-mediated inhibition of gastric acid secretion that would reduce the acid alleviating symptoms, and CCK-induced gallbladder contraction would involve fat digestion. All right, so here's a relevant photo of the patient. Again, let me know if you think this is helpful, and I'll start to include it in the future. There are some things to know, and one of those things is gastrin actually increases the lower esophageal sphincter tone, and that helps to prevent the reflux. And so it's protective against GERD. So gastrin is not the right answer. Somatostatin inhibits gastric acid secretion. And so that's not the answer either. Vagal inhibition would be wrong because vagal nerve stimulates esophageal peristalsis, does not inhibit it. And so GERD is not due to the impaired esophageal contractions. It's due to the lower esophageal relaxation. So the key takeaway for this question is it's obviously a GI question about the esophagus, and it's GERD. GERD is the word. GERD is the word. Transient lower esophageal relaxation, fatty foods, caffeine, alcohol, chocolate, large meals, that kind of stuff. Barrett's esophagus could be a complication that you see from this. Esophagitis and stricture, and also adenocarcinoma. And the treatment is lifestyle change, proton pump inhibitors, and anytime that you're taking this silly test and you see postprandial heartburn that is worse with fatty acid foods and it's GERD, you should think of the lower esophageal sphincter dysfunction. Now, another question they could ask, we can't cover everything, but we can try to flesh out these topics as well as possible. Which neurotransmitter mediates the lower esophageal relaxation in GERD? And the answer is nitric oxide, which is released by vagal stimulation, is the neurotransmitter that mediates that lower esophageal sphincter relaxation. What is the most dangerous long-term complication of GERD? Well, this is actually going to be via that Barrett's esophagus pathway that I mentioned. It's esophageal adenocarcinoma. And adenocarcinoma is just a fancy way of saying a malignant tumor that's formed from the glandular structures in epithelial tissues. That's what adenocarcinoma means. All right, question 163. Here we have a 72-year-old woman, could be as like a young boy, an adolescent, as you can see here in this photo. Just want to make sure you're not super locked into this demographic. But they are admitted to the ICU with altered mental status, hypotension, and high fever. Her blood pressure remains low despite receiving aggressive IV fluid resuscitation. A norepinephrine infusion is started. The agent primarily acts by increasing vascular smooth muscle tone through stimulation of what? All right. Let's get the lay of the land. If we have a patient who comes with shock, then we're probably going to want some vasoconstriction. And a great vasoconstrictor is the alpha-1. And indeed, norepinephrine in things like septic shock is going to target the alpha-1 receptor, causing vasoconstriction. And it also causes some beta-1 effects as well. And by the way, the shock type that is best treated by beta-1 stimulation is cardiogenic shock. That's where you have the low cardiac output. And the receptor that causes vasodilation of the renal arteries at low dopamine doses is the D1 receptor. But what you should think of for this question is alpha-1 agonists like norepinephrine or high-dose dopamine are good for treating septic shock or situations where you have increased SVR. And so if you see vasodilation and bounding pulses and warm extremities, then you should probably be thinking of septic shock. Another word for this is distributive shock, and that's where you have the vasodilation. And so how do you treat all that vasodilation? Alpha-1 agonism, because that causes vasoconstriction. All right, so norepinephrine exerts its primary action in stimulating alpha-1s, causing vasoconstriction. This raises SVR and is helpful in septic shock. Dopamine 1, that causes renal vasodilation, but it's associated with the renal perfusion. Beta-1 adrenergic receptors increases heart rate and contractility. Beta-2 helps with bronchodilation, vasodilation, and alpha-2 activation leads to decreased norepinephrine release, lower BP, and is harmful in shock. All right, so those are the explanations. And this is important because sepsis is one of the top causes of death in the ICU. And if you start them on an early vasopressor, it could save their life. And the problem with septic shock is that the vessels are way too relaxed. And the reason why is because they have cytokines like TNF-alpha and IL-1, and they're causing widespread vasodilation. So fluid resuscitation is really important, but if it stays low, if the mean arterial pressure still stays low, like let's say like under 65, then it's time to introduce a vasopressor. And norepinephrine is the hero drug there. And the reason why is because of that alpha-1 agonism. And those are GQ coupled receptors. And they activate then phase C, and that clamps down on the vessels to make them go tight. All right, so there's the image of our patient. You can see altered mental status. He's got his IV in there. He's undergoing septic shock. All right, and our next question, we have a 7-year-old girl running barefoot and her family lawn accidentally scrapes her foot on a sharp sprinkler head. Within 20 minutes, her right foot becomes swollen, warm, and red. Physical exam shows localized tenderness and fluctuant edema. Which of the following best explains the mechanism of fluid accumulation? All right, so we have some localized edema within 20 minutes, within 30 minutes. What's the primary mechanism at play? Now you can see this in a lot of different scenarios, but here we have histamine-mediated endothelial contraction. And this is due to reversible gap formation in the postcapillary venules. And that gap allows leakage of plasma proteins and fluid to go into the interstitial space. And that causes exudative edema. All right, so trap answers, VEGF, that would be involved in chronic processes and cancer, not acute stuff, but it would increase the permeability, just not acute, for direct necrosis. Increased hydrostatic pressure would be heart failure or DVT, that's a transudate, not exudate. And immune complex deposition would be a type 3 hypersensitivity, which would be more systemic or delayed. All right, so you stub your toe, get a scrape. First responders are the mast cells, releasing histamine. Then it opens up the small gaps. Histamine binds and triggers cytoskeletal contraction, making the wall leaky. And then the fluid in the immune cells spill out, so you get warmth, redness, and swelling there. It's the endothelial gap formation. All right, so there's an example of our little patient. Now you could also see this if somebody gets stung by a bee, for instance, then the bee venom can actually contain phospholipase A2, which disrupts the cell membrane and it activates arachidonic acid pathways, and that actually triggers a mast cell activation. So a similar kind of mechanism that we were talking about, and that mast cell degranulation causes the release of histamine. So now we got histamine, and histamine causes vasodilation, so that improves the blood flow. So if you get stung by a bee, you get increased blood flow, but you also have edema because you get contraction of the endothelial cells. That causes the gaps to form, the intercellular gaps. That increases vascular permeability, and you get fluid and protein leak into the interstitium. So that's localized swelling and edema. All right, so here are some buzzwords: endothelial contraction, histamine, bradykinin, Transudate versus exudate. Got to watch out for the histamines, leukotrienes, increased permeability, and there's the pathophys. Some things to look out for, some topics that you need to know for step 1 is how to distinguish this from demargination. And that's what happens with cortisol and steroids or stress. And this does not cause edema. You should know fibrin, that's involved in the clotting, not going to be involved in a sting. Vasodilation increases blood flow and also redness and warmth, but it does not increase vascular permeability. So it's not just vasodilation. The question is really getting at the gap junction formation. So this is kind of an immunology, inflammation question, and the vascular changes that you see there. So histamine causes endothelial contraction. That increases permeability, leading to exudate, which is protein-rich accumulation, and it's seen in the early phase of inflammation. So histamine, bradykinin, leukotrienes, CDE4, this contributes to endothelial cell contraction, gap formation in the postcapillary venules, increased permeability, exudation, and edema. So a quick rapid recall for you, just to make sure you got this. Which inflammatory mediator causes both vasodilation and increased vascular permeability? Well, the answer is, of course, histamine. Yay, we learned something. What type of vessel is most affected in inflammatory fluid leakage? Well, that is the postcapillary venule. And what's the difference between exudate and transudate? Exudate is going to be protein-rich, and that's due to inflammation because of increased permeability. Transudate is protein-4, and that's because of hydrostatic pressure or decreased oncotic pressure. So if they ask about localized edema after some sort of a sting or allergy, then it's going to be histamine, endothelial gap junctions. That causes exudation. All right, this next one is just kind of like an ethics principle here. Always apologize, even if it's not your fault. Apologize because they're feeling bad. Don't ever make any excuses whatsoever. Don't try to explain or say, oh my gosh, it's all Bob Jones's fault. Just say, hey, I'm sorry, my bad. And then focus on whatever concern they have. Don't get caught up in the weeds of your own ego. Just apologize, no excuses. All right, that's ethics. Next. Okay, on to our next practice question. Here, a 73-year-old man, could be a woman as well, goes to a primary care physician with fatigue and lightheadedness when walking uphill. He denies chest pain, reports occasional near fainting spells. On exam, his carotid pulse is slowly rising and weak. Carotid auscultation reveals a harsh systolic murmur lattice of the second right intercostal space. Radiating toward the neck, there's no peripheral edema, and echocardiogram shows concentric left ventricular hypertrophy with normal ejection fraction. Which of the following is the most likely cause of his symptoms? Okay, so here's our guy, so you can see. Well, he is an elderly patient, and so the answer is going to be calcification of the aortic valve leaflets. Basically, aortic stenosis due to calcific degeneration. We know this because of the crescendo-decrescendo murmur, carotid radiation, and delayed upstroke. Now, the symptoms you might have to look out for on test day are fatigue, lightheadedness, especially if they're exerting, and near syncope. The exam would show a slow, rising, weak carotid pulse. There's also a harsh systolic murmur at the second right intercostal space, and that radiates to the neck. And you have concentric left ventricle hypertrophy with normal ejection fraction. All those signs kind of point toward aortic stenosis. And the key finding really in aortic stenosis is the crescendo, decrescendo quality in the second right intercostal space, because that's the location of the aortic valve. Slow rising or weak pulse, like pulsus parvis et tardis, that's high yield for aortic stenosis as well. And the pathophys for this is actually pretty simple. We basically just have a stenotic valve, and that causes resistance to outflow, and that leads to pressure overload. And so the left ventricle compensates with concentric hypertrophy, and that preserves the ejection fraction at first, and eventually you have decreased CO2 on exertion, and you get syncope and fatigue and angina. So this is kind of like a heart murmur cardiovascular question. And the triad to look out for, you can remember by saying it's SAD if somebody has aortic stenosis. That's because of pulmonary congestion as the left ventricle pressure starts to back up. And really it's unique because it radiates to the carotids. All right, here's some trap answers. Myxomatous degeneration of the mitral valve would have a click, late systolic murmur seen in mitral valve prolapse. Rheumatic fusion, opening snap, diastolic rumble. Infected destruction of pulmonic valve, that'd be a diastolic murmur with IV drug use. And papillary muscle rupture, acute mitral regurg with hypotension and flash pulmonary edema, usually post-MI. All right, so the most common cause of acute stenosis in the elderly is calcific degeneration, known as senile calcific aortic stenosis. The type of murmur that increases with squatting and decreases with Valsalva is aortic stenosis. And the difference in left ventricular remodeling between aortic stenosis and aortic regurgitation is that in stenosis, you have concentric hypertrophy, pressure overload, and in aortic regurgitation, you get eccentric hypertrophy, volume overload. For the next question, we have a 68-year-old man with a history of BPH presenting to the emergency department with fever, dysuria, left-sided flank pain for 24 hours, experienced difficulty voiding, temperature 101, abdominal exam shows suprapubic fullness and left costovertebral angle tenderness. Urine dipstick is positive for leukocyte esterase but negative for nitrates. Urine culture shows gram-positive cocci pairs and chains. Which of the following is most likely? So it's gram-positive, and all these signs are pointing toward Enterococcus faecalis. We know this is like a urinary tract infection of some sort. We know that he has like pyelonephritis, and it's like a bug identification question, and it's gram-positive. And so I diagnosed this guy with acute pyelonephritis. And the pathophysiology is that we have a gram-positive cocci and chains. So our answer is C. Now, here's the explanation. But essentially, this organism is catalase negative, and it's part of the normal GI tract, the flora, and it can grow in bile and sodium chloride, and it's PYR positive. Now, you might be thinking, okay, well, I thought that the most common or whatever was E. coli. And you would indeed be right, but that is gram-positive. How about Shigella? You might have thought, okay, this is toast Shigella. No, because that's a gram-negative rod, and it causes bloody. Anytime you see Shigella, think blood in the urine. And it's not pyogenes, not strep, group A strep. That would be pharyngitis, cellulitis, necrotizing fasciitis, not a urinary problem. Klebsiella is gram-negative, and the mucoid colony is encapsulated. And saprophyticus, always think of young, sexually active females with UTI. It's rare in elderly men. So the demographic's different in that one. All right, next we got a 64-year-old man, could also be a woman, probably similar age, undergoing treatment for diffuse large B-cell lymphoma. His chemotherapy regimen includes anthracycline agent. He initially responsible to therapy, but then later, after 6 months, he has progressive exertional dyspnea, orthopnea, and bilateral lower extremity edema. Physical exam shows bibasilar crackles, JVD, and third heart sound. Echocardiogram reveals dilated left ventricle and ejection fraction of 30%. What describes the mechanism? All right, so there's our new patient that fits this question's demographic. And the answer is going to be oxidative injury from free radicals. And we said anthracycline, but maybe it would have helped if you missed this question to know doxorubicin, which is an anthracycline and it's commonly used, and that develops cardiomyopathy. And the mechanism of toxicity is what you need to know. So doxorubicin, any of like the rubicins will intercalate the DNA and inhibit topoisomerase 2. But the cardiotoxicity will be caused by iron-dependent generation of free radicals, and that leads to lipid peroxidation of the cardiomyocytes, and so you get myocyte necrosis and dilated cardiomyopathy. So the cardiomyopathy is dose-dependent, and the causes of dilated cardiomyopathy in this question is clearly from that anthracycline from the doxorubicin. So histologically, you have myofibril losses, vacuolization, which is the formation of vacuoles, the small membrane-bound sacs within the cells, and those can be a sign of cellular stress, and also interstitial fibrosis you might see. So really, a way to simplify this question is just a nice little easy farm question, and you're giving them some sort of like an anti-tumor antibiotic, doxorubicin, and that causes dilated cardiomyopathy, which is a dose-limiting toxicity. And you have free radical-induced damage to the myocytes. And so you could give them something like dexrazoxane, that's an iron chelator that prevents cardiotoxicity. Okay, some trap answers why they're wrong. Beta amyloid would be restrictive cardiomyopathy and amyloidosis. Calcium phosphate, dystrophic calcification. Immune complexes would be lupus, myocarditis. So doxorubicin enters the cardiac cells, goes through redox cycling, turns out reactive oxygenation species. They punch holes in the heart muscle cells, causing apoptosis and dilated cardiomyopathy. That's what we give them to protect. All right, now some of you guys might be wondering about EGFRs. So EGFR inhibitors, like cetuximab, are actually going to cause a papulopustular rash, not cardiomyopathy. Papulopustular just means you have the papules, which are the small little raised bumps, and the pustules, which are pus-filled. So you get that redness, the flushing of the skin, the raised bumps with pus, and that's related to blood vessel dilation, bacterial overgrowth, that kind of stuff. It's not the abnormal myoglobin, because myoglobin release, anytime you think of myoglobin release, you should think of rhabdomyolysis, not chemotherapy induction. And vincristine would cause impairment of actin synthesis. That's vincristine's job. All right, in our next question, we have a 2-year-old male neonate born at 39 weeks gestation, noted for severe respiratory distress after birth. Physical exam shows nasal flaring, grunting, subcostal retractions, abdomen is scaphoid. Breath sounds are diminished on the right. Heart sounds more prominent on the left. Chest x-ray shows bowel loops occupying the right thoracic cavity with leftward mediastinal shift. Which of the following structures most likely failed to develop properly? And our answer is C, the right pleuroperitoneal membrane. I see this more as a memorization question, but typically you have like a full-term newborn. They got respiratory distress and they have abdominal contents in the thorax somewhere. It's congenital diaphragmatic hernia. And then you just have to memorize that congenital diaphragmatic hernia is due to that failure to fuse the pleuroperitoneal membrane with the septum transversum. That's what causes the hernia. It's that failure to fuse. And the thorax, by the way, is the part of the body on any mammal that's between the neck and the abdomen. And so it's usually referred to like the cavity that's enclosed by the ribs. It's like that breastbone area, that dorsal vertebrae. Usually it has the chief organs of circulation and respiration. So what happens in this little baby is that you have the compression of those developing lungs and pulmonary hypoplasia and respiratory failure. And so this is often associated with persistent pulmonary hypertension of the newborn. Think of this as an embryology question and diaphragm development question. It's a congenital diaphragmatic hernia because of the defective development of the pleuroperitoneal membrane, and that leads to pulmonary hypoplasia. And it's usually left-sided, and that's the reason being that the liver protects the right side. Okay, here the trap answers are whether wrong. Septum transversum is rarely the sole defect here. Pulmonary endoderm affects lung tissue development. Pleuropericardial fold separates the pericardium and the pleural cavity. Cervical somites provide the muscle. So the diaphragm is kind of like a little quilt. It's made of pleuroperitoneal membrane, transversum, and somites. What happens here is that the abdominal organs slip through the hole into the thorax. Pulmonary hypoplasia. Now you can't breathe. Now the abdomen's sunken because the bowel's not in the belly. It's in the chest. Wild. Now, some other answers you could see would be like the diaphragmatic cruce, and that gives support, but it's not the site of the herniation. And septum transversum is what actually forms the central tendon. That's possible, but it would form the rare central hernia, not CD8. All right, now look at this absolutely adorable infant. 3-month-old male, could be female, as you can see here. Born at term, 9 pounds, has an enlarged tongue, prominent umbilical hernia. Asymmetry of the limbs and the right leg appearing longer than the left. Abdominal ultrasound shows heterogeneous mass of the right kidney. Genetic analysis demonstrates loss of maternal methylation through imprinting on 11/15. Which of the following best explains the pathogenesis of this patient's condition? Okay, so there's a little baby that represents this demographic in this question. Super cute. Pediatrics is the absolute best, by the way. Now, this is a condition known as Beckwith-Weidman syndrome, and a couple of things are seen here. One is excessive birth weight and maybe some postnasal overgrowth. They typically have a large tongue. Macroglossia is that's super classic for BWS. They could also have that stork bite, but that could be kind of nonspecific. And one thing to really look out for that's super high yield that they're going to test you on is the abnormal mass. Wilms tumor. That's high yield for BWS. And there's a genetic mutation of 11p15. It's the abnormal methylation, which is a huge clue as well. And the pathophys here is that there's a loss of imprinting or uniparental disomy of that 11p15. And so that affects the insulin-like growth factor 2, which is the paternally expressed growth promoter, or it could affect the maternally expressed growth suppressor. And so normally one parental allele is active, right? We're familiar with imprinting there. But in BWS, both alleles are expressed, and so there's overgrowth. So you're expressing IGF2, which is the paternally expressed growth promoter, and you're also expressing the maternally expressed growth expressor. And imprinting is the epigenetic silencing of only one parental allele. And it's mediated by DNA methylation and histone modification. An example of that is Prader-Willi starts with the P, and so which one's deleted? The P. Angelman, what sticks out to you is the man in that, so it's maternal deletion. And Beckwith-Weidman is a biallelic paternal-like expression. It's not heteroplasmy, that's mitochondrial DNA variation. It's not anticipation, that's like Huntington's disease or myotonic dystrophy. It's not pleiotropy, that's one gene. So pleiotropy is one gene that affects many other systems. An example of that is PKU. And the most common tumor seen with Beckwith is Wilms tumor. So look out for the nephroblastoma, Wilms. And the gene that's normally maternally imprinted and overexpresses IGF2. So it's abnormal imprinting. It's the loss of methylation on the maternal allele, and that causes biallelic expression. And so the answer is epigenetic silence failure. All right, so it's not Huntington's or Fragile X. That'd be triplets, mitochondrial heteroplasmy, variable expression, chromosomal non-disjunction. That's like Downs, and germline would be multiple affected siblings with normal parents. All right, here are the buzzwords: macrosomia, IGF2 overexpression, nevus flammeus, port-wide stain, common in syndromes involving overgrowth and vascular malformations, and Wilms, renal malignancy, macroglossia, big tongue, abnormal methylation, defect of the maternal. And so the maternal suppressor normally silences through methylation, but in BWS, the maternal methylation is lost, and so you can't suppress that gene. So you just get dad's growth factor. Mom was supposed to press the mute button. She didn't. And now the baby is playing twice as loud. I like that. Guys, thank you so much for watching these 10 questions. Hello, everybody. Welcome back. Here are 10 more questions that are going to help you pass step 1. In our first question, a double-blind randomized clinical trial investigates the effect of novel therapy in patients with acute myocardial infarction. Patients are randomized to receive either the experimental therapy or a placebo within 6 hours. The relative risk of the recurrent MI in the treatment group is 0.65, and the confidence interval is 0.4 to 0.9. Relative risk of all-cause mortality is 0.82, and the 95% confidence window is 0.59 to 1.12. Now, the question is, which of the following best summarizes the findings for the treatment group compared to the placebo? And the answer is significantly lower risk of MI recurrence, but no significant difference in mortality. All right, so what is, first of all, relative risk? We need to know. That is the likelihood of an outcome like death, disability, myocardial infarction between the treatment group and the control group, those who get the placebo. And the formula is literally just the risk of the treated over the control. And if the relative risk equals 1, that means there's no difference. If relative risk is greater than 1, then the treatment increases the risk. Like let's say it's 2. that means it's bad. And if the relative risk is less than 1, then the treatment reduces the risk, which is good. But there's also this thing called a confidence interval. Typically, we use a 95% confidence interval. And that tells you if we repeated this study 100 times, the true relative risk would fall within the range 95 times. And so for the relative risk to be statistically significant, the entire 95% confidence interval has to be above or has to be below 1. Because if it includes 1, then it could go up or down and it wouldn't be statistically significant. And that's why in this question, there's no significant difference in mortality in this group because the confidence interval includes 1. You don't know if it's gone up or down. It's not statistically significant. That's all you need to know for this first question. In this next question, a 72-year-old woman, it could be a man. That man could look like this, but for our purposes, it's a 72-year-old woman with congestive heart failure that started on a new diuretic to manage volume overload. After 5 days, she presents with new onset fatigue and lightheadedness. Her labs show sodium 134, potassium 2.8, bicarb 33, chloride 92, pH 7.48. What describes the acid, base, and volume status in this patient? All right, so looking at that pH, we know that it's going to be alkalosis, so we can cross off the acidosis. I've gone ahead and updated the patient demographic for this question. And the reason why is because loop diuretics can cause the loss of sodium and the loss of potassium and chloride. That results in volume contraction. And so the answer is alkalosis, volume contraction. The volume contraction then activates the renin-aldosterone-angiotensin system. So now if aldosterone is active, it'll promote hydronium ion and potassium loss that leads to metabolic alkalosis. And so the mechanism that you have to know is that loop diuretics activate the RAS system. That leads to increased hydronium and potassium loss in the urine, and that leaves behind a relative excess of bicarbonate. And specifically how this works is a loop diuretics cause volume loss, and they block the sodium potassium chloride reabsorption in the thick ascending limb. And the loss of sodium means you have less water reabsorption, right? Because water follows sodium. And so you have less water reabsorption, and that means volume contraction. And volume contraction means RAS activation, which is the renin, angiotensin 2, aldosterone system. And so aldosterone, what does that do? It increases the sodium reabsorption at the expense of potassium and hydronium secretion, and that's in the collecting duct. So hydronium loss leads to alkalosis, obviously, right? There's less acid in the blood. That's alkalosis. And that happens through the type A intercalated cells in the collecting duct where the hydronium ions are exchanged for sodium via aldosterone. So aldosterone goes and it's like, hey, let's exchange hydronium ions for that sodium. Maybe a good way to think about contraction, volume contraction, is like, imagine this right here is a nice warm bowl of soup. Yummy. That's some nice soup. And if you boil it down, right, imagine it's just full of water. If you boil this down, that's volume contraction. Then the concentration of bicarbonate increases, even if you don't add any more base. That's contraction alkalosis. There's a relative excess of bicarbonate due to the fluid loss. So this is a classic renal question on diuretics, acid-base disturbances. So loops lose volume, lose hydronium ions, and that causes alkalosis because of that relative increase in the bicarbonate. Next, we have a 36-year-old man, has to be a man, presents with 2-month history of dull scrotal heaviness and swelling on the left side. He works at a warehouse and notices the mass worsens by the end of his shift. He denies pain, fever, trauma, or urinary symptoms. Physical exam reveals soft, irregular mass superior to the left testes that enlarges with Valsalva and does not transluminate. His creatinine is 2.6. Urine analysis shows mild proteinuria. What best explains these scrotal findings? All right, so we got a dude, could be a little older. This guy's a little younger. They might have several conditions. They might say you've got diabetes, you've got hypertension. But we do note that the creatinine is 2.6. That is elevated. So that means he has chronic kidney disease. All right, so now maybe they also say that he has some sort of periorbital or lower extremity edema. He might have some unilateral left. Usually they'll say scrotal swelling. And there's a mass just superior to the testicle. And they'll say that it enlarges with Valsalva. So this is our classic varicocele due to renal vein hypertension. And this is like when the patient bears down, like the Valsalva maneuver, then the venous pressure increases and the veins that are already dilated become more prominent. And a varicocele is the dilated veins in the pampiniform plexus. And so increased pressure makes the veins swell even more. And that causes the mass to get larger when you're standing or during Valsalva maneuver. And that's why they have to say the mass enlarges when they're standing or doing Valsalva, or they're decompressing when supine, something like that. A hydrocele can slightly enlarge. Cancer would have no change. Torsion would have acute pain. Epididymitis would be painful, and a cyst would not change as well. Here's a brief explanation, left-sided, because the left drains the left gonadal. There's an obstruction, compression, elevates venous pressure in the varicocele, and then also diabetes history leads one to think of the kidney disease, kidney damage, contributing to venous hypertension. Rhabdomyosarcoma would be painless. Testicular torsion would be sudden severe, high riding testes. Inguinal mass extension may transluminate as well. And the epididymal cyst would be painless, round, fluid-filled mass that transluminates and does not enlarge with Valsalva. This is pretty common. 50% of men have it, don't know it. And it's because the left vein drains into the left renal vein, which is then sandwiched between the aorta and the superior mesenteric artery. So when pressures rise, you think the left side, look for the bag of worms that doesn't transluminate. The answer is varicocele. All right, for this next question, step 1 loves to ask you about vitamins A, D, E, and K. Biliary atresia, you need to know, is the absence or obstruction of the extrahepatic bile ducts. That leads to cholestasis, means that the bile cannot reach the intestine. Literally this means the stasis of that bile. No bile means that you cannot form your micelles, and so you have decreased fat absorption, induced vitamin deficiencies. And vitamin E is one that causes neurologic problems in who? A little baby. As you can see here, look at that little baby. So cute. And so you see jaundice, pale stools, dark urine, hyperbilirubinemia, and these deficiencies. If untreated, it can cause cirrhosis and liver failure. So in our question we have, the photo here, it is a 6-week-old girl brought to the pediatrician for persistent jaundice. Her mother notes that her stools have become increasingly pale, and urine appears dark. On exam, the infant has hepatomegaly and scleral icterus. Lab studies showed elevated direct bilirubin and alkaline phosphatase. HIDA scan reveals failure of the radiotracer to reach the duodenum. The patient undergoes surgical intervention to restore bile flow. She is at risk of developing a deficiency in which of the following nutrients? Answer ADEK, vitamin E. So look out for the jaundice, the pale stools, congenital biliary atresia is the diagnosis usually here. Biliary atresia means there's no bile. No bile means there's no fat absorption, at least deficient absorption, because bile is needed to emulsify the fats, right? So if you don't have the bile, then the fats can be absorbed and you get steatorrhea. And steatorrhea is just the presence of a lot of fat in the stools. And so they're going to be oily and bulky and foul smelling. Everything else is going to be water soluble like B6, B12. Here's the brief explanation. You might see, for instance, spinocerebral degeneration and hemolytic anemia in infants. Not ascorbic acid, that's water soluble. These are all going to be water soluble. Niacin, thiamine, riboflavin, and ascorbic acid. All right, fat deficiency because there's no bile. That's the way to think about this question. You will 100% see ADEK on your test. No doubt. All right, in our next question, it could be a male or a female, but I'm putting the female demographic because I feel like it's going to be more common that way. A 68-year-old man presents with fatigue, diffuse bone pain, and difficulty climbing stairs over the past year. He has a history of alcohol use disorder and recently was treated for chronic pancreatitis. Physical exam shows tenderness of the ribs and thighs. Calcium is low. Phosphate is low, ALP is high, PTH is high, 25 is super low. What explains these symptoms? The answer is going to be, well, first, why don't you decide? And I'll give you some potential clues here. There's diffuse muscle pain, maybe some proximal weakness for a long time, typically like 6 months or so. And the pain worsens with activity. There's a tender shin surface. You got, bone pain, essentially is what that means. There's proximal muscle weakness, metabolic myopathy. If it's a female, then they could have, or maybe another clue would be lack of sunlight exposure. They have decreased calcium, increased parathyroid hormone. And if it's decreased calcium, that means it's secondary hyperparathyroidism. And so in adults, if you're noting defective mineralization, then it could be due to several things. One of them is going to be vitamin D deficiency. It could also be a calcium deficiency, and also it could be a phosphate deficiency. And if that happens, the bones are going to become soft and weak and painful. So if you have low calcium and high PTH, that's secondary hyperparathyroidism. And the most common cause in the elderly, for instance, here's an elderly man, could be an elderly woman, most commonly causes vitamin D deficiency. So the answer is osteomalacia. It's the adult equivalent of rickets. All right, Paget's disease of bone, mosaic laminar bone is wrong because the ALP is elevated, but these guys are normal. In Paget, the bone pain is localized, not diffuse. Vitamin D resistant rickets would be in children's. Multiple myeloma, lytic lesions, hypercalcemia. That's wrong because of the low calcium and the lack of the renal dysfunction, the M spike, and the anemia. Primary hyperparathyroidism, classic stones, bones, groans, psychiatric overtones. That would cause hypercalcemia. This is hypocalcemia. All right, there is the mechanism. Now, it's not hypoparathyroidism because that would show low PTH and low calcium. But here we have high PTH. It's working, we just can't do anything because of that vitamin D deficiency, so we can't get enough calcium. That's why we're increasing the PTH. It's not metastatic breast cancer. That causes hypercalcemia, not hypocalcemia. It's not primary because primary would have increased calcium and increased parathyroid hormone. And it's not osteoporosis because that will usually show normal labs. It's usually asymptomatic until they have some sort of a fracture. So vitamin D deficiency means you have defective mineralization of the osteoid. Low vitamin D means low calcium and phosphate triggering compensatory PTH, which worsens phosphate loss and tries to maintain calcium by breaking down the bone. But without enough vitamin D, the bones cannot mineralize well enough, leading to pain, fractures, muscle weakness. Now, vitamin D does not create calcium. It does help your body absorb it from the gut. So without it, you eat the calcium, but it passes right through. With vitamin D, it induces expression of the calcium-binding proteins. And if you're deficient, you can't absorb the calcium at all. Right? Your blood calcium will drop in the parathyroid. Glands are going to freak out and be like, oh my gosh, secondary hyperparathyroidism time. Let's try to save this patient. All right, and that's that question. In this next question, we have a 43-year-old woman brought to the emergency department after being found unconscious in her apartment. On exam, she's hypotensive and unresponsive. Okay, this could be a man as well. T shows a large adrenal hemorrhage after stabilization. Her serum cortisol is undetectable. Okay, so here's our patient demographic for this question. ACTH is markedly elevated. Which of the following cells is most likely responsible for increased hormone and driving her cortisol? All right. So everybody knows that the answer here has something to do with ACTH. We know that. Now, what we don't know and what's hard to learn is that the anterior pituitary is where the CRH stimulates ACTH, adrenocorticotropic hormone, and ACTH is secreted by the basophils, specifically the corticotrophs, and it's derived from POMC, and you will see this in the NBMEs. And the adrenal cortex, the zona fasciculata, is where ACTH stimulates the cortisol production. So to answer this question, we have to know a couple of things. We got to know basophils in the anterior pituitary include corticotrophs, thyrotrophs, and gonadotrophs. So cortico would be like ACTH, thyrotrophs would be like TSH, gonadotrophs would be LH and FSH. That's the anterior pituitary. You can think of it like the base that you build off of, so basophils. You could also think of B flat, right? B flat, because FSH, LH, ACTH, TSH, B flat. And so our answer is basophil of the anterior pituitary because the ACTH is elevated, and that is because of the corticotroph stimulation. So primary adrenal insufficiency due to the this leads to unregulated ACTH secretion from the pituitary basophils. Follicular of the thyroid makes thyroid hormone in response to TSH. Chromaffin cells releases epinephrine, norepinephrine. Parvocellular neuron of the hypothalamus produces CRH. It's upstream, but it's not the source of ACTH. Acetophil of the anterior pituitary makes the growth hormones, not B flat. So as I mentioned before, ACTH comes from the adrenal medulla. It's produced in the anterior pituitary by the basophils, specifically the corticotrophs. They respond to CRH. They cleave the POMC into ACTH, MSH, and beta endorphin. Now, just to be super clear, the acetophils, those stain pink. You should think of prolactin and growth hormone. And the way to remember those would be PIG. Prolactin, growth hormone. Think of a really toxic, a really acidic pig. Basophils, you remember B flat. FSH, LH, ACTH, TSH. All right, just to do a quick quiz for you. What's growth hormone? Acetophil. What's TSH? Basophil. What's prolactin? Acetophil. ACTH, LH, basophils. You got it. All right, in our next question, we have a 55-year-old man, but could also be a female, as denoted in my demographic photo right here. So this man presents with acute shortness of breath and pleuritic chest pain while climbing stairs. He returned from a 10-hour flight. DVT is now in our minds. History of hypertension. Wow, yep. Tachypnic, oxygen sat of 88, x-ray normal. Ventilation perfusion, scanner reveals perfusion defect of the right lower lobe, which vessel provides collateral oxygenation. Oxygenated blood to the lung parenchyma. All right, I've updated the patient demographic so you can see what this guy looks like. That's how he presents. Now, what is the answer? Okay, so they can present this a couple of ways. They'll say this person has a lot of chest pain, the cough, they're a smoker. If it's maybe they'll say it's a female taking oral contraceptives. That's like an increased embolic risk. You might see subsinus tachycardia on the ECG and a pulmonary embolism. What's interesting about that is that you actually have a normal chest x-ray, and the scan is going to show a perfusion defect in the right upper lobe. And now that's all well and good. We know it's a pulmonary embolism, easy. But they're asking which artery provides collateral blood flow to that spot. So you have to know the blood supply of the lungs. I think it's worth talking about the lungs for a sec and pulmonary circulation generally. So here's our heart. This originates from the right ventricle to the pulmonary trunk, and then it divides into the right and the left pulmonary arteries. And that delivers deoxygenated blood to the lungs for gas exchange. But there's also this thing, right? Because that's the pulmonic circulation. It's pretty low pressure. It originates from the right ventricle. There's also this other type, and it's bronchial circulation. So what I've described here, this is what people think of usually, pulmonary circulation. But now I want you to think of bronchial circulation. And that has systemic collateral influence, and that comes from the aorta. So here's our heart. It's like a little boot. Comes from the aorta and the intercostal arteries, and it supplies oxygenated blood to bronchi and the lung parenchyma and the visceral pleura. And that can bypass blocked pulmonary arteries and maintain the perfusion. And on the right side, the right bronchial artery typically comes off of the intercostal artery and it supplies the right lung, and that includes the upper lobe. And so the answer is the right bronchial artery. Bronchial arteries arise from systemic circulation, like the aorta, and cause the oxygenated blood to be actually given to what makes the lungs work. When they're obstructed, bronchial circulation does the collateral stuff. It's not subclavian that feeds the upper extremity and parts of the thorax, not pulmonary trunk that carries deoxygenated blood, not left coronary artery that's for cardiac perfusion, and internal thoracic artery would be mediastinum and the chest wall supply, not used in the lung parenchyma. All right, so there's the explanation. And they're going to try to, confuse you with all sorts of different arteries that they could flow at you. For instance, they might talk about the brachiocephalic. That supplies the head, the neck, and the right arm, brachiocephalic, not the lungs, though. They might say, is the left pulmonary artery? Well, that supplies the left lung, not the right side. So if they're asking about the left, maybe, but that's not the right answer. The internal thoracic supplies the anterior chest wall and the sternum, not the lungs. And the right coronary supplies the heart. So the way to think about this is you have pulmonary arteries. Those are deoxygenated blood into the alveoli. And then the bronchial arteries, the systemic oxygenated blood to the bronchi, visceral pleura, and the supporting lung tissues. So the pulmonary system is for alveoli. Bronchial is for the pleura, the parenchyma, and it does more collateral stuff. In this question, we have a 29-year-old woman presenting with palpitations, excessive sweating, and anxiety after delivering a baby. She had unintentional weight loss despite a normal appetite. She denies neck pain or tenderness. 98.2, heart rate 105, BP 122/82. Her thyroid is symmetrically enlarged but non-tender. Free T4 is high. TSH, that's low. 24-hour radioiodine uptake is super high, and the anti-thyroid peroxidase antibody is positive. What's the cause? All right, now this one is kind of hard to see sometimes on test day, but there's going to be somebody who recently had a baby and they're feeling nervous, tremulous, they have some weight loss. There's basically thyroid symptoms. They have a firm, non-tender, enlarged thyroid, and there's low TSH and high or normal free T4. There's usually low radioactive iodine uptake. But what happens is you actually release that thyroid hormone from the thyroid gland in what is actually a form of subacute lymphocytic thyroiditis called postpartum thyroiditis. And this is seen within 1 year postpartum. And the pathophys is kind of crazy. Basically, there's a lymphocytic infiltration of the thyroid gland, and then it destroys the follicles, just absolutely wrecks them. And that releases, obviously, preformed T3 and T4. So now you have transients like, oh my gosh, we have all this T4, but then it's followed by a hypothyroid phase because it's not going to last forever. And then the gland is not making new hormone, and so there's not going to be iodine uptake needed. So it's postpartum thyroiditis. Autoimmune stimulation would be Graves. Iodine-induced synthesis, think amiodarone, not postpartum. Thyroid adenoma, hot nodules have focal increased uptake, not diffuse low uptake. TSH secreting, high TSH, high T4 would be seen. If there's low uptake, it's a hormone leak. High uptake, hormone overproduction. Now, this is self-limited, painless thyroiditis that's seen in up to like 1 year after delivery. Transient hyperthyroid to hypothyroid to euthyroid. That's the life cycle of it. You have low reactive iodine uptake. And you might be wondering, okay, well, why is there low uptake? Well, that level that we've been talking about, the radioactive iodine uptake, that measures how much iodine the thyroid actively takes up. And it's used to distinguish between types of hyperparathyroidism. So uptake, the thyroid is overactive, it makes too much of the hormone, and that's if it's increased. But if the uptake is decreased, then the thyroid is damaged. That's pretty much all there is to say about that. Leaky gland means low uptake. All right, here we have a 24-year-old woman presenting with a 10-day history of mild itchy rash for the first time. She first noticed the single large salmon-colored patch in her upper thigh. A few days later, she has small lesions on her trunk and upper arms. The new lesions are oval, slightly raised, and follow the natural skin lines of her back. She denies fever, chills. She takes oral contraceptive and is otherwise healthy. What's the correct answer? All right, so it starts with a single oval patch on the abdomen. That is known as Harold's patch and spreads over the trunk and the back. There's no systemic symptoms, right? There's no fever or chills or sweats. She's sexually active, but she's healthy otherwise. And the image has multiple of those oval, scaly kind of looking lesions. Well, if you know the Harold patch and it's followed by that Christmas tree pattern, there's a rash. That's the classic presentation for pityriasis rosea. Usually have like the oval, scaly plaques and the Langer's lines, which is like the skin tension lines on the trunk. It's usually viral triggered and self-limited, and it's common in young adults. So the answer is B. The initial Harold patch followed by oval lesions in the Christmas tree pattern along the Langer's lines. Tinea corporis would have annular lesions with central clearing, so that kind of like ring shape, but it would not spread in symmetric trunk pattern, and you would need antifungals for this. Secondary syphilis would be on the palms and soles. Psoriasis vulgaris would be silvery scale, and that's usually seen on the elbows and the knees. Starts with that solitary oval salmon-colored lesion that shows up first on the thigh or the trunk, and then you get plaques that kind of look like kind of like those like Christmas wreaths on the back of the abdomen. And there's no systemic signs, usually just goes away on its own. All right, that's that question. By the way, if you're finding this helpful, please consider liking and subscribing. It really makes a big difference for the channel. Also, we just launched ivmed.net, the beta, so go ahead and check that out. And if you want to tutor, just visit Ivy Tutoring. There you'll be able to get access to one-on-one tutoring with a Harvard graduate like myself. It's a good way to guarantee that you pass step 1. All right, so in this question, we have a 42-year-old man, could be a female as well, presents to the emergency department with severe upper abdominal pain that began suddenly 2 days ago. He describes the pain as sharp, constant, and radiating to the back. Ooh, what's that? While you think I've just updated the patient demographics, you can actually visualize this exact patient in addition to another demographic. But this should be making you think of acute pancreatitis. Constant, it's the sharp, constant radiating to the back kind of thing. Nausea, vomited twice since the onset. He drinks approximately 8 to 10 beers daily and has done so for a long time. He feels ill. He's got a fever. Abdomen is distended. He's got some discoloration because of bruising below his skin, noted around the umbilicus. Look at that lipase level. Holy cow, that's acute pancreatitis. That's your cue. You also have low calcium. It's got acute pancreatitis written all over it, honestly. Now, why is this acute pancreatitis? Why were we like, oh my gosh, this is obvious? It's because there's a triad of symptoms. And the first one is epigastric pain that radiates to the back. Let me move this guy so you can see my notes here. Gastric pain that radiates to the back. That's the first thing. You also have nausea or vomiting for the second thing. And the third thing is a history of gallstone or alcohol use. And the specific physical sign is the Gray-Turner sign. That's the ecchymosis of the flanks. And that's because of the retroperitoneal hemorrhaging. And that suggests the hemorrhaging pancreatitis. So gallstones, obesity, diabetes, and actually female is going to be another risk factor as well. But a huge dead giveaway, if they're super nice to you, super crazy nice, then they're also going to show you the elevated amylase and lipase, especially lipase. As you can see in this question that I made for you guys, look at this lipase level. My goodness, have you ever seen a lipase level that high? Acute pancreatitis. All right, so here are the trap answers. Perforated peptic ulcer. That would cause free air to be in the diaphragm, but you don't have any mention of that. Ischemic colitis would be elderly, bloody diarrhea, watershed areas. Alcoholic hepatitis would be AST greater than ALT, and the transaminases are mild. Those are alcoholic. And cholecystitis, that's right upper quadrant pain, and this is actually important to know, so I'm going to write this down. For cholecystitis, you should think of right upper quadrant pain, Murphy's sign as well, and gallstones. And I want to get into this in a second, but just before I do, I want to explain about the pancreas. Looks like this, I know, beautiful drawing, right? But in acute pancreatitis, you have autodigestion of the pancreas by pancreatic enzymes. And that causes, there's this mnemonic that you have to know, get smashed. And G is gallstones, E is ethanol, T is trauma, S is steroids, M is mumps, A is autoimmune, S is scorpion, H is hypercalcemia and also hypertriglyceridemia, E is ERCP, and D stands for drugs. And the drugs there could be like azathioprine, furosemide, thiazides, valproate, that kind of thing. Now, it's important to know that this is not Charcot's triad or acute cholangitis. That's the right upper quadrant pain, the fever, the jaundice, because in that, there's no back pain, or there's also no Gray-Turner sign. And it's not a rupture of the AAA, because that would be in older males with shock and a pulsatile mass. They're typically not going to give you a woman for this, in my experience. It's not a ruptured ectopic thing. That'd have vaginal bleeding. And some signs to look out for, literal signs are like colon sign. That's in hemorrhagic pancreatitis. And the big thing to look out for is lipase. They love asking about lipase with acute pancreatitis. That's number one. And then the number one cause of acute pancreatitis is the G in the get smashed. It's the gallstones. And the complications there are pseudocyst, necrosis, hemorrhaging, ARDS, and hypocalcemia. So look out for those gallstones, alcohol, Gray-Turner. And the Gray-Turner sign, by the way, is that bluish discoloration, the ecchymosis of the flanks due to the retroperitoneal hemorrhaging. And that usually happens like 24, 48 hours after the bleeding begins. That's Gray-Turner's. The colon sign is also seen in the hemorrhagic pancreatitis. There's also this thing that's not tested, but like it's called the Fox sign, which is pretty cool. That's like really severe pancreatitis. And that's like located in like the upper thigh inguinal ligament area. But I promised that I would go back to this cholecystitis because it's super important. The cholecystitis versus pancreatitis. So acute cholecystitis would have right upper quadrant pain, whereas acute pancreatitis would have epigastric pain to the back. This guy would be seen with Murphy's sign, and that's like the inspiratory arrest on the right upper quadrant palpation, whereas we talked about the other signs for acute pancreatitis like Gray-Turner, colon sign. And the triggers are going to be gallstones for both. But acute pancreatitis also likes alcohol in the question stems. And usually for cholecystitis, you look at the lipase levels and they're normal. And that's why I made a big deal out of this lipase level. Because in acute pancreatitis, the lipase is elevated every single time. And usually you'll see some sort of a gallstone with this one whenever you do imaging on cholecystitis. And on pancreatitis, you have a CT scan, you see a swollen pancreas, and you might see some pseudocysts or something like that. And the treatment for cholecystitis is a cholecystectomy, but the treatment for acute pancreatitis would be like IV fluids, pain control, that kind of stuff. Also, MPO, nil per Oz, nothing by the mouth treatment for acute pancreatitis. So, rapid quiz, the 2 signs that suggest retroperitoneal hemorrhaging in pancreatitis, what are they? Colon sign, the umbilicus, and then the gray Turner sign, which is the flanks. What's the test of choice for diagnosing cholecystitis? Right upper quadrant ultrasound. Right upper quadrant, remember, very different than pancreatitis. What test is used if right upper quadrant ultrasound is equivocal, but you still have a suspicion for it? You do a HIDA scan, at nuclear medicine, which is involved in nuclear medicine. All right, I think we explained that pretty well. If you found this helpful, please consider liking and subscribing. Visit the new website. Just doing this to be as helpful as possible. It'd be great if you could spread awareness of this channel. We'll see you guys in the next video. Hello, everybody. Welcome back. We only have 20 questions and more to go, so get that popcorn popping, and let's learn the most important content you will need to know by the time you take step 1. For our first question, we have a 29-year-old woman presenting to the gynecology clinic for evaluation of primary infertility. As part of her workup, she undergoes a fluoroscopic procedure involving contrast ejection into the cervix to assess the uterine and tubal architecture. Imaging reveals symmetric opacification of the uterine cavity, bilateral narrow linear structures extending laterally. In contrast, materials seen diffusely in the pelvis beyond the tubes. She reports no discomfort. What's the interpretation of her finding? So she is taking a hysterosalpingogram, and it looks like it's showing that there are patent tubes, which is a normal finding. And so the answer is normal finding indicating tubal patency. All right, so the way to think about this is the fallopian tubes are the only direct passage between the inside of the reproductive tract and the open abdominal cavity. Contrast in the peritoneum does not indicate that there is a leak. It only means that the tubes are open. And if they're open, that means they are working. That's how God made them. And it's very common for you to think, oh man, the contrast in the peritoneum, that means there's a rupture. But a rupture would show irregular outlines and also really chaotic extravasation. And also you would be presenting with pain and bleeding. That's not the case here. So in a hysterosalpingogram, or HSG, you have contrast injected into the cervix to evaluate the uterine cavity and the fallopian tube patency. And a normal finding is smooth contour, linear filling of bilateral fallopian tubes, and there should be free contrast spillage into the peritoneal cavity. That would be normal for the fallopian tube. All right, moving on to the next question. All right, for this one, we're going to talk about cholecystokinin, CCK. It's released in response to fatty acids in the duodenum. So it stimulates that pancreatic enzyme secretion, gallbladder contraction, and bile release. Here's our question. An investigator studying a gastrointestinal hormone secretion in response to different macronutrients. On trial, a mixture rich in long fatty acids is delivered. What is observed? The answer, increased cholecystokinin. Fatty acids stimulate CCK release from eye cells. They also might ask you about the sphincter of OD relaxation to digest the fats. So the small intestine actually has hormone sensing cells, and they detect whenever they see fat, and they send chemical instructions to the pancreas and the gallbladder. Increased GIP would stimulate insulin. VIP is for secretory diarrhea. Motilin would be inhibited by food intake. Those are related to fasting and migration motor complexes, so fasting states for motilin. Suppressed gastrin, that would mildly occur with fatty acids, but it's not the main mechanism at play for fatty acids in the duodenum stimulating those CCK. That's CCK release. The goal is to maximize lipid digestion. All right, in our next question, a 24-year-old graduate student is enrolled in neuroscience research examining the neural effects of psychoactive drugs. During the study, she receives a dose of stimulant compound and her brain activity is monitored via functional MRI. The imaging shows increased activity in the nucleus accumbens, prefrontal cortex, and VTA. These findings most likely reflect increased neurotransmission in which pathway? So we have noradrenergic, serotonergic, dopaminergic, cholinergic, and GABA. This is a dopamine pathway in the VTA, and they could make it more difficult and ask which of the dopamine pathways is it. And if they ask that, it's important to know the mesocortical and the mesolimbic dopaminergic pathways are the key circuits underlying drug reinforcement and addiction. And the VTA, ventral tegmental area, projects dopamine to the nucleus accumbens, the mesolimbic pathway. And the nucleus accumbens then projects to the prefrontal cortex, and that's through the mesocortical pathway. So that's the pathway. And that mesocortical pathway to the prefrontal cortex mediates the conscious experience of pleasure and craving and compulsory nature, drug seeking, that kind of stuff. And virtually all drugs of abuse, so cocaine, amphetamines, opioids, nicotine, alcohol, and sedative hypnotics, increase dopamine release somehow in those pathways. Now let's look at why these answers are wrong. Noradrenergic would be associated with arousal, memory, and encoding. Serotonin is mood regulation. It's dysregulated in depression. Cholinergic would be prefrontal cortex associated, attention and learning. GABA is associated with the caudate nucleus, motor inhibition. So once again, it's that VTA that sends the dopamine-rich projections to the nucleus accumbens. That's the pleasure hub. And then it loops in with the prefrontal cortex. So in this student, they're increasing the activation of the nucleus accumbens, the VTA, the prefrontal cortex, and that is why she is feeling that dopamine rush. Now you might ask, why is not an endorphin? Well, endorphins are actually not for step one going to be recognized as reinforcement pathways. Endogenous opioids can modulate dopamine, but they do not directly go through those pathways. The noradrenergic, the norepinephrine through the locus coeruleus, increases alertness and arousal. All right, in our next question, we have, could be a man or a woman, but in this case, it's a 59-year-old woman with a history of hyperlipidemia and diabetes, presents to the ED with crushing substernal chest pain radiating to her left arm. She reports increasing frequency of similar episodes in the past, ST depressions in leads 4 to 6. Which the following substance is most likely prevented from binding? Troponin 1 is elevated. She's administered aspirin, clopidogrel, nitroglycerin, and heparin, and an IV medication that inhibits the final step of aggregation. So if it's aggregation, it's going to be fibrinogen, and our answer is indeed C. And for this one, we have to know our GPs. GP2B3A on activated platelets is the final common pathway for aggregation because its extracellular domain binds fibrinogen, which cross-links the adjacent platelets. And so abiximab will block the GP2B3A and prevent fibrinogen binding, and it also will halt the propagation of the thrombus. ADP to P2Y12 would be platelet activation and upregulation. That is blocked by clopidogrel, not by abiximab. Adenosine, increased CAMP, it'd be anti-aggregatory. And serotonin is released from dense granules. A way to think about this is von Willebrand factor binds GP1B for adhesion, and fibrinogen binds GP2B3A for aggregation. And abiximab is going to block this latter pathway. Fibrinogen allows platelet cross-linking and aggregation. Unstable angina and NSTEMI is what this patient was suffering from, and so they gave abiximab to block that interaction and halt the thrombus growth. Granted is adhesion, thromboxane A2 is vasoconstriction and platelet activation, but it's upstream. Serotonin is released from the granules, and ADP stimulates platelet activation. So it promotes that expression, but it does not bind it. So it's the final step in that platelet aggregation pathway is the protein GP2B3A. Next, we have a 6-month-old boy brought to the clinic due to persistent cough, otitis media, and several episodes of pneumonia since he stopped breastfeeding. His birth history is unremarkable. He has no palpable lymph nodes or tonsils. Cytometry shows absence of IgM. Well, it's not going to be hyper-IgM syndrome then. It's going to be X-linked agammaglobulinemia. Flow cytometry shows some normal CD3 T cells and absent or near absent IgMs. Those are B cells, and that would be the classic failure for B cell maturation. And it's these infections that begin after 6 months. And why is it after 6 months? Because that's when the IgG will start to wane from the mother. And the etiology is BTK, Bruton's tyrosine kinase mutation. It's X-linked, and it blocks the pre-B to immature B development. And so you have a very low B cell count and pan-hypogammaglobulinemia. So that would be low IgG, low IgA, low IgM, low IgE. You'll have small or absent tonsils and lymph nodes. And though almost every single time are going to try to make you think that it's something else like SCID, but that would be decreased T cells and B cells. It would have basically a low CD3 positive count as well. And also opportunistic infections would be present. Hyper IgM would have normal B numbers with high IgM, hence the name. Selective IgA deficiency would have normal B and T cell numbers. Only the IgA would be low. And MPO deficiency would be neutrophil killing defect, and the lymphocyte phenotype would be normal. Okay, for this next one, I just wanted to speak very briefly because it's kind of easy. It's just acne in athletes and military trainees. It can be due to friction. You can treat it with retinoids, which decrease the keratinization, benzoyl peroxide, or antibiotics. Here's some myths about acne. And they might say, hey, we have a 17-year-old male who has eruption on his back and shoulders after he's wearing pads during practice. What is the contributing factor? It's mechanical irritation from sports equipment. Acne can be caused by the follicular occlusion, increased sebum production, and then the bacteria gets trapped there. And that's what's happening. It's not the fatty food. And it's not a fungal infection like malassezia, because that would not have the comedones. So yep, you're wearing a helmet, you're playing football, watch out for this. In our next question, we have a 24-year-old woman presenting with concerns about increased facial hair and difficulty losing weight. You should already be thinking of some PCOS, coarse hair on the jawline, and indeed it is polycystic ovarian syndrome. Super easy diagnosis: oligomenorrhea, hirsutism, obesity, elevated LH and FSH ratio, no signs of virilization or Cushingoid features. but they do have that kind of facial hair growth just a tiny bit. They're the trap answers and why they're wrong, but watch out for irregular menses. And also this is due to obesity, which increases the risk of insulin resistance. And you have polycystic ovaries on ultrasound. Androgen secreting ovarian tumor is wrong because they don't have clitoromegaly or deepening voice, and testosterone is elevated but not dramatically high. Cushing syndrome, that presents with the striae, moon facies, and the buffalo hump, but you don't see those signs. She lacks central obesity and proximal muscle weakness. Idiopathic hirsutism, it's not idiopathic because the cycles were abnormal. Primary hypothyroidism, fatigue, and weight gain and bradycardia and cold intolerance would be seen. And this is actually super common, about 10% of reproductive age women. All right, there are the buzzwords. All right, here's another relatively easy one. A 28-year-old man comes to the emergency department. Look at that, pressure 196. I would immediately start thinking of pheochromocytoma. And so the next step would be start phenoxybenzamine before surgery. Could be a male or a female, as you can see here. Here's an example of a patient. You give alpha adrenergic blockade with phenoxybenzamine. It's non-selective irreversible to prevent the hypertensive crisis. And so there's a triad here. It's paroxysmal headaches, palpitations, and refractory hypertension. If you're put on a beta blocker like metoprolol without an alpha blockade, they're not going to actually worsen the crisis because you get unopposed alpha adrenergic vasoconstriction. This comes from the chromaffin cells, the neural crest cells, and the adrenal medulla. And you should do a 24-hour urine catecholamine metanephrine screen because the metanephrines are going to remain elevated between the attacks. And on pre-op, you have to do, it's imperative that you do an alpha blocker first, like phenoxybenzamine or doxazosine, and then the beta blocker so you can expand the volume with the fluids. And for the genetics, you should think of men, 2A, 2B, the RET, von Hippel-Lindau or NF1 screen in young patients. So it's episodic catecholamine surges, and you diagnose them with metanephrines, and you have to treat the alpha before the beta, and then you do surgical resection. So you can't give propanolol first or labetalol, even though that has mixed alpha and beta activity. Definitely you cannot observe somebody's pheochromes. Well, you just want to watch somebody die? So the answer is not E. For the next question, we have a 32-year-old man, could also be a female here, blood pressure 168 over 106. We got a high-pitched bruit in the left upper quadrant, plasma's renin at 200 on the left and then 12 on the right. We can see some narrowing of the left renal artery. The vasoconstrictor responsible for this is produced where? The answer, pulmonary endothelial cells. And the reason why is because angiotensin 1 is converted to angiotensin 2 by the ACE located at the pulmonary vascular endothelium. And this condition is known as renovascular hypertension from the right renal artery stenosis, like an abdominal bruit. And so what happens is you have decreased renal perfusion, and that causes the juxtaglomerular cells to then release renin. That converts angiotensinogen into angiotensin 1. Then angiotensin converting enzyme, ACE, in the pulmonary endothelium converts angiotensin 1 into angiotensin 2. That's a potent vasoconstrictor that raises blood pressure. And so the vasoconstrictor emerges from the pulmonary vasculature. And so the answer is D. Renal macula densa would be detecting the tubular sodium chloride and signals the cells but does not make angiotensin. Adrenal zona fasciculata, for that you should think of cortisol. Glomerular basement membrane is involved in filtration, and the hepatic sinusoidal endothelium would be angiotensinogen. And so angiotensin 2 is the systemic vasoconstrictor that increases the systemic vascular resistance and preferential efferent arterial constriction. It maintains the GFR. So for therapy here, you do revascularization, angioplasty or a stent. For fibromuscular dysplasia or critical stenosis, you give like an ARB or an ACE inhibitor as well in unilateral disease, but that could also precipitate acute renal injury and bilateral renal arterial stenosis by dropping that efferent tone. All right, for this one, we have a 65-year-old woman with poorly controlled hypertension started on a new medication. 2 weeks later, she reports new onset ankle swelling and occasional headache. Her pressure has decreased from 168 to 130. We have some pitting edema, though, which mechanism explains the hypertensive effect of this drug. Okay, the answer is going to be the decreased arterial resistance, but we have to know the drug, dihydropyridine, calcium channel blockers, act primarily on the vascular smooth muscle. Examples of this would be like amlodipine, and they block the L-type calcium channels in the vascular smooth muscle, and that causes arterial vasodilation, which then decreases the SVR, which is the afterload, and decreases the blood pressure. And it has minimal effect on the heart rate and the contractility, unlike non-dihydropyridines like diltiazem. And these dihydropyridine calcium blockers are first-line antihypertensives, especially in Black patients and those with isolated systolic hypertension, so the elderly. And common side effects can be peripheral edema. And the way that I like to remember that is you think of these as legs, and then you think of this as the edema because it's the L-type. Peripheral edema from arterial dilation, which then increases the capillary hydrostatic pressure. It's not increased capacitance of the venous vessels. Nitrates would work there, not calcium blockers. That'd be venodilation. B, decreased cardiac contractility. That'd be seen with verapamil and diltiazem, not dihydropyridines. Suppression of sympathetic outflow would be a central alpha agonist, like clonidine. And reduction of intravascular volume would be natriuresis, thiazides, and loop diuretics. Now, 50 million Americans are treated for high blood pressure, and this is the drug that only targets the blood vessels, not the heart. Dihydropyridine calcium blockers, like amlodipine, nifedipine. Heart rate is affected by beta-1 adrenergic antagonists, like metoprolol and propranolol. The blood volume can be affected by diuretics. The veins affected by nitrates. But CCBs are antihypertensives that inhibit the calcium influx, and that causes vasodilation and decreased arterial resistance. All right, this one is super simple, so we'll go quickly. An 8-year-old girl is admitted after prolonged exposure to chemical fire in a factory near her home. She develops worsening dyspnea, hypoxia, diffuse bilateral infiltrates on chest x-ray. A novel agent is designed to mitigate the inflammatory cascade. What is it? The answer is interleukin 10. Interleukin 10 is the anti-inflammatory one. And ARDS is a diffuse inflammatory lung injury where you have increased capillary permeability and protein-rich edema, and you have decreased compliance and a VQ mismatch. And that damage is driven by the pro-inflammatory cytokines like TNF-alpha, IL-1, and the neutrophils, recruitment and activation, and also NF-kappa B-mediated gene programs. So IL-10 is anti-inflammatory, and so it helps with ARDS. It inhibits the activated macrophages. It decreases the MHC2 expression, and also Th1 cytokines will be decreased by IL-10. And examples of those would be like IL-2 or interferon gamma. And so it dampens the inflammatory cascade, lowers IL-2, lowers interferon gamma. Now, IL-6 is a acute phase reactant. Interferon gamma is a macrophage activator, so it kind of does the opposite here. GM-CSF would be a granulocyte booster, and leukotriene B4 is involved in chemotaxis. For our next question, we have a 52-year-old woman presenting with 8 months of worsening shortness of breath and a dry cough. She has a 15-year history of Raynaud's phenomenon. High resolution shows bilateral basilar reticulations and honeycombing. Which of the following is most likely the cause of the patient's symptoms? All right, so this is pulmonary involvement in scleroderma. This person has systemic sclerosis, scleroderma. And we know this because they have Raynaud's. That's when the hands turn really white in the cold. And also diffuse skin thickening of the face, the neck, the shoulders, the arms, the fingers. And there's also esophageal reflux and dysmotility, joint stiffness, and progressive dyspnea and a dry cough. And you have dermal collagen deposition. And so the answer to this question, which of the following is most likely the cause, is going to be interstitial lung fibrosis. Because of that diffuse sclerosis, the interstitial lung is the complication. The honeycombing supports pulmonary fibrosis. Answers and why they're wrong. Cryptogenic has subacute flu-like symptoms and patchy alveolar infiltrates. That's not going to be scleroderma. Pulmonary embolism, that'd be super acute, not gradual fibrosis. Chronic bronchitis would have a productive cough. And small cells is a paraneoplastic syndrome, and there's no smoking history here. So pulmonary fibrosis is super serious. It's one of the leading causes of death in patients with systemic sclerosis. So they have skin tightening, Raynaud's, GERD, and a dry cough, scleroderma. It's fibrosis of the alveolar septa, and reticulations and honeycombing will really help you lock in that answer. And this can progress to pulmonary arterial hypertension from the vascular remodeling, but the primary parenchymal process is definitely going to be fibrosis. Now, there's some other answers as well. Like they could have given you emphysema or something that's obstructive caused by smoking. Also, you could see alpha-1 antitrypsin, not fibrosis. They could also try to get you with granulomatous inflammation like sarcoid, tuberculosis, A or GPA, not scleroderma though. Lung cancers like PNA or PE would not match that chronic course. And then bronchiectasis has a bunch of recurrence infections, cystic fibrosis, cartagenars, that kind of stuff. All right, the next question, we have a 62-year-old man, history of chronic tobacco use, presenting with progressive headaches. MRI shows heterogeneously enhancing lesions on the right parietal lobe with surrounding edema. Biopsy shows malignant cells with high nucleus to cytoplasmic ratio. Immunohistochemistry shows positivity of cytokeratin. Very important there. And so what is it going to be then? Well, cytokeratin, and so it's probably going to be epithelial cell. And that probably would suggest a metastatic carcinoma as well. But cytokeratins are the intermediate filaments of the epithelial origin. And the brain mass whose tumor cells stain positive for cytokeratin most likely would be like a metastatic carcinoma. Epithelial would not primarily be like a glial or a neuronal tumor. And so there's some markers that you have to know that I'll write down. Some of the most important markers are for epithelial, astrocytes, mesenchyme, muscle, and also the neurons. So epithelial would be cytokeratin, astrocytes is GFAP, mesenchyme would be vimentin, muscle is desmin, and the neurons would be neurofilament. So epithelial is cytokeratin. So you think of desmin, he's like a really strong guy. Think of your own thing for GFAP. Epithelial, I like to think of that like the keratinization. neuro with neurons, and it makes it pretty simple to memorize that. So cytokeratin positivity means epithelial derivation. And so if it's a brain mass or something like that, it might be a metastatic carcinoma from the epithelial origin. And that's why the answer is epithelial, even though it's in the brain. So epithelial would be metastatic to the brain. And it's all because of how that's stained, cytokeratin. Smooth muscle would be desmin with the muscle origins. Astrocyte would be GFAP. Endothelial cell is CD31-34. And a neurofilament. So really, it's just a one-to-one matching game. And it's cytokeratin positivity in this particular question. In our next question, we have a 59-year-old man with a history of mantle cell lymphoma beginning his first cycle of anti-CD20 monoclonal antibody therapy. 30 minutes into the infusion, he develops rigors, diffuse muscle aches, and a fever. His blood pressure and respiratory rate are stable. He has no rash, wheezing, or facial swelling. What is the most likely cause of the symptoms? Well, we got a fever. We got muscle aches after an infusion. So it's going to be a cytokine storm. Okay, so there is our nice man. I actually think I'm going to generate somebody who's like 59 years old. He looks very young. And this is actually something you really have to look out for in minutes to hours, because nearly half of the patients receiving their first rituximab infusion will experience some sort of a reaction, cytokine release syndrome, driven by the B cells. And we know rituximab binds to the CD20 on the B cells, and that triggers their activation. And when they break down, it causes TNF alpha and IL-6, and those guys are troublemakers. They'll cause the fever, chills, muscle pain, but it's not histamine or IgE, and definitely not anaphylaxis. So complement-mediated would be hemoglobinuria and jaundice, mast cell degranulation, urticaria, hives, bronchospasm, IgE activation. Antibody-dependent would be natural killer cells if it's cellular cytotoxicity, if it's cellularly cytotoxic. And serotonin syndrome would cause hyperreflexia and clonus and agitation. All right, so there is the new updated photo for that last question. And now we're already on to a new one. And here we have a 72-year-old woman. This could be a man as well, is undergoing evaluation for persistent fatigue and an unintentional weight loss. Imaging reveals retroperitoneal mass and biopsy shows poorly differentiated cells with high nuclear to cytoplasmic ratios. Immunohistochemistry reveals the tumor cells lack expression of MHC class 1. Flow cytometry of the patient's peripheral blood shows an increased activity of CD56. These lymphocytes are most likely to induce apoptosis of the tumor cells through which mechanism? All right, so the answer for inducing apoptosis is the recognition of cells that lack the MHC1 expression. This is a classic feature of many tumors. And you might say, hey, I've seen FAST and FAST-L that's involved in death. And yes, it's seen in T-cell mediated apoptosis, but not the natural killer cell method. That is a totally different mechanism. Natural killer cells preferentially destroy malignant tumor cells with decreased or absent MHC class 1 expression. That's their whole deal. They're like, you have a passport, you have a passport. Oh, I don't see your MHC class 1 expression, you're dead. That's how it works. IL-2 and interferon gamma secretion, that would be activating the macrophages and T cells, not direct cytotoxicity. And 8086 is the T cell stimulation that's irrelevant to the natural killer cells, which don't have those receptors. And these natural killers are first responders. Basically, you're holding up, every single cell is holding up this thing, the MHC1 that's like, don't kill me. And sometimes these tumor cells, they're being really clever and they just delete that. But then they delete that to avoid detection, but it ends up killing them because the natural killer cells are like, you don't have a passport, and they just attack them. All right, our next topic that we're going to cover is actually going to be an ethics question. You need to make sure you ask open-ended questions and you validate and recognize that emotional states can change, and so you have to check people's understanding. You don't give stats and premature reassurance. All right, so we got a dude, surgical resection. He's like, hey, I finished, but I still feel scared. What should I do now? What do you say? You say, you sound concerned. Can you tell me more about what's worrying you right now? Open-ended is what you need. Can you tell me more? Like, what are you specifically afraid of? That's what you need to be asking in these scenarios. Open-ended questions. If somebody expresses concern, so that you can ask for their understanding, and then you can tailor the discussion according to their gaps and their needs and their concerns. But first you have to ask. By the way, we just launched Ivy Med, which helps you master every major exam. If you want a Harvard tutor who teaches the ACT, SAT, MCAT, USMLE, any of that, then just visit ivytutoring.net. All right, for this one, it's super simple. Burnt sugar odor. That's due to isoleucine metabolism byproducts. You'll see a baby with vomiting, lethargy, hypotonia, 3 to 7 day old infant, onset after feeding starts, branched chain amino acids accumulate. It's an autosomal recessive inheritance, and you get ketoacidosis and cerebral edema because of those elevated branched chain keto acids. There's a deficient enzyme of the branched chain alpha keto acid dehydrogenase complex that causes these guys to build up, the branched chain ones. And leucine is neurotoxic, so it causes encephalopathy and a coma, and it smells like burnt maple syrup. That's all you need to know for this. So we got a young kiddo, poor feeding, irritability. He was healthy, but now he can't. Now he's got a sweet odor, maple syrup. It's a deficiency in what? Branched chain alpha keto acid. Super simple. One of the easiest questions out there. And that's a cute little photo of that neonate there for that question. Here's some other ones on why they're wrong. Ornithine transcarbamylase would be a urea acid defect, hyperammonia, not sweet smelling. Homogeneous oxidase would be alkaptonuria with the dark urine. Cystathione beta synthase will lead to the marfanoid habitus lens dislocation, not in the neonates. All right, next one, we have a 27-year-old man. I guess we can use this guy. There he is. Goes to the clinic after injuring his right middle finger while rock climbing. He slipped. Ouchies. And he has a sudden pop in his finger. He was gripping and he held it. All right, so now what structure is damaged? This is a memorization one. It's the flexor digitorum profundus. And the way that I like to remember this one is the jersey finger. Because if you're ever playing flag football and you get somebody's jersey, like this guy's rock climbing, and he goes, then you are going to be damaging the flexor digitorum profundus. And it's funny because it seems like a small injury, but I'm like, oh, that was a profound injury. It just helps me remember it. Radial nerve supplies the extensors, not the flexors. Flexor digitorum superficialis flexes the pip, not the dip. Pip, not the dip. See the difference? Digitorum superficialis, and this one is the dip. So superficial. The ulnar is involved in digits 4 to 5 and intrinsic hand muscles. Extensor controls the index finger extension, like that. So high yield MSK, flexor digitorum profundus. There it is, jersey finger. Yep. You can't flex the dip joint. And now for our last question. We're almost there, guys. You're one question away from watching Futurama or whatever it is you like to do. Walking your dog, who knows, going and working out. 62-year-old woman presents with progressive left axillary swelling for the past 3 months. She denies fever, night sweats, and weight loss. Physical exam shows 3 centimeters firm non-tender lymph node in the left axilla. Excision biopsy shows preserved nodular architecture with small cleaved cells. And we got CD19, 10, BCL2 positive, and monoclonal kappa light chain restriction, and there is no expression of your T cells, CD5, or CD23. Which of the following abnormalities is most likely characteristic? All right, did you get this one right? Do you know what the answer is? So on questions like this, you have a firm, slowly growing cervical node over like maybe 2 months. It's an indolent course. And they talk about maybe on CDs, on the flow cytometry, they talk about CD19 positivity. What's that? That's a B cell. They might also mention CD10. What's that? That's the germinal center marker. And that's actually a hallmark for something. What is it a hallmark for? That's right. For you guys in the back that said it, good job. That, my friends, is the giveaway. CD10 is the giveaway because follicular lymphoma. A light chain restriction is something you could also mention as well. And on histology, you have the nodular follicular architecture. I wonder why. BCL2 positivity. And that BCL2 positivity is actually from the T14 to 18, the translocation. It's the IGHBCL2 translocation. And there we have it, guys. The answer is C, because this person has follicular lymphoma, 14 follicular lymphoma, BCL2 overexpression. Remember that F sound, 14 follicular. Now 11 to 14, 11, look at all those L's. 1, 1, 1, 1. That's how you know that 1, 1, 1, 1 has all the L's because it's mantle cell. Look, 3 L's in that. There are 3 L's in that and there are 3 1s in this. And that's how you remember mantle is 11 to 14. 814 is a MIG translocation seen in Burkitt's lymphoma. You remember this because it's mixed. You have a kid who's 8 years old and you have like an adolescent. And it's mixed demographic there, Burkitt, which would be a rapidly growing mass. And then the 922, for this one, I like to envision a Philadelphia football player wearing a jersey with 922. And that's CML or BALL, not slow-growing lymphomas. And a deletion would be seen in chronic lymphocytic leukemia. So we have a translocation that hijacks that BCL2 gene and lets them cheat death. They can never die. Which, by the way, I think that humans will get there. I think anti-senescent technology is reaching the point that in my lifetime, there will be some people who are born who won't die for hundreds, if not thousands of years. Wild to think about. That's the importance of getting an education. But yes, I digress. This is follicular lymphoma. It's indolent germinal centers, B-cell lymphoma, CD19 positivity, CD10 positivity, BCL2 positivity, light chain restricted, often is going to be T14-18 translocation. All right, so remember your CD markers. You should be good to go. Congratulations, guys. We did it. Can you believe it? We have finished 200 of these original questions. They're done. If you guys found this helpful, then please share ivmed.net or ivtutoring.net to your friends. We're launching a step 1 prep course, as you can see here. Now, a lot of this is still in beta, but we have our analytics. We have an entire medical library. And the goal is to make this totally free and extremely cheap for you guys as we continue to add more features. But we're making an interactive medical library with question banks, with flashcards integrated into OnKey, can also plug into other things like eWorld. This is going to be amazing. So visit ivmed.net and visit Ivy Tutoring right here, ivytutoring.net. If you'd like a one-on-one tutor, that's a way that you can guarantee that you'll pass step 1. It's one thing to just chance it and just study like crazy, which I encourage you to do. Watch all these videos, pass this silly exam. It is a silly exam. It's just a bunch of factoids. But if you really want to make sure that you pass it like 100%, then just visit ivytutoring.net, fill out the form, and we'll give you a Harvard tutor who's going to make sure that you pass the exam. Guys, you're troopers. Thanks for sticking with it. I love reaching out to you guys, interacting with the community. I want to build like a super positive community here. There's some students who email me, which by the way, email me at blake@ivytutoring.net, and they'll say, hey, I just can't do any more studying for the day. And I'm like, no worries. I got to send out some emails. I got some work calls that I got to make. Why don't we just hop on a Zoom call? You can just sit there on the other side and I'll put a Pomodoro timer on and we can just get through this exam. I really deeply care about you guys and I want to make sure that you're taking care of yourself in this prep time. Dedicated period is like crazy. It's not a psychologically like balanced time and you need to take care of your mental health, your physical health. Make sure you guys are working out. Make sure you're going on runs, taking your dog for a walk. One of the greatest ironies of medicine is that we do too little prepare and prevent and way too much repair and repent. As a future physician, you are sacrificing your mid to late 20s, your early 30s, so that you can help other patients who are suffering. That's very commendable, but don't disregard your health, physical and mental, as you prepare for this test. Remember, if you're struggling, no thought is final. Tomorrow's going to be a new day. You can always reinvent yourself. The only thing we actually have in life is the present. Everything else is either a memory or a best guess about what's going to happen in the future. Reframe those best guesses with cognitive behavioral therapy. Make sure that you self-talk in a way that's positive and try to find a lot of fulfillment as you go through your medical career. Really excited for you guys. Thank you so much for coming along. Thanks for liking and subscribing. If you didn't, thank you for just being out there, for putting in the good work every single day of your life, for helping other people, for showing up today for others and for yourself. Give yourself a pat on the back. And with that, all I'll say is we'll see you in the next video. You guys take care.
For me, it's pretty hard to know. I didn't think you really knew that. I guess it's